Assalamualaikum. Ni Kak Ina dah mute dah. Dah unmute.
Bukan mikrofon. Volume laptop.
Dah 100. 100 lah. Oh, yang tu. Tapi macam tak ada sound. Tadi ada sound, lepas tu tak ada sound. Ini kawan PRO dekat. Hello, Bara.
Hi, Kak. I can hear you.
Hi. Yeah. Okey, ada suara doktor tapi Dr. Hisham Shah tak ada tadi. Sekarang.
No audio yet.
Professionals to be ever inquisitive researchers to keep up with the quick to evolve or to mutate virus. Research is the key enabling healthcare workers to practice evidence-based medicine throughout the years. In healthcare management, both clinical practice and research goes issues. It is not a cookbook with recipes, but it is good, application, bring cost-effective and better healthcare. And one of the greatest achievements of evidence-based medicine has been the development of systematic reviews and meta-analysis, methods by which researchers identify multiple studies on a topic, separate the best ones, and then critically appraise and analyze them to come up with a summary of the best available evidence. Like privacy, health research has high value to society. It can provide important information about disease, trends, and risk factors, outcomes of treatment, or public health interventions, functional abilities, patterns of care, and healthcare costs. Hospital Kuala Lumpur Research Day 2020. Ladies and gentlemen, it is indeed a privilege to be part of this event, which reflects the efforts of everyone, the doctors, nurses, and all the research staff of Hospital Kuala Lumpur involved in clinical research. The theme, Research Today for the Best Healthcare Tomorrow, is very much reflected by the ever-expanding advances in research with parallel progress in the healthcare system worldwide. Research has been and will always play a major role in the evolution of medicine. Keeping in mind the recent catastrophic pandemic, COVID-19 has pushed healthcare professionals to be ever inquisitive researchers to keep up with the quick to evolve or to mutate virus. Research is the key enabling healthcare workers to practice evidence-based medicine throughout the years. In healthcare management, both clinical practice and research goes hand in hand. They are very closely interlinked and mutually reinforcing. The progress and advancements in research are fundamental for a competent and credible clinical practice. New research evidence and discoveries help advance clinical practice and improve patient care, while clinical priorities shape our understanding and it gives context to research emphasis and its direction. Evidence-based medicine is the conscientious, explicit, judicious, and reasonable use of modern best evidence in making decisions about the care of individual patients. It integrates clinical experience and patient values with the best available research information. It is a movement which aims to increase the use of high-quality clinical research in clinical decision-making. Evidence-based medicine requires new skills of the clinicians, including efficient literature searching and the application of formal rules of evidence in evaluating the clinical literature. The practice of evidence-based medicine is a process of lifelong, self-directed, problem-based learning in which caring for one's own patients creates the need for clinically important information about diagnosis, prognosis, therapies, and other clinical health-related issues. It is not a cookbook with recipes, but it is good, but its goods application brings cost-effective and better healthcare. And one of the greatest achievements of evidence-based medicine has been the development of systematic reviews and meta-analysis, methods by which researchers identify multiple studies on a topic, separate the best ones, and then critically appraise and analyze them to come up with a summary of the best available evidence.
and a very good morning to all of you. It is a pleasure to be speaking to you today in conjunction with
Assalamualaikum warahmatullahi wabarakatuh. A good morning to all, ladies and gentlemen. I would like to invite all our guests present physically or online to be prepared and make yourselves comfortable. Our ceremony shall begin shortly. Before that, some housekeeping notes before our program commences. First, kindly mute your PC or laptops to ensure an uninterrupted event. We will regularly announce any updates from time to time, so please be alert. The QR code and Google links will be provided in the chat box for the attendance and feedback form, whereby certificates and CPD points will be obtained upon filling those. Please do leave your comments or questions in the chat box on our Zoom, FB Live, or YouTube. Also, we will leave a link for the Research Day ebook program for your perusal. We shall begin momentarily. Salam sejahtera and good morning, ladies and gentlemen. We are very pleased to welcome you to our first virtual research day of the 5th Hospital Kuala Lumpur Research Day of the year 2022, live from our Clinical Research Centre, CRC HKL. I am Dr. Aina Wahida Muhammad from the CRC HKL team, and I'm very honored to be your Master of Ceremony for today's event. A very warm welcome to Yang Bahagia Datuk Dr. Hisham Shah Muhammad Ibrahim, Deputy Director General of Health, MOH, Yang Berusaha Dr. Fairuz Azlim Muslim, Deputy Director of HKL, Yang Berusaha Dr. Haja Salina Abdul Aziz, Head of our Clinical Research Centre, Hospital Kuala Lumpur, Heads of Departments, ladies and gentlemen, distinguished guests, thank you for your time to join us today. I would now like to invite Mr. Al-Fadil Al-Muyadi Ramli to lead us for the Dua recital.
Bismillahirrahmanirrahim. Alhamdulillahi Rabbil Alamin. Wassalatu wassalamu ala asrafil anbiya'i wal mursalin. Wa ala alihi wa sahbihi ajma'in. Ya Allah, ya Tuhan kami, dengan sifat-sifat keagungan serta kebesaran-Mu pada pagi yang penuh keberkatan ini, bersempena dengan HKL Research Day 2022, kami sekalian hamba-Mu ya Allah merafak dengan penuh rendah diri agar Engkau curahkan nikmat yang berterusan kepada kami. Kurniakanlah petunjuk kepada kami dalam mencapai keredaan-Mu. Ya Allah, jauhkanlah kami dari ujian mara bahaya. Ampunilah dosa kesalahan kami. Kukuhkanlah perpaduan serta murhibah antara kami yang tinggal di dalam sebuah negara yang berbilang kaum ini. Ya Rahman, Ya Rahim. Tanamkanlah sifat-sifat terpuji dalam diri kami agar budaya kerja berkualiti menjadi amalan kami dan supaya kami sentiasa berusaha melakukan penambahbaikan dalam kerja seharian demi kemajuan organisasi, masyarakat, agama dan negara. Engkau sematkanlah ke dalam diri kami ya Allah rasa tanggungjawab atas setiap tugas yang diamanahkan kepada kami untuk dilaksanakan. Ya Zal Jalali wal Ikram. Kurniakanlah apa kiranya kepada kami kesihatan anggota, kecergasan minda, ketenangan jiwa dan kekuatan semangat. Semoga dengannya kami mampu mendepani cabaran, berdaya saing serta mampu mengangkat martabat diri, keluarga, masyarakat, agama dan negara. وصلى الله على سيدنا محمد وعلى آله وصحبه وسلم والحمد لله رب العالمين.
Amin, 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 Ya Rabbal Alameen. Thank you so much, Mr. Mulyadi. We hope our prayers will guide us for a blessed day ahead. Thank you for still staying with us. So now let's begin by lending our ears to some welcoming words from Dr. Haja Salina Abdul Aziz, Head of Clinical Research Center, Hospital Kuala Lumpur.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera. Yang berbahagia Datuk Hisham Shah bin Muhammad Ibrahim, Deputy Director General of Health, Research and Technical Support. Yang berbahagia Datin Paduka Dr. Rohana Johan, Director Hospital Kuala Lumpur. Yang berusaha Dr. Fairuz Azlim, Deputy Director Hospital Kuala Lumpur. Yang berusaha Head of Departments in HKL, Committee Members of Hospital Research Committee, HRRC, Research Coordinator of HKL, Datuk-Datuk, Datin-Datin, doctors, ladies and gentlemen. I would like to extend a warm welcome to all of you. Thank you for attending our 5th HKL Research Day. First of all, I would like to thank Yang Berbahagia Datuk Dr. Hisham Shah for his continuous support of HKL. We are very honored and privileged that you are able to officiate our 5th HKL Research Day today. This is the first time we are hosting our HKL Research Day virtually. We are excited and honored that many of you are able to join us from far and wide. CRC HKL has come a long way since our establishment in 2012. That is physically lah. Before 2012, we were there virtually. It has been a decade since we were first established in HKL. We started with 3 staff, and now we have a family of 20. It is very encouraging to see the extent of our growth. CSC HKL provides many services to help investigators involved with research. Despite the pandemic the past 2 years, we were still able to organize workshops by converting our training workshop to hybrid or virtual mode to cater to a larger audience. Our in-person research consultation clinic were also converted to virtual consult to ensure that CRC was able to attend to increasing demand by investigators who were still very actively conducting research despite the pandemic. Also, since the inception of HRRC by the JPP NIH in 2015, HKL is still one of the most active hospital research review committee in the country. In 2021, HRRC reviewed a total of 122 research. Kudos to the HRRC committee. They have done a great work actually. Our review comes from various clinical and non-clinical departments in HKL, and together their expertise has contributed tremendously in the reviewing process. HKL being a premier hospital and also a premier prime site has helped nurture and instill excellent research culture among clinicians. Investigators in HKL are actively involved in research despite their busy and grueling schedule. As of January 2022, there are 74 ISR alone in HKL. So we are involved quite a lot in ISR. And the active department are oncology, nephrology, dermatology, neurology, psychiatry, and many others. Investigator-initiated research are also increasing in numbers. Last year, a total of 300 researchers were registered in HKL. It is encouraging and heartening to see that despite the heavy workload, clinicians in HKL are still actively conducting research. With that being said, we do still have a lot more work to be done. In terms of promoting the research culture, reaching out and training investigators to conduct high quality and ethical research. But together with everyone's support, I am hopeful that the foundation of our work will remain solid through the future. I would also like to sincerely thank all the speakers, delegates who submitted their research abstract and posters, and participants who took the time to attend this event. Without you, this event would not be possible. Last but not least, a grand thank you and appreciation to the organizing committee members. Those are my 20 staff who have been working tirelessly with their dedication in realizing this HKL Research Day. Well done to you all. I hope all of you today will be able to gain some knowledge and continue to be inspired and motivated to be involved in research. We are I think in 2 days time, we are all going to fast. So I take this opportunity to say selamat menyambut Ramadan kepada semua. Semoga kita mendapat manfaat sebaiknya di bulan yang mulia ini. Dengan itu saya akhiri dengan wabillahi taufik wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh. Thank you.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Dr. Hajah Salina, for your wonderful and inspiring words of wisdom. You shall always be our mentor forever. Now, it is my privilege to call upon our distinguished guest of honor, Yang Bahagia, Datuk Dr. Hisham Shah bin Muhammad Ibrahim, Deputy Director General Health, Research and Technical Support Division of MOH, for the opening ceremony and launching of the 5th HKL Research Day.
Thank you, Master of Ceremony. Yang berbahagia, Datin Paduka Dr. Rohana binti Johan, Director of Hospital Kuala Lumpur. Yang berusaha Dr. Salina Abdul Aziz, Head of Clinical Research Centre, CRC HKL, Heads of Department, Datuk-datuk, datin-datin, ladies and gentlemen. Assalamualaikum warahmatullahi wabarakatuh, and very good morning to all of you. I would like to express my appreciation to the organizing committee for giving me the privilege of officiating the 5th Hospital Kuala Lumpur Research Day 2020. Ladies and gentlemen, it is indeed a privilege to be part of this event, which reflects the efforts of everyone, the doctors, nurses, and all the research staff of Hospital Kuala Lumpur involved in clinical research. The theme, Research Today for the Best Healthcare Tomorrow, is very much reflected by the ever-expanding advances in research with parallel progress in the healthcare system worldwide. Research has been and will always play a major role in the evolution of medicine, keeping in mind the recent catastrophic pandemic. COVID-19 has pushed healthcare professionals to be ever inquisitive researchers to keep up with the quick to evolve or to mutate virus. Research is the key enabling healthcare workers to practice evidence-based medicine throughout the years. In healthcare management, both clinical practice and research goes hand in hand. They are very closely interlinked and mutually reinforcing. The progress and advancements in research are fundamental for a competent and credible clinical practice. New research evidence and discoveries help advance clinical practice and improve patient care, while clinical priorities shape our understanding and it gives context to research emphasis and its direction. Evidence-based medicine is the conscientious, explicit, judicious, and reasonable use of modern best evidence in making decisions about the care of individual patients. It integrates clinical experience and patient values with the best available research information. It is a movement which aims to increase the use of high-quality clinical research in clinical decision-making. Evidence-based medicine requires new skills of the clinicians, including efficient literature searching and the application of formal rules of evidence in evaluating the clinical literature. The practice of evidence-based medicine is a process of lifelong, self-directed, problem-based learning in which caring for one's own patients creates the need for clinically important information about diagnosis, prognosis, therapies, and other clinical health-related issues. It is not a cookbook with recipes, but it is good, but its goods application brings cost-effective and better healthcare. And one of the greatest achievements of evidence-based medicine has been the development of systematic reviews and meta-analysis, methods by which researchers identify multiple studies on a topic, separate the best ones, and then critically appraise and analyze them to come up with a summary of the best available evidence. Like privacy, health research has high value to society. It can provide important information about disease, trends, and risk factors, outcomes of treatment, or public health interventions, functional abilities, patterns of care, and healthcare costs and its use. The different approaches to research provide additional complementary insights. Clinical trials can provide important information about the efficacy and adverse events of medical interventions by controlling the variables that could impact the results of the study. But feedback from real-world clinical experience is also crucial for comparing and improving the use of drugs, vaccines, medical devices, and also diagnostics. And tracking clinical experience with the drug is important for identifying relatively rare adverse events and for determining the effectiveness in different populations or different circumstances. It is also vital to record and assess experience in clinical practice in order to develop guidelines for best practice and to ensure high quality patient care. Another important aspect that is of our particular interest would be the advancement of e-health in the midst of the global pandemic. Electronic health or e-health offers new ways to access health information, to deliver health and social care, and to perform self-management. The adoption of e-health solutions by citizens, patients, health professionals, and healthcare providers has increased substantially during the last decade, particularly in the past few years during the pandemic. In the light of the ongoing COVID-19 pandemic, many countries have experienced a dramatic increase in the use of digital technology to meet their doctor. Ladies and gentlemen, Malaysia is an ideal destination to conduct multiple studies because of various unique features, such as the ethnic diversity of our population, a high incidence of non-communicable diseases, and established and experienced infrastructure with resources and capabilities such as the network of clinical research centers, knowledgeable and GCP certified physicians, available key opinion leaders in various specialties, a well-developed and equipped healthcare system in the public, university, and private sectors, established and mature institutional review boards and ethics committee, as well as a strong regulatory framework. The continuously improving relationship among investigators, sponsors, and various research organizations has helped our nation to reach greater heights in the clinical research ecosystem. This would also be the best opportunity for us to appreciate the efforts and contributions of our patients and all the clinical research volunteers. Each patient who has been recruited into the studies conducted in the country have played a very crucial role in the research process and for the future of tomorrow's healthcare. Ladies and gentlemen, Datuk Datin, Tuan-Tuan dan Puan-Puan, we must always keep in mind that the increasing number of industry-sponsored researchers opens many doors of opportunities to elevate the standards of our own investigator-initiated research. We can't simply focus on one and neglect the other. MOH once again would like to emphasize the importance of improving both the industry-sponsored as well as the investigator-initiated researchers for the betterment of the future of medicine in Malaysia. We also have to play our roles in encouraging more innovative and creative studies to be conducted, allowing new treatment modalities, which in return benefits our patients, despite the stringent and vigorous regulatory processes. It is indeed my pleasure to share that the Ministry of Health is hard at work to implement the electronic medical records system in all of its hospitals in the nearest interval. This will provide a wealth of real-world information, big data that can be used by public health officials, our doctors, and the research community as a whole to assess the myriad of conditions and diseases that affect Malaysians. For example, how many are affected by a certain disease or condition who are at high risk of any of these conditions, and also its many complications. How many patients are affected with a condition that are rare or neglected, and what are the available treatment modalities, and how effective are they in the real world, in the clinical setting in our country. As such, we must not forget the significance of conducting clinical epidemiological studies, as it supports the holistic approach to enhancing Malaysia's standing within the clinical trial sphere. Malaysia has always been up to par in contributing its fair share in research, especially those related to healthcare. And the Ministry of Health is ever ready to lend a helping hand to researchers throughout Malaysia, contributing more in innovative discoveries. I certainly believe that Hospital Kuala Lumpur has led by example in making its presence in the field of clinical research in Malaysia felt, a feat I hope that will continue to flourish for the years coming. I would like to take this opportunity to express gratitude to all parties involved in the field of research, especially the researchers themselves, the sponsors, the volunteers, and the patients participating. It is vital that each party play their role diligently to ensure the healthy expansion of clinical research and the healthcare system. Ladies and gentlemen, Datuk, Datin, Tuan-Tuan, dan Puan-Puan, with the support of the Network of Clinical Research Centers, MOH and CRM Malaysia, together with the continuous efforts of all stakeholders that make up the clinical research ecosystem, including the investigators, sponsors, contract research organizations, academic institutions, and patients, I am certainly confident that Malaysia is fast reaching its goal of gaining a reputation as a world-class clinical research hub within the region. Last but not least, I would like to congratulate the organizing committee chaired by my friend, Dr. Salina Abdul Aziz, head of CRC HKL, for successfully executing this event. My hope that this continues as an annual event, as I believe it provides an engaging platform for the researchers, clinicians, patients, and the industry to share and learn from each other. On that note, I have the pleasure to declare the 5th HKL Research Day 2022 open. Thank you and have a successful event.
Thank you, Yang Bahagia Datuk, for your opening remarks. With this, our 5th Hospital Kuala Lumpur Research Day 2022 has officially been launched. Before we move on, let's entertain ourselves with a short multimedia presentation. Welcome back to our 5th HKL Research Day. Please be kindly prepared for our next session that will begin shortly. I would like to invite Dr. Fazila Sheikh Alauddin as the first speaker for this research day. Before she begins her talk, let me briefly introduce her. Dr. Fazila is presently the Senior Deputy Director of the Planning Division. Prior to this, she has held various leadership roles in MOH and hospitals. She holds an MD from the National University of Malaysia and an MBA in Healthcare Administration from the University of Toledo, Ohio, America. She is professionally certified in enterprise architecture and in governance and management of enterprise IT. A significant portion of her career has been in policy and strategy for health system transformation agenda and project management, mainly hospital information system, HIS. She also leads the nationwide electronic medical record EMR project, the national agenda of lifetime health record, and not to forget her major involvement in our nation's COVID-19 response. With this, Dr. Fazila, we welcome you to the stage.
Thank you. Can you hear me?
Yes, Dr. Fazila.
Okay, great. First of all, I would like to say thank you to CRC HKL for inviting me, and a very good morning and Assalamualaikum to Pengarah HKL, also to Dr. Salina, my very good friend in the research community. Actually, I'm very, like what Dr. Salina mentioned, be inspired, be motivated. And if you see the theme of your research day is for the best of healthcare tomorrow, but you all must understand, tomorrow is already here today. So let's see what's happening in the digital transformation world. Let me share my slide. Can you see the slides?
Yes.
All right, okay. So my topic today is on healthcare in the age of disruption. And as you know, the pandemic has actually pushed digital transformation at a speed that is unimaginable for the last 2 years. A lot of things that we were trying to do for last 10 years, it's just realized in the last 2 years. So it's the healthcare system itself is disrupted, and I think we must all move on with this digital transformation. So today, I will just give you a brief on the policy landscape. I think it's very important, especially as researchers, for you to understand the policy landscape, the guidelines that's out there. So when you're doing your research, you sort of tailor it to the needs of the day. And I'll talk about Health 4.0, a little bit on future of work. I think it's very important, especially our young doctors who are here on the research day. And I'll conclude the presentation. A little bit on our country. Total population is 32.7 with a GDP capita of 12,500. But what is interesting, in fact, it's not interesting, it's actually scary. As you know, we are going into an aging nation. If you see the population above 60, in the last year, fourth quarter, is 11.2%. So when we are talking about research, areas of research, aging needs must be addressed. Our total health expenditure is still very low, 4.7%. It's almost 50-50, public and private. And our life expectancy has improved, 75.6, but that does not mean our quality of life has improved. So bear that in mind. And as researchers, this is what we need to look at, how to improve the quality of life. This is a bit on the health and wellness data, which I took from the NHMS of 2019, our health fact, and also from the disease control division. If you see, we have both burdens, non-communicable and communicable diseases. Non-communicable is very scary. We have about 1.7 million people with 3 major risk factors. And if you look at the 10 principal causes of death in 2020, disease of the circulatory system is the highest. At the same time, our infectious diseases are rising. And you can see the increase, also incidence of vaccine preventable diseases. Obesity is at the worst. And we also have all the other issues, including mental health issues. So moving forward, these are some of the major issues and challenges in the country. So what are the areas of concern in health? And as researchers, these are very important because your research must address these areas of concern of health, in health. We have concerns in the population health, which I have mentioned earlier, disease burden, aging society, mental health. Not forgetting environmental health plays a big role in the coming years, especially when we are addressing climate-related matters, nutrition and urbanization. What about the people, the society? The needs and expectations have changed. We have become a digital society in this pandemic. Empowerment and participation and lifestyle is also very important. In terms of delivery system, a lot of issues of resources, health workforce that is inadequate, and then the coming in of technologies and new service models and so forth. And of course, financing. We are underfunded, underinvestment. This has been mentioned by our Minister of Health many times. Our healthcare cost is rising. Are we able to sustain if we go on continue like this? And issues of financing and reimbursement also comes into the picture. What about COVID-19? How has it affected us? As you see the figures here, nearly 500 million cases within the next few weeks. We'll hit 500 million cases globally. And Malaysia alone, we have more than 4.2 million cases. It's not only a public health crisis, but it's also had an immense pressure on our healthcare system and also on our economic and social impact. It also showed all the gaps that we had, all the inequalities and disparities. But at the same time, there's also a silver lining where suddenly digital transformation, adoption has actually taken a quantum leap. Suddenly, we are all the digital society in this pandemic. I think it's important for us to know there is a vision called Shared Prosperity Vision of 2030, where we are committed to make Malaysia a nation that achieves fair and equitable, sustainable growth. And at the same time, all of us in healthcare must know SDG 3.8, which is the universal health coverage, in ensuring access to quality health is given to all without facing financial hardship, especially to the rural folks, vulnerable groups, and also the B40 group. So what is the digital policy landscape in the country? I have put here 5 important national landscape, national policy that has an effect on the digital and which has relation to health. One definitely is a 12 Malaysia plan, and if you have not read it, I have summarized this. It's actually what it wants is for us to have a healthy life and promoting well-being of the rakyat. And there's 3 main strategies inside there, which includes redesigning the healthcare services, strengthening health financing, and also leveraging technology. So with the 12 Malaysia plan, we have included all this input into all our strategic plan. And the white paper that's coming up, which I'm sure you have heard Minister talking about it, where we are moving towards health reform, will also address all this. At the same time, very important is the digital economy blueprint, especially you are in the research community. A lot of research in terms of digital technology, digital innovation is in this area, but I will speak about this much later again. We also have the public sector digitalization plan, on which based on this plan, which is done by Mampu, that's how Ministry of Health will come up with its plan, which I will also discuss further. The National Technology Innovation Sandbox is very important, especially our research community. You must know about this because this is where you can be facilitated, you have grants and so forth. And finally is the MySTIE framework, which a lot of research community is involved in this. And in here, there are national roadmaps for blockchain, AI, robotics, advanced material, and of course, our vaccine development. But what about Ministry of Health? What is our vision our goals, our strategic direction. If you see on the left, the 8 health goals and the integrated telehealth chart, this was done in 1996. Again, this was done in 1996. We had a long-term vision then, but along the way, a lot of things did not happen, execution and implementation challenges and so forth. But we are moving on. Where in the 11th Malaysia Plan, we have included strengthening ICT. Again, in the 12th Malaysia Plan, the game changer is about digitalization. And then again, in the strategic plan, where we have putting leveraging technology as one of the strategy. And finally, our MOH digitalization strategic plan, also talking about integrated quality and sustainable health service delivery. So I have mapped it out, what are the most important things, but in every of this strategic plan, the word digital keep on appearing and appearing and appearing. So it is a very important important thing in leveraging technology and innovation in healthcare if you want a better healthcare tomorrow. The MOH digitalization strategic plan, if you have not read it, it's already on the portal. It was just launched on the last day of February. And our vision is for an integrated quality and sustainable health service delivery. But what I want to move your attention is to the focus areas. A lot of focus is on governance and stewardship, including the governance and stewardship of research, integrated health service delivery. We are talking about cloud, technology and infra, talking about emerging technology and 4IR, which a lot of CRC is involved, and also ICR and NIH. One of our big major initiative in this strategic plan for 5 years is the big data analytics ecosystem. This is for the research community. And so we really hope this will take off. We have strategic collaborations. Ministry of Health cannot do this alone. It's very important for researchers to work with the academia, to work with the industry, and also to work with the society, where we call it a quadruple helix or triple helix model. Competency framework is very important for our healthcare workers. Are we ready in this era of 4.0? And also not forgetting research development and commercialization, especially all your innovation and so forth. How do we help in commercializing these innovations? The slide is not moving. Just 1 minute. Okay, sorry. So I'll just give you the landscape in Malaysia in terms of Health 4.0. This is the global digitalization benchmark. You can see many countries have moved towards digital government, have moved towards national digital ID, and most of them are going into AI. In fact, if you see, Singapore has already got many things: Digital Academy, EA initiative, a national AI strategy. India also has the same, Korea and so forth. So we still have a lot of work to do, but we have moved into digital government. We are actively looking into open data. That is why you see a lot of COVID information is on GitHub, and our genomics is also on GSAID. We have started on big data analytics and AI, and also the national digital ID. What about the market size in digital health services in Asia? And this is also relevant to Malaysia. This is one of the latest publication by McKinsey, where they are talking about consumer-centric digital health ecosystem. And if you see, the highest percentage is on telemedicine and remote monitoring, and that has been really proven in our pandemic. Talking about digital pharmacies, AI imaging, digital therapies, genomics, and wearables, and so forth. So the total market size in Asia is projected to be in billions by 2025. What about our journey? Our journey in Malaysia. We started in the era of multimedia super corridor. In 1995, we are talking about process automation. And then 10 years later, we are talking about connected government, where we're talking about eGov 1.0. And then we moved on to collaborative government, And then we use the word digital government, where all the services are digitalized, and you can go on our digital government portal, and you can access mostly all main services in the country. And in 2025, we are hoping to achieve a digital nation. So this has been our journey. It is quite a long journey. Along the way, things may not have been done. Things may have failed, but that doesn't matter. We fall and we get up and we move on. But where is Malaysia in all this in terms of innovation, in terms of competitiveness, knowledge, and talent? We still have a lot of work to do. We really have to have good talent, good infrastructure, and we really need to improve our innovation capacity. Our skills need to be strengthened. If you really want to move towards a science, technology, and innovation kind of a country, and we really have to enhance our research capability, our high quality research capability as a country. So I think as a research community, we have a lot of work to do. But where are we today in healthcare? There's a lot of things we have done for the last 20, 30 years, patient-related systems and pharmacy systems, blood bank. We have Malaysian data warehouse. We also have regulatory-related systems for food safety, for example, FOSIM. We have systems for the professionals. Of course, e-government systems is there. It's almost many of our day-to-day HR, finance, procurement, human resource is all digital. We also have online health services where there's a lot of online services direct to the consumers. We have advancement in emerging technology and 5G. But again, this emerging technology 5G is still in an ad hoc manner. We don't really have like a nationwide implementation, so a lot of it are silos and a lot of digital collaborations. And not forgetting, during COVID-19, we had the entire digital ecosystem, which I will present after this. But even as much as we have achieved, there's a lot of challenges. If you see on the right hand, it's a lot of silos and fragmented systems, even among hospitals, among primary care. There's also silos among programs, So how do we close this gap? We still have weak analytic capabilities, but I think over the years it has improved. Our hospitals and clinics are still manual, especially like HKL, huge hospital. A lot of it you are still doing manual. We have public and private sector dichotomy, and there's a lot of limitation. We have new technology that is disrupting our service model. We always think that everyone has to come to hospital and clinic, but the pandemic has proven not necessarily. A lot of regulatory roadblocks, old legacy regulations and policy that really needs to be reviewed. Public expectation is high, and because of funding, we have very slow scaling and rollout. And also, we have done so much during the COVID time, but how are we going to sustain all these systems? This one is just showing you how much is done during COVID. This is 2 years only. And if you see the one in rates are the one that is new. There are some that is already ongoing, we're just leveraging. So either we create something new or we leverage what we have. It's a lot. A lot has been done. And a lot has been done also in the area of research and clinical trial in terms of drug and vaccine trials. You have done on AI, genomic surveillance. We also tried a lot of 3D printing for equipment and PPE during this pandemics. Robotics, we did in MIPS, we did in so many other hospitals, testing kits, medical devices. So it's a lot of areas was done. But what I want to show you is this, some of the major initiatives in pandemic. Of course, for the entire vaccine program, it's actually a huge ecosystem of digital, where we use the vaccine management system and the vaccine administration system as a backbone for vaccination. Of course, My Sejahtera app is another huge implementation, which is the main app used in COVID-19. And this one had a lot of effort of collaboration of multi-government agencies and industry with various modules for empowering community. Even though today we are having some issues, but these are all commercial issues. E-COVID-19 for data collection, reporting, and case management, and those who are in hospitals like HKL. I'm sure you also know about this system, and the CPRC hospital system, which all 141 hospital uses it in terms of planning and operations for COVID. And this is mainly for your capacity, your beds, your supply chain visibilities in terms of PPE, clinical reporting, lab utilization, and also HR planning. At the same time, during these 2 years, we have become a data-driven ecosystem. There's so many dashboards outside there. COVID now, CPRC World COVID Surveillance, vaccination dashboard, CPRC dashboard, My Sejahtera dashboard. What does this show you? This show you data is the oil. Data is the oil of the future. Data is very important in strategic planning. Data is important in management of pandemic. Data is important. And this is what, that is why for the research community, we are pushing for a big data analytics ecosystem. So you have data. You cannot do AI, for example, without data. So this is what the data-driven ecosystem is all about. And again, I'm showing you the digital ecosystem of our national vaccination program. This was the first project where we use blockchain for our vaccine systems, and it is an entire huge management of digital system. It's not easy. It has so many players in this, and so many systems, and so many ministries were involved in this entire national vaccination program. But now let's come back to reality check. Yes, we have moved forward, but let's stop for a while, pause for a while, think about it. Science and technology is actually rapidly developing. Either you catch up with it or you are left behind, So we have become a data-centric and data-driven world, and the pandemic has shown that. At the same time, the consumer behavior and expectation has changed. People are more knowledgeable. In fact, the moment they walk into your doctor's room, they know more than you, so that is the reality. And because of the rapid adoption so your relationship with your patient, you must change. It's no more you know everything, doctors know everything, so you must change. And consumers are now wanting healthcare as how they get their Lazada and their Grab and their Zalora, so they want on-demand retail-like service. So are we ready for that? So this is what for us to think about. So you really need a paradigm change in these new care models. Providers, we must be ready. Consumers are ready, I think. We must modernize our policies and regulation, and we must have new models of reimbursement. And digital transformation in the pandemic is real. We have digital disruption, we have digital society and consumers. Now everyone knows how to work from home. Everyone knows how to order food. Everyone knows how to order grocery. So why can't I just order for health service? So this is the new norm. So there's a new normal service delivery. It's actually a platform economy right now. You can order your flight ticket, you can order your hotels, and everything is on platform. So the same as for healthcare. But what's important is how do we sustain all this? So this is the focus area of our future healthcare. Mind you, the DG of Health, we sat down and did this in 2018. And we never thought in 2020 to 2022, all this will be real. So it's a reality in pandemic, quality and safety, of course, no compromise. Illness to wellness is very important. We are bringing healthcare back to communities, families, and individuals, smart solutions, collaborative partnerships, and also public-private integration. So we must move away thinking that everything needs to be done in hospital or clinic. Everything needs to be done in the four walls of our healthcare facilities. It's no more. So we all have to move. Healthcare have to move back to the community, families, and individuals. So this is our vision. We want an interoperable health ecosystem, and this vision has been there since 1996, yet we have not achieved it. So we want the public and private to be integrated, but our system is right now is totally dichotomous. But how do we bring them together? So only if all the health facilities ICT enabled, we can achieve an integrated national health information system. So this is our vision, that all the public healthcare, private healthcare is all integrated, and then we have data at the data warehouse, we have all the other support services, then the people, the societies use the wearables and health inputs, and then we have the health insurance providers as an interoperable health ecosystem. So what is the National EMR Initiative? You heard Datuk Hisham Shah mentioned about it. Actually, it's an initiative where we want to have a nationwide EMR implementation in all our hospitals and clinics. But at the same time, we are establishing the National Health Information Exchange Platform and the Lifetime Health Record. But this is for the country. So we want to meet our health vision, which we did in 1996. And the objectives is more of continuity of care, patient engagement. But what's important is data analytics is there, so that we have data-driven insights as the goal, and other plus all the other goals that is here. But also not forgetting patient experience, customer experience has now become a very important component in our health system. And the outcome is, again, like I mentioned earlier, towards an integrated healthcare delivery system, towards a healthy Malaysia. So we have actually started, I just go back. For this project, we are doing a pilot, Negeri Sembilan, we have taken off. So hopefully if all goes well, and then we are at the same time continuing all our implementation of EMR in hospitals and clinics, and our health information exchange platform. The first version will be ready in this August. So we really hope we can move forward. But what is the future? The future is all about human and techno interaction. We are still here at digitalization. Actually, the future is about personalization. We must talk about man and machine. It's very important, you know, and how we work in harmony. And that is what is important in moving forward. So the digital economy blueprint, I'm coming back to this very important document, which was released in February 2021, had these 6 clusters. But how is this related to our healthcare? Among these 6 clusters, cluster 4 actually and 5 is the most intensive one, has all the healthcare initiative. And I will mention to you what it is. And also for data and digital infrastructure is in cluster 4, has also big data, also talks about improving our connectivity, 5G, and so forth. So in each of these cluster, there is healthcare components, but I'm very much involved in cluster 5. So I'll just explain to you what is cluster 5. So these are the game changers for tomorrow. AI, IoT, cloud, big data, 5G, robotics, genomics, blockchain. So in that cluster of cluster 5, there is initiatives for Ministry of Health for mid-term and long-term, which in all these areas. I think someone is... sorry, there is some disruption there. Okay, so so in all these areas, there are a lot of initiatives which is done and led by either hospitals, clinics, or industry, or academic, Ministry of Health, NIH, and so forth. So these are the things. But some of the things that's already starting to move is robotics and drone, Of course, in the area of blockchain, we have started with our vaccine. 5G is now, we are actively looking into improving 5G connectivity in certain hospitals. Now, it's now cloud first policy. Everything we do have to be cloud. Of course, IoT and AI, there's a lot of things being done, but not at the nationwide scale. So we are hoping we can take this off in our digital economy initiatives. AI will be the thing in the coming years. So as a researchers, you must know what is the framework for AI use cases in healthcare. You can get it from the AI in Global Health, the USAID document. It's a very nice how they have put where AI plays a role. And in Malaysia, we have already have AI in the area of population health. We are also doing some AI in the individual health. In terms of health systems, I'm not sure if anyone is doing it right now, but in terms of pharma and medtech, we're also doing. But again, like I told you, it is still in a either early phase or still in a trial stage. This is for AI, and everyone in the research community must know about the use of AI, because the two important things is AI and also 5G in the coming years. So this is the 5G use cases on healthcare, and we are going to come up with one or two pilot hospitals. We have done some pilots on 5G last year, and we have proven that it works. So we might be coming up with some new things under the 12 Malaysia plan. And I think it will be launched soon for one or two hospitals to be 5G pilots for systems. So these are some of the 5G use cases on healthcare, mainly robotics in clinical, like surgery, smart ambulance, telemedicine, and of course, augmented reality is also one thing that is further enhanced in 5G. But as much as I've spoken about all this, there's a lot of implementation challenges, and this is same. Every country has the same challenges: policies, infrastructure, system, financial, people. People issue is a big issue, you know. Clinical leadership. As clinicians, it's very important you lead the way for digital transformation in your own areas or in your own hospital. Then the others will follow behind, you know. So it is the clinical leadership that's very important. Digital leadership at the national level, at the hospital level, at the primary care, you know, at the state level is important. Change management, skills and expertise. But we must work in a speed and agility that we have never seen before. So that's very important. But actually, these are common issues. Every year is the same challenges. But what about new issues? What about new things that's coming in? So you see, this is real. It's already happening, you know. Mobile ultrasound, Watson, AR, robots used in healthcare. We even have 3D advanced printing, you know. We have robotic surgeries, nanotechnology, you name it, AI, digital stats, it's all there. But is it risky? And do you want, what are the challenges? So this is very important. So these are some of the new challenges: legal issues, ethical issues, safety issues. And as research community, this is very important. And some of the issues are still being addressed. You know, we have issues in terms of process and policy, especially regulation, whether we are ready, you know. We are still having issues on cloud policy. What about data ethics? I know as research committee, your ethical is a very, very important thing. So what are we doing about that in clinical and data ethics? What we are talking about data quality and governance, you know, and what about a new business model? In terms of people, is there digital literacy? Is there trust in the people to use the innovation? What about our healthcare workers? What about our upskilling? Digital divide and equity, you know, when we do some things, it's not only for the urban, it must be for everyone, you know. and it must be affordable. What about our consumers? Are they AI savvy? Digital nomads. It's a very interesting term. Digital nomads, where our people just keep on moving, because they don't have to be stuck to one place to work. And then we're also talking about AI, algorithm bias, which can happen. Clinical validation is very, very important in trials, and also governance of platform economy. So these are some of the new challenges. But what is the role of government? When I say government, it is not Ministry of Health overall. When I'm saying government, it also many ministries, many agencies. We have a role in leadership. We have a role in the digital stewardship. Political commitment is very important, advocacy. What about policy, regulation, and legislation? We must really look into some of it and we must balance innovation and safety and social protection. We must have standards. What about IP protections and regulations? All of y'all are doing a lot of innovation. Are we talking about the IP protection, and so forth? Access is important. Talent development, capacity building, research and education, and also collaboration. Again and again and again, we cannot do research ourselves. We have to work with academia, we have to work with the industry, and finally, maybe with the patients and the people. So public-private partnership is important in digital health and innovation. So basically, that is the role of government. So, but I cannot end this presentation without talking about the future of work, the future of clinicians, the future of radiologists. What about the future of pathologists? What's going to happen to medical record officers? What's going to happen to many healthcare workers? Is AI is going to take our work? Is robots going to replace us? So there was a foresight 2050 that was done by Academy Science, which they say that machine learning algorithm can do work of 140 million knowledge workers, and 30% of the middle income job will be eliminated due to innovation, and that will affect 51% of our current job. So what are we going to do about it? Are we just going to continue to do same, or are we going to improve our skill and learn about digital? It was interesting. I had a meeting yesterday, and I was talking to them about digital technology, and many of them said, "Oh, I don't know about this. No, it's not my area." You cannot say that anymore. If you are using your phone, you are digital, okay? So it's very important to upskill, to know about digital. So again, back to the question, are you talking about future of your job, or are you talking of jobs of the future? What do you want? It's up to us to choose what we want. Do we want to be left behind, or we also catch up with science and technology? So these are some of the pictures to show what the future is going to be in healthcare. There was a review done by NHS that was launched in February 2019. This is 2019, before the pandemic. At that time, they were already saying that genomics, digital medicine, AI, and robotics is going to change the role and function of clinical staff over the next 2 decades. And they never know that this is going to change for the next 2 years, from 2020 onwards, you see. So we really didn't know this was coming, but it was a great review where they talk about what is the role of healthcare workers, and this was done for the NHS workforce for 2020 to 2040. But I won't be surprised if this has changed dramatically because of the pandemic. So as all of us, we are leaders, we are workers in the 4th Industrial Revolution. What are we supposed to do? We really need to have a different kind of leadership. We really have to be comfortable with technology. We have to be comfortable with machines. We have to be comfortable with robots. There is even robots in Mama shop now, serving you food. So we must have new skills. We must unlearn and relearn. You know, we must unlearn. We must unlearn and relearn new things. Look at our children. We can learn from our children, especially the young ones. You know, we must also reskill and upskill. It's very important. We must have talent diversity. We must have lifelong learning, and we must have cross industry. Again and again, I think a lot of our management do not allow our staff to go for any seminars or conference that is not healthcare. You will never learn. You must go for a financing conference. You must go for a manufacturing conference. Then you know what's happening in other industries, how technology is shaping agriculture, how technology is shaping education. If you keep on going for a conference in healthcare, you will never learn. So you must have cross industry. That is the minimum you can have, at least attend the conferences. So I really advise all our department heads, please allow your officers to go and expose themselves to conferences, to expos, to demos. That is not healthcare related. All right. Be inspired, be motivated in moving forward. So this is the workforce of the future. So this is what our universities must make sure the workforce that comes out from the universities have all this kind of new skills, even including our medical students. Our medical education must change. Our nursing education must change. And all the others, the allied health also must change. Our schools must change and make sure people are capable of the future, you know, and they are ready for the future. So these are some of the skill, communication skills, people skills, social capital, and so forth. You know, STEM skill is very important. Science, technology, mathematics is also very important. And we must also have some business skills, especially if you are doing innovation, you're talking about IP and so forth. And complex problem solving skills, which is quite lacking right nowadays. So finally, in moving forward, I think in this pandemic, post-pandemic, we really need a comprehensive recovery plan. Our system must be ready. We must be a resilient nation. And you know, this health in all policies is actually an old term. We have been using it many years, but nobody believed it. But today, the pandemic has shown that every ministry is health ministry. You must have health in all policies, all right? And then we must also enhance science, research, digital technology, and analytics, and become an insight-driven organization. We must have new approaches in this era. You know, we must talk about cloud deployment models. We must talk about new fundings. We talk about public-private partnership. Regulation maturity is very important. And finally, in conclusion, the future of care, I always have these 3 Ps and the 3 As: predictive, preventive, personalized. You cannot do predictive, preventive, personalized without digital technology and innovation. But again and again, as researchers, please do not compromise on availability, accessibility, and affordability when we are doing innovation. And then it must also go beyond just curing disease. Talk about wellness, how to keep people healthy, you know, and you must move away from walls of hospital and clinic. We must talk about digital therapeutics. We must talk about individuals managing their own health. We must talk about new paradigm of data ownership, privacy, and sharing. It's still very important. We must upskill, have new skills, you know, and also unlearn and relearn. And policymakers, we must be fast in agile policy making. Of course, cybersecurity is a big threat. So it's very important, cybersecurity and biosafety, and not forgetting ethical and social issue has become more and more important in this digital economy, especially with AI and so forth. So with that, thank you very much for your attention. And I think I pass it back to the Secretariat.
Thank you so much, Dr. Fazila. Would you be open for any questions,
Yeah,
Doctor?
yeah, fine. I'm open for any questions.
Okay, so we have several questions. Before that, there's a Dr. Munira Ibrahim. She says, congratulations for the past 2 years of the Ministry of Health achievements. Congratulations. Okay, so we have two questions here from Mr. or Dr. Kiam Seong Go. He is asking, is there any platforms or training or workshops on this medical digitalization skills in MOH?
Okay, right now we don't have a platform, but in our 5-year digitalization plan, we are coming up with a competency framework. We may not create the platform, but we must send out our people to be trained and so forth. But at the same time, there's so many of these webinars and training outside there, which you must look for it. So always keep an eye on that. And then, but definitely our competency framework will also identify what are the skills that's required. And I think we are also hoping that bahagian latihan will look into, all our schools, our nursing schools, allied health schools, about their curriculum. And about the universities, in fact, just 2 years ago, just before the pandemic, all the medical universities, all the deans have sat down and re-looked into moving forward for the medical education. I was invited at that time, so hopefully, but I'm not sure whether the plan is out. But definitely right now we don't have a platform, but please look out for all the other platforms that's out there.
Thank you, Dr. Fazila. Basically, we should be more proactive as healthcare workers, open up our eyes, look for any opportunities out there. I totally agree with you, Doctor.
Yeah.
Another from Dr. Munira Ismail.
Sorry, just one more thing. And just tadi Dr. apa cakap tadi?
Dr. Kiam.
Okay, and then also Dr. Kiong, I at this level, I still read about 3 or 4 articles per day.
Amazing.
Per day, because I subscribe to a lot. I mean, there's a lot of free subscription, am I right? You don't have to pay. There's a lot of free. So you just read, keep up to this one. So you have to read. So again and again, the basic we can do is read. So even when the Quran came down, it was read.
Iqra.
Yeah, Iqra. So read, and that's how you improve the knowledge. I started with zero knowledge. I'm not saying I'm an expert. I started with zero knowledge, but I attend all seminars that I can. I read. I also attend non-healthcare seminars. Boring, always going for healthcare seminars. Go for non-healthcare seminars. Tapi ketua jabatan kena bagi kebenaran lah.
Amin, betul tu. Sokongan ketua jabatan sangat penting. Another from Dr. Munira, Dr. Fazila, it's not a question, but she says, hopefully BPL or training providers can consider providing this area on medical digitalization, health informatics as part of our training as a priority.
That's very interesting, but all the universities now, I think most of them are offering masters in health informatics and PhD. So our local universities have started to offer that. And if you hear every year dalam LDP, there are already a lot of people going for this kind of local health informatics study for their postgrad. So that is one area where some of you who are who are interested in this area can pursue that. I think with the universities, correct.
Okay, so far questions are typed in the chat box. I would open the floor for any live questions to our participants. We have around 200 people on Zoom, Dr. Fazila.
Wow.
And several on FB live streaming and also on YouTube as well.
I see. So anyone want to ask me a question? This is your time. I have a lot of time here. Dr. Salina ada?
Dr. Salina ada. She's with us in our training room in CRC. Yeah. Okay. And at the moment, we have our poster presentations in our main lobby of HKL, main auditorium, and also online.
Good luck to all the poster presentation. So I hope we get some, good research papers.
Dr. Fazila, a question from myself. How do you see our Ministry of Health in this era, for this digitalized era, in about 5 and 10 years ahead?
Yeah. If you notice, we have taken a digital leadership role for the last few years, so I think it has to come from Ministry of Health, because we are one of the biggest stakeholder in health. So that is why we came up with the digitalization plan, and we are very active with the digital economy blueprint initiatives, looking into emerging technology. But at the same time, there's a lot of gaps in our basics. Our hospitals are manual, clinics are manual. So we are trying to address that, and we are trying to address public-private integration. But again and again, if Malaysia want to move forward in health sector, it cannot just be Ministry of Health. It has to be everyone. So it's very important for us to have public-private collaboration, very important to work with the academics, work with the industry, and very important to move this research agenda. I'm not a researcher, Dr. Salina pun tahu. I'm not a researcher, but I'm very passionate about research, isn't it?
Yes.
Yeah. So, and then be inspired, be motivated, do something, is that when you grow old, when you turn back, say, I have done that. That is what you must do as young people, young doctors, young nurses, young healthcare workers, and then what you leave behind is for your children and your generation. So that is my advice to all.
Yes, Dr. Fadila, thank you very much. It's been very inspiring. Okay, you sound like a motivator.
You tahu kan, I suka research dengan innovation.
I think there is a lot of things going on actually. Even in my mental health, there's a lot of therapy using AI that we are starting. But again, I think the higher up lah orang.
It's not coordinated.
Yes.
Yeah, it's like it's a silo. People are doing because of their interest, but there's no one looking at it, facilitating it, bringing all together. So that is why we are hoping in this, because under the digital economy blueprint, we have to list out everything that's happening. So this is the first time I knew there was so many things happening in so many areas.
Yes.
So we are sort of taking stock take first, and then let's see how we can facilitate.
Yeah, because I mean, being at MREC, I see quite a lot of proposal that comes in with regards to AI. Sometimes we have a bit of difficulty on like channeling where to get advice, especially with regards to these new technologies, new stuff that they're doing lah.
Yeah, so we are also hoping that one of the there are 10 main initiatives under the MOH digitalization plan. One of it is the big data analytics ecosystem, where if we have that ecosystem, it will really help the researchers to get data. I know researchers are having such a problem getting data, so I think
banyak red tape.
Betul.
Ministry of Health kedekut, macam-macam lah dia punya.
Memanglah. So that is why last one year ni under the Jawatan Kuasa Informatics, we are reviewing all the data guidelines, data access dan sebagainya. I think that and now government is pushing for open data. So in fact, Mampu has just written a letter 2 days ago also about open data lah. So I rasa we must move forward. Data is the oil.
Yeah, I think we must have a bit more trust in each other. Sekarang ni too much suspicion and paranoia feeling between the different ministry. I think there need to be more trust and more collaboration. I think insyaAllah we can move forward.
Not only between different ministries, within ministry.
Oh yeah, betul. Okay. Oh, nice talking to you. Nice listening to you. Thank you very much.
Okay. So thank you so much for inviting me. I have to go for my next meeting at 10. So I wish you all the best.
Selamat berpuasa.
Same to you. Bye-bye.
Bye.
Thank you so much, Dr. Salina, for her special appearance during Dr. Fazila's talk. Now, we will rest shortly for 15 minutes for our tea break. In the meantime, we would like to invite our viewers in FB Live and Zenodo Online on YouTube and on-site at the main lobby to enjoy browsing through our poster presentations. For those viewing online, do scan the QR code and click on the link provided at the side to view the posters. Please do leave your comments or ideas along the way. We shall see you back in 10:30 a.m. Thank you. Alhamdulillah, welcome back. We hope you had a very refreshing tea break with your teh tarik, your Nescafe, and so forth. Now, let's move on to our next program for today. Our second speaker is Dr. Muthu Kumaran Thiagarajan. He is our clinical oncologist of Hospital Kuala Lumpur. Dr. Muthu Kumaran obtained his master's in clinical oncology from University of Malaya in 2013. He previously served at Sabah Women and Children Hospital. Currently, he is based at HKL's Department of Radiotherapy and Oncology. Dr. Muthu Kumaran has a special interest in pulmonary oncology, genitourinary oncology, neuro-oncology, and pediatric radiation. He is actively involved in both industry-sponsored and investigator-initiated clinical research. Dr. Muthukumaran is currently the president of the Malaysian Oncological Society, MOS. He is also a national representative to the Federation of Asian Organizations for Radiation Oncology, FARO, and International Atomic Energy Agency. So without further ado, let's invite Dr. Muthukumaran for his talk on the clinical impact of research and its challenges.
Hello. Very good morning, everyone. So thank you very much to the Madam Chairperson for the kind introduction, as well as the organizers of the 5th HKL Research Day for their kind invitation. The task given to me today is to speak on the clinical impact of research and its challenges. So I've got no disclosures specific to this talk. So just as a brief introduction, so research mainly means systematic investigation into, as well as study of materials and sources in order to establish facts and reach new conclusions. It is the means by which we create new knowledge and or use the existing knowledge in a new and creative way so that we can generate new concepts, methodologies, understanding. And this could synthesize and subsequently lead to analysis of previous research in the extent that leads to new and creative outcomes. So it's basically the way we progress in science, and more importantly, the way we progress in medicine. So looking into medical research, as a conundrum in itself, it is divided into primary and secondary research. So in primary research, we are looking into basic research that looks into preclinical models, either using in vitro cell culture-based research or in vivo animal-based research. It also includes studies such as imaging procedures, biometric procedures, and so on, so forth. So basic research forms the scientific basis to actually be developed into clinical research, the first in human and subsequently human experiments are then conducted. The second column that you could see is clinical research, which is basically the main focus of the talk today. It could be an experimental research looking into phase 1 to phase 4 clinical trial, or it could be observational study looking into case control studies or prospective or retrospective cohort studies, trying to investigate the science behind diseases in relation to patients. The third group will be the epidemiological studies to look into the community effect of a specific disease in medicine. So it could also be interventional, or it could also be a cohort study. Secondary research would be the way to synthesize strong evidence based on basic clinical as well as epidemiological research. It includes meta-analysis and systematic reviews. So what is cancer research? So in cancer, we are basically looking into 4 main components. We are looking into how we can prevent cancer. We are looking into how we can detect cancer. We are looking into how we can diagnose a cancer better. And the final bit is how we treat cancer better. So in the Department of Radiotherapy and Oncology here in HKL, we are mainly focused on cancer research on treatment of cancer. So the cycle of cancer research basically starts from observational of a medical occurrence that subsequently leads to a discovery and a therapeutic development and clinical testing. And subsequently, it goes into vigorous clinical research and then goes into a clinical practice, and that creates a curve for learning. And the cycle then continues where this new intervention then becomes an observation of the future, and that creates a discovery for the future. So cancer research, or any research for that matter, is a continuous cycle that continues to generate the information that we need to treat our patients better. So looking into the interventional studies in the clinical setting, so we do have phase 1 to phase 4 studies. Now, phase 0 or phase O studies refers to the preclinical in vivo and in vitro studies that forms a basis for a specific intervention, mainly drugs, to come into a phase 1 study. So in a phase 1 study, we're looking at a small group of patients. Either they are patients with very terminal cancers where they've got no chance of cure, or sometimes even healthy individuals, whereby we would like to study how this drug basically affects the person in terms of absorption, elimination, as well as toxicity. And once a specific dose or the maximum tolerated dose is actually discovered, then the drug then moves into phase 2 to see whether the drug is actually efficacious in treating the disease in question. So usually phase 2 has about hundreds of patients. So once the efficacy is established, it then moves into phase 3, whereby we would like to then compare this intervention with the standard of care. So phase 3 studies typically has hundreds of patients and even can go up to thousands. And subsequently, if the phase 3 study is a huge success, this drug is then registered and marketed. And post-marketing, the drug is continued to be studied, and this is called a phase 4 post-approval study, whereby a constant lookout on its rare toxicities are in constant surveillance. And this usually involves thousands of patients, and this is what we call as real-world evidence studies. So newer in the concept, especially in oncology, is the concept of the umbrella and basket studies. As the traditional phase 1 to phase 4 studies requires a large number of patients, requires a long duration of study, and it takes years before a new intervention can actually enter clinical practice, there are some accelerated ways by which new drugs could actually be used to treat cancer patients. So in the umbrella study, what we do is that we look into a specific type of cancer and we identify biomarkers that are targetable. So for biomarker A, the patient is given then drug A, biomarker B, drug B, so on and so forth. And the individual efficacy of the drugs are then evaluated in the setting. And this could lead to a registration of drug, especially if we are looking at a rare subgroup of a cancer. In the basket study, on the other hand, we are looking at multiple cancers, of which all of them harbor a specific biomarker, and the drug that targets that biomarker is then used. So these are two new emerging concepts, and there are a lot of studies, especially with the use of targeted treatment, that actually uses into this. So in future, we may be looking at a situation whereby we may not need phase 3 randomized clinical trials anymore to actually bring a drug in to be used in prime time. So what happens to the information that we gather from all this research is that it amounts to our decision-making process, which we call as evidence-based medicine. So EBM is a conscientious, explicit, judicious, and reasonable use of modern and best evidence available in making decisions about the care of an individual patient. It aims to create the use of high-quality clinical research in clinical decision-making. So if you look into the pyramid on this particular slide, you would see that animal research and in vitro studies actually forms the lowest mark. Of course, the amount of data available here is probably the most, but the quality of evidence that it provides is probably the lowest. And subsequently, you move on to expert opinions and editorials, and moving on to individual or case series, and subsequently for case control studies and cohort studies. And then at the peak of the pyramid, we are then looking into evidences derived from randomized controlled clinical studies or randomized controlled double-blinded clinical studies. And with this kind of a pyramidal assessment of evidence, we are then able to identify high quality evidence to aid decision-making as to what would be the best treatment to be offered to patients. However, not every single clinical scenario could actually be explained or could actually be manipulated with the use of evidence-based medicine. So the British Medical Journal actually has got this series which they actually publish towards Christmas every year, whereby they actually poke some fun into the field of research. So this is a publication in 2003, whereby the editors actually decided to do a systematic review whether the use of parachute can prevent death and major trauma related to gravitational challenge. So they actually went on to do a complete systematic review and search of all the literature. And the conclusion that they actually derived was that they were unable to identify any randomized control trials. And therefore, the conclusion is that the effectiveness of parachutes has not been subjected to rigorous evaluation. So the option exists, so under exceptional circumstances, common sense may actually be the best way to actually drive decision-making in our daily practice. Of course, if we continue to quest for evidence-based medicine, especially in situations like this, then technically no one should be using parachutes because we can't justify it with available good quality research. So as much as we are running after evidence, we also sometimes need to understand that not everything can actually be explained by evidence-based medicine. Therefore, we may be forced to actually choose treatment options that are probably best accessible, that are probably best available, or probably that can be best provided to patients with the best notion intact. So let's look into the impact of clinical research. And I would like to first focus on the impact towards a patient. So if a patient actually comes into a clinic and is offered a participation in a clinical trial, the advantage that this patient could hold is that they could be accessing new or latest medicine or treatment options. They probably have got a better, more focused healthcare because the monitoring process for clinical trials are usually more rigorous and it's actually more frequent than what we do in usual clinical practice. They could be contributing to the future generation. Therefore, the information that is gathered from them, as well as their participation in the trial, could then be used to guide treatments of the patients who comes in the future. And of course, there is an opportunity for financial reimbursement for patients who participate in trials. Of course, the disadvantage is that the treatment they receive may not be better than the current standard, because we do know that we're going to compare with the current standard. So they could be getting a substandard treatment. They are, of course, going to be subjected to more frequent hospital visits. So, of course, on one end, we're probably talking about more focused healthcare, but it also means it's more cumbersome for the patients to actually come back to the hospital very frequently. And especially in HKL, where parking is difficult and access to public transport is quite challenging. That's quite a bit of a disadvantage to some patients. Patients may be subjected to more procedures and risks related to the procedures than usual. So quite a number of patients actually go through quite frequent imaging process, whether it's CT or MRI, more frequent than what we do in regular practice. And that, of course, carries a little bit of a risk to the patients. And of course, there could be implications on health insurance. Of course, it's probably not applicable in Malaysia anymore, but there are reports overseas whereby a participation of a patient in an experimental protocol actually excludes them from health insurance coverage. So these are probably some things that we actually want to look into and talk to patients about before they participate in a clinical study. So allow me to explain this with a little bit of a case series, right? A case study, for example. So this is ECOG 1594, which shows the overall survival of patients receiving first-line chemotherapy for metastatic non-small cell lung cancer. Now, this was a publication in the early 2000s, whereby it shows that the combination of a platinum-based chemotherapy with a third-generation chemotherapy actually resulted in an average median overall survival of about 10 months. So at best, if you give these patients with advanced lung cancer a platinum-based chemotherapy, about 50% of them are going to die by the 10-month mark. So that was the unfortunate truth that we were actually faced with when I actually started in oncology around about that time. So IMpower 132 is a study by which we in HKL participated in. So this is a study that randomized patients into a combination of a platinum-based chemotherapy with or without an immunotherapy. And in this particular case, it is atezolizumab. And it was subsequently continued with maintenance chemotherapy. So this is the outcome of the study, whereby it shows that the median progression-free survival is about 5 months in the control arm, as well as 7.8 months in the experimental arm. So this is a clinically positive study. However, the magnitude of benefit wasn't considered to be great enough to actually be practice changing. So we are quite proud to say that we were actually part of this study, and we contributed to some of the information that was actually generated to this particular study. So being a part of clinical trials, we do contribute to addition of knowledge. But more importantly, IMPAL 132 had a specific effect on one of my patients. So this is actually a 40-year-old man who was diagnosed with stage 4 lung cancer, and he was diagnosed back in 2017, and he was actually eligible for a chemotherapy trial. But when we randomized him, he actually got into the control arm. So yeah, I mean, he didn't get the new drug, but he didn't take it to be a very disadvantageous situation, and he actually soldiered on to the protocol as per the request. And the best overall response he had was it was stable disease. The cancer never shrank, the cancer never disappeared. It was just stable all the way. But the interesting bit is that he was actually on the trial for probably the longest possible duration, whereby he actually stayed on the trial until 24th of February 2020. That is a good 2 years in on chemotherapy. And subsequently, he was subjected to second-line chemotherapy, which then he also responded for a reasonable duration of time. And as per all patients with advanced cancer, he did succumb to his disease and passed away in 1st of April last year. And if we look at the point of diagnosis to the point of death, his overall survival was 39 months. So that's 3.5 years. So he's young with kids. So he already knew at the point of diagnosis 2017 that death was definitely imminent, but he actually had 3 years at his disposal to actually plan out to see his children grow, to actually spend more time with his family and wife. And his passing was regarded as something that was very peaceful and something that was very acceptable to the entire family. And I believe that this remarkable achievement was only possible because of his participation in a clinical trial, because although he actually got into the control arm, the chemotherapy that he received, it is not available as a standard of care in Ministry of Health. So although a patient ends up in a control arm, there is still a likelihood that they will benefit overall from treatments that are actually offered. So now let me show you the flip side of that. So IMvigor 130 was another study that we also conducted here in Hospital Kuala Lumpur. And this was conducted on a population of patients with metastatic urothelial carcinoma in the first-line setting. So patients were randomized into 3 arms. Either they received atezolizumab in combination with a chemotherapy, or chemotherapy alone, or atezolizumab monotherapy, which is an immunotherapy. So this study basically wanted to demonstrate that you could probably not give chemotherapy and still have a very good response with patients. And the phase 2 studies were very much encouraging. Sadly, though, this was a negative study whereby the single agent atezolizumab was inferior to the standard chemotherapy. In fact, patients who received atezolizumab actually passed on much faster in the earlier duration of treatment as compared to patients who received the platinum and gemcitabine combination. So atezolizumab was even regarded as something harmful for this group of patients. And this study generated the evidence that patients in the first-line setting should not be offered a monotherapy without chemotherapy, right? And this is a case study of MHB, who is a 50-year-old man who was diagnosed with metastatic urothelial cancer 4 years prior in 2013. And then he developed metastatic disease. He was then recruited into the clinical trial. And at that point in time, he was quite relieved that he actually got into Arm B, because he, as much as possible, wanted to avoid chemotherapy. And he was very thankful that he was randomized into that. However, what we realized is that throughout the 3 months that he was actually on the study, he actually did not respond to the treatment at all. And it was actually confirmed with disease progression by July in that very same year. So he was randomized in February, progressed in July, right? So subsequently, he received radiotherapy and went on to receive second-line chemotherapy. Unfortunately, he was only able to complete 4 cycles. He had multiple toxicities. He had febrile neutropenia that required hospital admissions multiple times. And in view of his safety, right, despite a good response on CT scan with the chemo, he was actually stopped on the treatment. He developed progressive disease and he passed away within a year later. So his overall survival was 14 months. So this is definitely a patient who got into an experimental arm whereby the treatment that was offered to him did not quite help him. And he was actually salvaged with a standard of care. And this is probably one of the risks that the patients will have got to accept, right? So he was definitely a very reasonable patient, and he completely understood that the risks of actually getting the study, but we had quite a bit of a difficulty in relating it to the family because they were actually very disappointed with the outcome of the clinical trial as a whole. And this is basically part and parcel of the challenges that we face, whereby we deal with real patients on a day-to-day basis. So there is an impact into quality of life, whereby this particular study is a derivation of the IPAS study that looked into the use of oral targeted therapy versus chemotherapy in non-small cell lung cancer. So oral targeted therapy have now replaced chemotherapy for EGFR mutated non-small cell lung cancer with an equivalent and efficacious outcome. However, the toxicities are a lot different. So if chemotherapy was associated with life-threatening complications such as febrile neutropenia, admission to ICU, bleeding, and so on and so forth, these side effects with the tyrosine kinase inhibitors actually comes to be more annoying. So patients end up with acneiform rashes, patients end up with paronychia, as well as frequent diarrhea. So as much as these side effects don't result in life-threatening complications, but they actually exist at a lower grade for the duration of their treatment, which can be very annoying and requires a lot of motivation to actually talk to patients and get them to be on board the treatment. So new treatments, better outcome, but different toxicity. In another viewpoint, let's look at the impact of clinical research onto an institution, right? So this is a very interesting study in a first world nation that looked into the outcome of patients in institutions that actively runs clinical trial versus the institutions that do not run clinical trial. And what was noticed was that patients who were receiving treatment in centers that had active clinical trials actually had better overall survival as compared to in centers whereby no clinical trials were actually being offered. Now, the reason for this is probably due to the fact that they have got access to newer medication. But as I've told you, not all the treatments are actually practice changing. But what we understand from this particular study is that if a center conducts clinical trials, they are probably more in touch with the latest evidences. So they are probably at a better position to advise what would be the best modality to treat their condition, given the current state and resources available. There are also false alarms with the use of certain drugs in research setting. So this was actually olaratumab, which was a very promising drug in the treatment of sarcoma, whereby the phase 2 study showed an unprecedented advantage in terms of its response rates for patients with metastatic soft tissue sarcoma. However, when it was actually investigated in a randomized controlled clinical trial, just like the previous IM-130 trial, it was actually shown to be inferior. So we have got to also be aware of the false alarms that we get from such research. And we also do not want to give patients false hopes. So this is a study of hepatocellular carcinoma, whereby sorafenib was actually tested against placebo. And what it was actually noted was that patients in the sorafenib arm actually did much better as compared to those with placebo. But if you actually zoom in to look into the median, actually sorafenib only improved the survival by a mere 2.3 months. So at the expense of toxicity and cost, you're only going to prolong survival in these patients for about 2 months. So as much as the evidence suggests that this is a positive study, where the hazard ratio is very significant at 0.68 with p-value of less than 0.5 at 0.14, the net effect is only 2.3 months. So a positive study, but probably not so hopeful for patients. And the challenges doesn't just stop there. It moves on from challenges of designing a study, from methodology to publication and interpretation of the study. And these are all challenges that we have got to continuously engage with and trying to improve the outcome of the patients overall. So now let's move on briefly into my department, which is the Department of Radiotherapy and Oncology. So we are actually housed in the Institute of Radiotherapy and Oncology. We have been standing there since 1973. And of course, our daycare is actually located in level 6 of the SCACC. So this is basically a breakdown of the clinical research that is currently being conducted in our department. In 2019, we had 7 IIR and 2 ISR. In 2020, the number increased to 14 IIR and 6 ISR. And in 2021, we are running about 18 IIR and 11 ISR. And these numbers are definitely much higher as we even see in 2022. So definitely we in oncology and HKL are definitely involved massively in research, and definitely our capacity is expanding, and that's definitely something very good. But the challenges that we face is that, number one, we did have difficulty in housing our study coordinators. We have about 9 study coordinators, and this was unfortunately the room that all the 9 of them had to cram into. But with time, we were able to negotiate some space. So of course, the original room still remains as messy as it was before, but we were then able to move some of them to a different room, so creating a slightly more place. Of course, space is a huge constraint here in HKL, and finding a space to actually place our study coordinators or even to prioritize research is a huge challenge. And I think after about 5 years of negotiation, I think we've finally gotten a space to actually place them. But even with that, you can still see the rooms actually still pretty full. And this hunt for more space is still ongoing. So in terms of storage spaces, clinical research and clinical trials have got a lot of lab kits, a lot of monitoring kits that is actually provided to us. So we actually have got no place to actually place them. So this is actually one of our rooms in our procedure room. Downstairs in the operating, which used to be operating theater. And we have actually put all these boxes in there right now. So this is currently in, we're actually planning a solution whereby we have actually gotten an approval for a container. It's just that we don't have a place to actually put this container. And it's been about 6 months that we have been moving around the whole hospital looking for a place. So hopefully when we get granted a location, we would then be able to move these kits to this particular storage container, and the space in the OT will then be released back to the department. So in terms of clinical trial units, we have been sharing the space of conducting clinical trials and procedures with our normal clinical routine. So we have been using the clinic space, we have been using daycare space, we have been using inpatient beds to actually run our clinical trials. So recently we came into an allocation through one of our collaborative effects with Japan called the Atlas Project, whereby we were given an opportunity to actually renovate one part of the wards to be made into clinical trial unit. And of course, with all the approvals in hand, the clinical trial unit has currently been completed. So this is how the space now looks like. We are actually going to do a TNC for this facility this afternoon. And we are hoping that we will be able to do a proper opening, probably after Raya, and use this facility by June this year. So all of our clinical trial patients will actually have a specific place to go. So we would then be able to review them, administer the investigational products, monitor for their toxicities, and maintain their laboratory kits as well as their clinical notes, all within this facility. So in terms of IP storage, we have always been at war with the pharmacists, trying to actually get to put our drugs into their storage capacity. So for ambient IPs or even the cold chain IP. So, and this is basically a photograph to demonstrate the current fridge at the Onco Pharmacy in my building, right? And one of the solutions that we have been given with great help from CRC HKL was to use the fridge that is actually available in level 7 SCACC. So although physically disconnected from our building, we actually found this particular storage area to be very, very useful. And despite just storing our IPs, we also use the freezers to actually store some of our samples. So thank you very much to CRC for the continuous support. And we hope to have better expansion of these facilities in the future so that we can continue to store more investigational products, as well as have a better quality control of these products. So in terms of human resource, this is a breakdown that we have. I think we're quite lucky that we have got 9 principal investigators in-house at the moment, with 24 co-investigators, mainly from medical officers. We do encourage all our medical officers to actually go for GCP and get themselves actually qualified to do clinical trials. We do have 7 GCP qualified pharmacists and 7 non-GCP qualified pharmacists who are sponsor trained. We've got about 7 nurses who are trained by sponsor to administer oncology related investigational products, and we have got 9 study coordinators. So based on the current load, this particular human resource allocation is currently adequate, but of course with an increasing number of trials, these numbers will have got to expand as well. And we are doing our level best to continue to train and provide continuous medical education to ensure that the staff remains qualified to actually conduct clinical studies. So in terms of the solutions that we have actually had is that we have been including more and more our newer oncologists and our younger oncologists into new clinical trials. We have been continuously educating our medical officers on the importance of research and promoting them to actually enter GCP courses. And of course, if our medical officers in a department attend GCP courses, we actually reimburse their registration fee. For pharmacists, again, we provide them with continuous education and promote them to attend GCP courses. And we also reimburse their GCP course registration fee. For staff nurses, we attend them to attend GCP courses, as well as we encourage them to attend training by sponsors whenever a new study comes into our site, right? So what is the future of oncology research or cancer-related research in HKL? So this is, of course, a wish list, right? We hope that we could be able to establish a full-fledged clinical trial unit or a clinical trial department dedicated for cancer research, where it incorporates research office, consultation suite, pharmacy, reconstitution zone, as well as treatment area. So this is a cartoon representation that shows a complex that actually does all that right under one roof. Of course, having a clinical trial unit as a part of one of our second-class ward is definitely one step forward, but this is definitely not sustainable in the long run because we could only treat 4 patients at one go. So with more and more clinical trials and increasing complexity of oncology clinical trials, we'll definitely need a lot more space, and having a dedicated space to do clinical trials would be something truly advantageous. We are also looking into establishing a laboratory, because laboratory will allow us to actually invest into translational research, looking into the merge between basic research and clinical research, as well as create an avenue for us to actually start embarking on phase 1 clinical trials and first in human clinical trials, whereby there is already a lot of interest from sponsors as well as institutions overseas to actually approach us in Malaysia. We are also looking into better engagement with stakeholders. Of course, we are truly thankful for the engagement we have with Clinical Research Center, as well as Clinical Research Malaysia, CRM. We are also very happy with the engagement that we have with sponsors, and we hope that this kind of partnership will continue to exist. And we are one of the favorite spots for some of the sponsors to actually come to when they have got new trials that comes in. So that's very much elating. And of course, our engagement with the Ministry of Health, the continuous support that we have to actually run clinical trials. Besides that, we also have got very good engagement with the hospital management, hospital administrators, as well as private laboratories, private hospitals to help us run some of our specialized or specific investigations. So continuous as well as an upgraded engagement with stakeholders is something that we are already doing, and we hope it can be further enhanced in the future to come. So we also hope to generate more research questions, basically to promote more investigator-initiated research, and hopefully more publication and more presentation in the years to come. So with that, I would like to thank you. And if there are any questions, I'll be happy to answer.
Thank you so much, Dr. Muthukumaran, for your very insightful talk on how our clinical research influence our daily practice. So we have about 5 minutes for questions. Are you okay? Okay, so the first question would be, thank you, Doctor, for your insightful sharing from Dr. Ho. She's asking, any challenges to have double-blinded, single-blinded participants? And do you mind sharing it? That's number 1. Number 2, your thoughts on, from Dr. Karina, your thoughts on establishing a CTU or clinical trial unit in hospitals, and is it viable for each discipline to practice that? Thank you, Doctor.
All right, so thank you very much. So I'll probably answer the first question by Dr. Ho. Do we have the capacity to actually run a double-blinded or single-blinded clinical trials here in HKL? The answer is yes. It is a little bit more challenging, right? Basically, you need to have a separate team of pharmacists mainly, because we deal with a lot of drug-related trials. Whereby they are completely blinded for the rest of the team to make sure that the biasness is constantly maintained. So it requires a little bit of an administrative adjustment, We did struggle when we had our first double-blinded clinical study. Probably the double-blinded clinical study is a lot easier to do because it is actually blinded by the system per se, so everybody in the hospital doesn't know. But if it is a single blind whereby the investigator doesn't know, but then the pharmacist knows, the tend to be a little bit of an issue. So I think a great degree of professionalism is definitely required to make sure that the investigator continues to remain impartial towards the protocol, as well as the professionalism from that side of the pharmacist. So administratively, it has got to be figured out, but it is something absolutely doable, and we are absolutely comfortable to do double-blind and single-blind studies today. Right. So the second question from Dr. Karina with regards to the establishment of clinical trial unit. So there are basically two ways of doing that. So either the hospital in itself could have a single clinical trial unit. So this is what happens in the universities. So the model that I know is basically in PPUKM, whereby they actually have a clinical trial unit, which is accessible to the entire hospital. So anybody from any department, if they've got any clinical trial that is actually ongoing, they could actually access that particular facility. So the advantage of that is that your study coordinators, your research-related documentations, your research administrators are all there at one spot. So you basically come in as an investigator, and it becomes a one-stop center for all the help that you would need, right? Including nursing staff, including support staff, so on and so forth. But of course, in order to do that, it requires a great deal of commitment as well as investment, right? In the absence of that, then perhaps each department could actually develop and institute their own clinical trial unit, which of course will not be as robust as having a centralized clinical trial unit for the whole hospital, but yet allow the clinical trial to be run with a certain degree of structure. So which is what we have been asking for, and we have been working towards, and thankfully we have been able to establish. The other point to note is that I think you need to have a reasonable amount of patients to actually ongoing clinical trials before you actually start considering a CTU. So if you're just having 1 or 2 patients coming in on alternate weeks, I don't think establishing a CTU would be that much of an advantage. So we in oncology, we have got research patients coming in on a daily basis, right? And they're receiving investigational products at least about 3 to 4 days per week. And on every day, it's about 3 to 4 patients. So the number is quite significant. So that's why we thought that it will be an advantage to us. So I think it's an amazing facility to have. It's something that we should all aim for and work towards.
Amazing, Dr. Muthukumaran. I'd like to open up to Dr. Zulaiha Muda for if she wants to ask any questions. Dr. Zulaiha, we can see you raising up your hand.
Hello.
Hello, Doctor. Yeah.
Hello.
Yeah. We can hear you.
Can you hear me?
Yes, we can.
Hi, Dr. Muthu. Thank you, Dr. Muthu, for the excellent presentations. I think if I can gather, your presentation mainly cover ISR, right? More ISR rather than IIR. Okay. My first question is, do you have any difficulty or challenges getting consent from the patient to involve in this ISR, and what are steps that you use to overcome or to persuade them to join the research? My second question is, I always have a problem in answering the feasibility study. There is preclinical, because they will specifically ask the number of patients we want to recruit, what are the facilities we have. How do you go about give some guidelines in answering the feasibility study to make sure we are chosen as a site for the ISR? Thank you.
So thank you, Dr. Zulaiha. So the first question on the consent. So is it difficult to obtain consent from patients? So in our experience, I think the informed consent process is always very individualized and definitely very challenging. So different patients have got different expectations. So majority of clinical studies that we do are, of course, ISR, and they are actually interventional. So we are actually comparing one treatment to the other treatment. And one of the most important things we tell them upfront is that you cannot choose which arm you actually get into. So if you are randomized and you end up in the control arm, it is going to be control arm and you should not back out. So I think the information that is being given to patients at the informed consent process is absolutely important. Majority of our patients, I would say close to about 70% of our patients would usually agree and they would actually follow on with whatever that we say. Another 30% may actually decide to think about it, and some of them may actually choose not to have it. So I think if we are absolutely honest in our explanation to patient and very frank about the outcomes as to what is likely to be expected, I think we would be able to segregate these patients much earlier. So if you are able to then identify those who would be on board with you for the trial and those who are not on board, then I think the entire process of consenting becomes a lot easier, right? And there's no easy way and there is no method to do an informed consent process. So it's always very challenging. I usually spend quite a lot of time doing that. And we do find that the amount of time that invested in that process is very, very rewarding, right? Because at the end of the day, you don't want to actually go through the process and a patient agreeing half-heartedly and subsequently disappearing, which again has happened. And we had to write long explanation to the sponsor as to why we even recruited that patient in the very first place. Right? So the second bit is regards to feasibility. Yes, feasibility is another different side of a concern in a lot of sense. They do ask a lot of very weird questions, right? And they also ask for things that we do not know and that we do not have control over. For example, now they're asking us a lot of information on biomarkers. You know, how many of your patients have got KRAS mutation in lung cancer? So I'll be staring at the papers like, we don't do KRAS for lung cancer. How am I supposed to know? So in the initial phases whereby we were replying feasibilities, we had a lot of trouble. What happened was over the years, I think we had then developed a template. For example, if we're being approached for lung cancer or for urothelial cancer or for breast cancer, I think most of the time we actually have quite a bit of the basic numbers in hand. Of course, this happened with years as well as with experience, as well as with the help of all my colleagues to actually establish that kind of a thing. So today, my study coordinators would actually be able to put most of these numbers in. But in a situation whereby we are asked questions that are actually we have no answer for, my general experience is I'm usually very honest in telling them that I actually do not know, right? But then we do tell them that if you want to select HKL as a site to actually do your study, we will try our level best to look for these patients, but that there is no means for me to actually tell you how many patients can actually come by. So sometimes with that kind of a very honest reply in the feasibility, we have been rejected quite a number of times. And there were some times that we were actually accepted. And through acceptance, we have also been able to outreach the target that was actually given to us for one of the rare lung cancer studies that we actually have at hand. So again, it is a process. You will need to gather the information over the years in order to answer it. And yet there will be times whereby we will not be able to answer it, and the best way to go about it is just to be honest. So I would rather be honest than to actually give them a false hope as to what happens, right? Our realization is that although we know that a certain intervention is really good and really nice, and some of the studies are very, very attractive, there is always more and more feasibilities that will come our way, knowing that HKL is definitely a research hub. So if this goes off our hands, there will definitely be another one that is coming in and that we will be considered for to actually run these trials.
Thank you very much, Dr. Muthukumaran, for pioneering this era in research. We will close questions now. Thank you again, Dr. Muthukumaran. Let's move on to our next guest speaker. Our third speaker for today is Ms. Audrey Uy, and she will be speaking on the potential of industry-sponsored research in Malaysia. Before that, a brief introduction on Ms. Uy. She has a various 8 years of experience in our clinical research industry in Malaysia. Currently, she is the Head of Business Development in Clinical Research Malaysia, CRM. She's also the part of the Program Committee and Session Chair for DIA Singapore Annual Meeting. She's also part of the Technical Working Group for Cell and Gene Therapy Products. Besides that, she has been active as being part of the Technical Committee member for Bioequivalence Center of Hospital UITM, and also part of the National Vaccine Development Roadmap Technical Working Group. Impressively, she has received the prestigious CRM CEO Award in the year 2017. So let's give a warm welcome to Ms. Audrey Ooi for her next presentation.
Hello and a very good morning to all of you. It is a pleasure to be speaking to you today in conjunction with the 5th Hospital Kuala Lumpur Research Day 2022. My name is Audrey from Clinical Research Malaysia, and today I will be speaking to you on Malaysia's potential in industry-sponsored research. I believe most of you have already known about Clinical Research Malaysia, but perhaps for the benefit of those who have not really heard about CRM, please allow me 5 to 10 minutes to briefly walk you through the establishment of CRM and the work that we do in the clinical research industry. So CRM was formed way back in 2012 when the government of Malaysia, under the Healthcare National Key Economic Area, identified clinical research as one of the entry point projects that would be able to contribute more largely towards the economic growth of the country. And hence in 2012, they have corporatized Clinical Research Malaysia, which is now fully owned by the Ministry of Health. And in 2019 and 2021, respectively, CRM received the ISO Quality Management System, as well as the Anti-Bribery Management System, in line with our objective to be a globally trusted research management organization, and to really create that trust and confidence in the clinic, among the clinical research stakeholders locally as well as globally. So what we do in CRM is we facilitate industry-sponsored research in the country, as well as to drive the clinical research agenda forward. Our main vision is to make Malaysia the preferred destination for clinical research within the region. And mission-wise, we want to create a value proposition in conducting clinical research by attracting more sponsored research into the country. In line to be a global trusted research management organization, we have also thus embarked on obtaining the accreditation of the ISO 9001:2015 as well as the ISO 37001:2016. And finally, in order for also the company to achieve self-sustainability, we have also introduced several new services to the clinical research industry players in the last year to really create new revenue streams for the company as well. So very briefly on CRM Board of Directors. Our Board of Directors is chaired by the Minister of Health himself. And under CRM's Board of Directors also sits the senior officers of the Ministry of Health, namely the Director General of Health, the Deputy Director General of Health. We also have key opinion leaders from the pharmaceutical industry as well as from the university hospitals and the private healthcare hospitals as well. And this really speaks about CRM's agenda to really create a very comprehensive and sustainable clinical research ecosystem across the Ministry of Health, the Ministry of Higher Education, as well as the private sectors, in order to drive clinical research in the country. So this slide basically shows the role of CRM even before a clinical trial is being awarded to a country. That means before a clinical trial is being conducted. Perhaps a lot of you have already known about the role of the clinical research centers, which are fully established and set up in most of the major public hospitals across Malaysia. So the CRC facilitates and supports the Ministry of Health investigators at the hospitals in investigator-initiated research. But when it comes to industry-sponsored research, that means a research that is being funded wholly by the pharmaceutical industry or the biotechnology or medical device companies. This is where CRM steps in as a one-stop center to facilitate sponsors and CROs and to make that necessary connection to the clinical research sites within Malaysia regardless of whether it's within the Ministry of Health or the university hospitals or the private healthcare facilities. So when it comes to know whether Malaysia would be able to carry out a clinical research, this is where CRM provides that consultative and advisory services to the sponsors and CROs in terms of providing information on the processes and the regulatory submission process to the sponsors and CROs, or when it comes to reviewing non-disclosure agreements. CRM also does that, especially on behalf of the Ministry of Health sites. And when there is any inquiries with regards to the clinical trial budget, CRM also facilitates in the sense that we do provide an estimation of the budget that is required to, or the costing that is required to conduct a clinical trial based on the protocol that is shared by the sponsors and CRO. But most importantly, within CRM, we have a very extensive database of investigators as well as trial sites that have that experience in the conducting clinical research, with investigators that are good clinical practice certified. And with this extensive database that we have, we are able to provide the feasibility outreach as well as the feasibility services to the sponsors and CROs in identifying the right investigators and the right sites based on the protocol that the sponsors and CROs have in hand. So within Malaysia itself, we have more than 140 public hospitals as well as clinic kesihatan that have experience in conducting sponsored research, 11 Ministry of Higher Education hospitals, 62 private hospitals, as well as more than 1,000 investigators that are GCP certified in multi-therapeutic areas. So we are able to provide this very important information back to the sponsors and CRO for them to really decide if Malaysia would be able to conduct this the clinical trial. And once the sponsors have decided that yes, Malaysia has the necessary facilities, we have the necessary patient pool as well as interested investigators who will be able to take up the specific study protocol. Clinical Research Malaysia ensures that the studies are conducted with speed, quality, and reliability. So one of the main services that we provide, especially in supporting the investigators at the trial site, is by providing training as well as placement of qualified study coordinators at the various Ministry of Health facilities throughout Malaysia. And our study coordinators play an important role in supporting the investigators in their day-to-day activities, such as data entry or certain study visits that is required, and also setting up of the patient, the clinical trial patient appointment as well. But over and above that, within CRM, we have our legal department that reviews all clinical trial agreements or contracts for that matter on behalf of the Ministry of Health sites to ensure that clinical trial agreement review are conducted, and it is being done without any necessary delays or bureaucracy as well. In addition, CRM also provides the support of managing the clinical trial budget and to ensure that the relevant reimbursement is provided to the patients, but also the necessary payments is channeled to the investigators as well as the relevant labs and as well as hospital administrative purposes. So we ensure that the trial budget is being handled in a very transparent manner. And finally, at CRM, we have recruitment officers that helps in coming up with strategies for patient recruitment, especially in studies where recruitment will be a challenge as well. So in that sense, the responsibilities of the sponsors and CROs are mainly in providing that necessary submission dossiers to the regulatory authorities, either to NPRA or MDA, to obtain the approval to conduct the clinical trial, as well as one of the major service that the sponsors and CRO does is in terms of monitoring the whole clinical research activities to ensure that the study is being carried out according to the good clinical practice, as well as conforms to the relevant protocols in which the study is being carried out. And finally, there are also several project management activities that are also taken up by the sponsors and CRO. So the sponsors and CROs they are mainly the main drivers in study monitoring, as well as handling of the submissions and approvals of the clinical research, whereas Clinical Research Malaysia acts more as a site management organization that really facilitates the clinical research sites and investigators by providing that the relevant finance management, as well as legal review services and study coordinators placement to support the investigators at the various trial sites within Malaysia. So this slide shows where CRM study coordinators are placed. So you can see that they have the presence at all states throughout Malaysia, and they are pretty much based in sites depending on the number of clinical research activities that are ongoing at that site. So in 2012, when CRM was established, we started off with about 22 study coordinators, and over the years there was a lot of requests, as well as the need to grow CRM study coordinators to support the investigators with the increasing number of industry-sponsored research that is coming into the country. And hence we have grown from 22 to 150 study coordinators in 2021. So CRM, basically we do place most of our study coordinators in the Ministry of Health sites, majority in the public hospitals. But we also do have our study coordinators also supporting the private hospitals like Pantai Hospital, as well as the university hospitals for that matter. Now moving on to the core presentation today, which is on Malaysia's achievements and potential in sponsored research. Last year was a really good year for the clinical research industry, in that it has recorded a total of 226 million in contract worth of clinical research, which came to a cumulative value of over 800 million in gross national income since 2012. So this is one of the highest number of clinical trial contract values that was recorded since CRM's establishment, and I think it is also a testament of the confidence and the trust from the clinical research industry, especially the sponsors and CROs, on Malaysia's potential to deliver well and provide quality data for their clinical trial. There was also about 2,291 skilled jobs within the clinical research industry that was created, both in the private sector as well as the public sector, and a total cumulative value of 1,806 sponsored research since 2012. So we see that there has been a good growth in terms of sponsored research in Malaysia in the last 2 years, especially during the times of pandemic. And it really shows that, despite the pandemic, clinical research continues to increase, not only within Malaysia, but also globally. There are a lot of research being done on infectious diseases, especially in the area of COVID-19, as well as its treatment and vaccines as well. So a little bit more information on the distribution of sponsored research in the 3 different sectors Last year, there was 66% of the clinical trial protocols that was conducted in the Ministry of Health facilities, 24% in university hospital, and about 10% in private centers. So we see that clinical research in Malaysia cuts across the three main sectors: public sector, the private sectors, as well as Ministry of Higher Education, university hospitals as well. And we see that there is also a good growth within the university hospitals, particularly UMMC and HQKM, who has been doing a lot of research activities work in the last three or 4 years. That being said as well, I think there were also a lot of new sites within the Ministry of Health facilities, especially in Klinik Kesihatan, when it comes to conducting new studies, especially in the areas of COVID-19 related studies. Private centers, most of them, they do conduct mostly in oncology clinical trials, because I think that is, if I can bring you to the next slide as well, there has been also a good growth in terms of the number of oncology study last year. But nevertheless, I think because of the pandemic, I think it's no surprise that infection and infectious diseases clinical trials have also seen a rise. So slightly more than half of the infectious diseases clinical trials are in COVID-19, but also there are also other infectious disease studies that is still being carried out, such as HIV, RSV studies, dengue, hepatitis B, as well as malaria studies in this therapeutic area. Of course, in the last 5 to 10 years, oncology study has seen a rise, and we see that number increasing year in and year out in Malaysia, because there's a lot of R&D going on, and the pipeline of oncology drugs in the pharmaceutical companies have also resulted in more and more clinical trials being conducted in this area as well. But mainly this graph goes to show that Malaysia has also that opportunity to have that capability to conduct clinical trials in various therapeutic areas, from rheumatology, urology, orthopedics, psychiatry, and so on and so forth. So it is a very diverse range of therapeutic areas in terms of sponsored research that is conducted within the country. Just a little bit on the breakdown of the types of sponsored research. So in 2021, we had a total of 215 industry-sponsored research, and about slightly more than half of it are interventional in nature. And from the interventional studies, about 71 of those studies are studying the drug or new chemical entities. 24 of the studies are of biologics or biosimilars in nature. 7 medical device trials, 6 vaccine trials, 5 traditional supplements, 3 procedure trials, and 1 gene therapy trial, which is a CAR-T trial. And a little bit more on the phase breakdown, we see that the majority is always in the phase 3 studies that we have been conducting. This is followed by phase 2, phase 4, bioequivalence, bioavailability, as well as phase 1 studies. And also like to show you the top sites that are awarded with sponsored research in 2021. Again, congratulations to Hospital Kuala Lumpur. I think it sits on the 3rd position after University Malaya Medical Center, as well as Hospital UKM Chancellor Tunku Muhriz. And among the Ministry of Health hospitals, Kuala Lumpur hospitals has the highest number of sponsored research that has been conducted last year. So congratulations to the team at Kuala Lumpur Hospital for committing to the number of studies, as well as really performing very well in terms of sponsored research. So if we can really also take a look at the type of clinical trials that are conducted in HKL in 2021. Majority of it are in oncology studies. And I think that has been the case in the last few years as well. We have seen that the clinical research team and investigators at Hospital Kuala Lumpur has been very active, especially in oncology trials. This includes trials on solid tumor, colorectal, ovarian cancer, breast cancer studies. So again, congratulations to the oncology team. But also, I think the other teams in dermatology, nephrology, psychiatry, cardiology, urology, infectious disease, as well as genetic disease studies are also coming up. And I think there's a lot of work being done as well, and achievement by the research and investigator team at Hospital Kuala Lumpur. Again, here I'd like to point out on the recruitment achievement in global sponsored research last year. Dr. Muthu has been recognized by sponsors as one of the global top recruiters in the non-small cell lung cancer. So I think it's a really good achievement and acknowledgement by the sponsors, because not only is the research team at HKL be the top recruiter in the region, but globally, they are the global top recruiters for the non-small cell lung cancer. So congratulations to Dr. Muthu and his clinical research team at HKL. And I think this really speaks about our investigators' commitment and their capability to really conduct and perform well in global multi-center studies, especially studies that are really difficult in recruitment as well. And I think it is a very important testament again to also build the confidence of sponsors and CROs on the capability of Malaysia in delivering global studies with really good achievement rate, as well as the quality of the studies as well. So we also do see other investigators in other smaller sites like Hospital Sri Manjung and Hospital Tuanku Japa, who also have achieved a very good achievement globally as well as in Asia Pacific. And this type of acknowledgement by the sponsors and CROs is very important, to make Malaysia stand out as one of the preferred destinations for sponsored research within the region, if not globally. I'd like to also show you on the breakdown of study phases from 2015 to 2021. You can see that again, we have been doing a lot of phase 3 and phase 2 studies, but we don't see much on phase 1 studies coming into the country. We have not done a first-in-human drug study previously. I think last year we did a first-in-patient study, which is the closest that we can get to first-in-human. But with regards to the ability and the capability of Malaysia in attracting more phase 1 studies, this is something that is a work in progress. I think if you have heard about the phase 1 realization project, it's an initiative that was launched by CRM way back in 2016 to really build a comprehensive early phase research ecosystem within the country through our 5 key pillars in establishing a phase 1 clinical trial guideline, developing our people as well as the capabilities, conducting early phase research, preparing our phase 1 sites as well as risk management. So this is a little bit of a busy slide, but I just want to show you some of the initiatives that has been rolled out and that has borne fruits over the years. The phase 1 realization project has come to a conclusion last year with all the 5 key pillars being achieved. So firstly, in terms of the guidelines for phase 1 clinical trial, it has been developed and launched in 2017 and sets a basis for the industry to really have that guidance documents on how it is to conduct an early phase study in Malaysia. That said, also we have invested in people development in early phase study, especially in sending the NPRA officers to postgraduate studies to really expose them and to build up their knowledge in early phase research within their attachment at very renowned early phase cancer clinical trial unit in the UK. That said as well, I think we have also sponsored one of our investigators to attend a clinical fellowship attachment training program at University of Toronto, which is attached to the Princess Margaret Cancer Centre, which is one of the top 5 cancer research centers globally. And I think this has worked also very well in the sense that last year we have received our first inpatient study, and it has been conducted in Sarawak General Hospital and has achieved the global first recruiter for that study as well. In terms of capability development, CRM has also established a scientific review panel that consists of national as well as international experts in early phase clinical research to support the MREC in reviewing first-in-human clinical trials. So I think moving forward, this is something that we have established for the conduct of early phase studies, especially first-in-human studies, and we hope to be attracting more early phase studies in Malaysia moving forward. Also, just a little bit more information on the board of sponsors and CRM that have been engaged with CRM and Malaysia as a whole to really bring in more clinical research into the country. And last year, we do see a lot of engagement with sponsors, mostly on Malaysia's capability in conducting COVID-19 vaccine and treatment studies. And as a result of it, I think last year was the first time that Malaysia has moved up the leaderboard to being the 2nd place within the region in terms of the number and volume of industry-sponsored research. So Malaysia has been, in 3rd position since 2012 to 2020 after Singapore and Thailand. But last year we did see quite a very steep growth in terms of the clinical research that has come into the country, and hence I think we have been also moving very progressively in attracting more and more of such clinical research in various therapeutic areas to be conducted in the country. And as we attract more sponsored research into the country, I think it's also very important and equally vital to grow that pool of investigators in Malaysia. And in growing the pool of investigators, I think CRM, we have also conducted several initiatives to attract new specialists to embark on the clinical research road, but also to provide support and facilitate our current investigators, especially in the Ministry of Health, understanding that clinical service is always their main work. We try to also support them in terms of industry-sponsored research, so that they are able to take up more clinical research under their arms as well. So services like providing a review for clinical trial agreements as well as non-disclosure agreements, managing the clinical trial budget on behalf of the investigators, providing trained study coordinators at the trial sites so that they will be able to support the investigators in their daily clinical work, clinical trial work as well. So all of this is a very important support to facilitate our current investigators in the Ministry of Health, because we understand that they have a very important role to play, both in clinical service as well as in clinical research as a whole. So I think this goes to my last slide. I think it's very important values that clinical research brings to the patients, the country health, to the nation's healthcare, as well as to the country as a whole. Clinical research provides that access to innovative treatment as well as treatment options that are of potential, especially to patients in which they have not been responding well to the current standard of care. But most importantly also, I think it creates job opportunities within the industry as well as contribute to the gross national income of the country. So with all those factors in place and all the achievements that Malaysia have achieved in the last few years, I think Malaysia definitely has that potential to excel in global clinical trials and be the preferred destination for clinical research within the region. So with that, I thank you for your attention.
Thank you so much, Ms. Audrey, for your very insightful and interesting talk on the potential of industry-sponsored research in Malaysia. We are very honored to have you here today. However, Ms. Audrey, probably a bit about ISR because you want to move to the next presentation, our oral presentation. Yeah.
Sure.
And anything that you would like to say before we move on to the next?
I see. I think there was a question.
Yeah,
I think there was a question from Dr. Karina on how to grow the number of investigators, especially in areas.
Okay, probably just one question. Yeah. Okay.
Yeah, if we can pick up Dr. Karina's question, if that's okay.
Yeah, probably we can spend 1 minute on it.
Sure. Yeah. All right. So I'll just quickly address the question on growing the potential pool of investigators in therapeutic areas that are not much active. So this is something that CRM has also been doing every year. We have a seminar called Nurturing New Talents to really attract new doctors, new specialists to take up industry-sponsored research. And what we have in this seminar is that we also have one of the experienced investigator to share his experience in conducting clinical research, and hopefully, our existing and experienced investigator will be able to, share their knowledge and experience and how they go about conducting this research. And hopefully, it creates more sort of like a motivation to young doctors to take up clinical research as a whole. So I think this kind of seminar, we have been doing it throughout Malaysia. Of course, because of the pandemic, we have resorted to a lot of virtual webinars. But that being said as well, I think we did receive quite a good response from the various hospitals in which the seminars is organized. And hopefully this will result in more doctors being involved in sponsored research, or whether if it's even in investigator-initiated research, is something that is a good outcome of this seminar as well.
Okay, thank you very much. It's an excellent effort on CRM's part. Thank you again, Ms. Audrey Uy, for your presence and your presentation. Thank you so much. Now we move on to our highlight of today, which is the oral presentation session. With this, I shall pass the stage to Dr. Raj Kumar from our Scientific Committee of Research Day.
Okay, thank you, Dr. Aina. A very good morning to all distinguished guests. We now move on to the next agenda, which is the oral presentation competition. This year, we received a total of 128 abstracts. Out of the submitted abstracts, the scientific committee has approved 76 posters, 29 from research abstract and 47 from case report abstract. The top 5 research abstracts were selected for the oral presentation competition. Before we proceed for the presentations, I will first introduce our honorable judges for today. We have Dato Dr. Suhaini Kadiman, a senior consultant and the head of anesthesiology in Institute Jantung Negara, and also the director of clinical research, IJN. Secondly, we have Professor Dr. Sanjay Rampal, a public health medicine specialist and professor of epidemiology at the Department of Social and Preventive Medicine, Faculty of Medicine, University of Malaya. He is also the Deputy Dean of Research for University of Malaya. And last but not least, our head of judges, Dr. Saiful Matsani, a consultant physician in acute and internal medicine at Department of Medicine, Hospital Kuala Lumpur, and also the Deputy Chairperson for Hospital Research Review and Research Committee, Hospital Kuala Lumpur. So welcome to our esteemed judges and our honor. It is our honor to have you here. Before we begin, let me read you some of the house rules and regulations for today's oral presentation competition. Each presenter is given a total of 7 minutes for your presentation. At the 6th minute, the bell will be rung once and twice at the end of the 7th minute. There will be then 5 minutes of question and answer session from the judges. I will notify the presenter and the judges whenever we have reached the given time limits of 5 minutes. All presenters and judges are reminded to keep to the time allocated. Now, without a further ado, we will proceed with our first presenter, Mr. Lai Po Son from Forensic Department HKL, with the research entitled Morphometry of Foramen Magnum by using post-mortem computed tomography, PMCT, for discriminant analysis of sex and ancestry among Malaysian population. The floor is yours, Mr. Lai.
Population. I'm Lai, forensic scientist at the National Institute of Forensic Medicine of HKL. For your information, it doesn't work. Sorry for the technical issue. A very good morning to panel judges and participants of the research day. Today, I would like to share my experience in my research entitled Morphometry of Foramen Magnum by using PMCT for discriminant analysis of sex and ancestry among Malaysian population. I'm Lai, a forensic scientist in the National Institute of Forensic Medicine in HKL. For your information, PMCT is only available in HKL throughout the country with 64 multi-slice helical kernel. The application of PMCT is useful as a strong adjunct of the routine autopsy and for 3D virtual reconstruction of skeletons and etc. In this domain, it opens a new field of research called virtual anthropology. The advantages of CT scan is non-invasively performing the biological profiling, including sex, ancestry, age, and also stature estimation without the necessity to deflash the bones. From my experience in this type of cases, it would take up to a few days or few weeks to deflash the human remains into the dry skeletons. Non-metric traits may be subjective and observer dependent as compared to morphometric measurements. Of all predictors, the skull has been extensively used in sex and ancestry estimation. These are examples of non-metric traits for sexing purpose, and these for ancestry estimation. These are the examples of morphometric measurements between the landmarks on the skeletons for sexing purpose, and this for ancestry estimation based on the cephalic index and facial indexes. These are the list of existing morphometric methods used in HKL, mostly based on the US population, and the nearest would be the Thai population data. Thus far, the baseline data in Malaysia is very lacking in the literature. So that's important to account for inherent population variations, such as genetic and environmental factors. What if only the cranium is found at the scene? According to Ibrahim et al., 22 parameters of Malaysian cranium had demonstrated sex classification accuracy up to 86%. Therefore, we use a foramen magnum as the parameters in this research due to its protected location and stable morphology. The general objective is to generate population-based reference value for sexual dimorphism. The first and second specific objective were discriminant analysis of sex and ancestry, respectively, from the morphometry of foramen magnum using PMCT images. All the postmortem cases with known biological profiles since year 2015 were included, with total sample size of 300 by retrospective convenient sampling, archived from the PMCT images available. Those skull-based with fractures and abnormalities were excluded. These are the sampling distribution of this study, and these are the technical specification and operational imaging performed in this research. The DICOM images were viewed in MPR and measured using infinite healthcare system. These are the landmarks and definition of FMAPD and FMTD used throughout the research. Anterior posterior length is measured used from bastion to opisthon at the mid-sagittal plane, and the transverse diameter is perpendicular to it. These are the statistical analysis used in this research, including independent t-test, ANOVA test, multivariate analysis, discriminant function analysis, and cross-validation to determine the accuracy of the classification of those discriminators. So we have obtained MIEC approval since November 2020. So for objective 1, the result shows males have relatively larger foramen magnum than females, with difference of mean values at 1.03 millimeter for transverse diameter and 1.36 millimeter for AP diameter. There were substantial significant differences of transverse diameter and AP diameter between sexes within the respective ancestry, with AP diameter better than transverse diameter at sex discriminator. The interaction of both parameters has achieved better sex discriminant function at 60% moderate accuracy. These are the canonical discriminant function of sex with female less than 0 and male more than 0. For objective 2, the result shows Chinese has generally larger foramen magnum than Malay and Indian. There were relatively significant differences of both parameters between ancestry, especially Chinese versus Indian. However, there was no significant interaction of sex and ancestry confounders based on both parameters. The transverse diameter became stronger discriminator than AP diameter based on discriminant function analysis. However, the interaction of both parameters only achieved at low accuracy of 40.7%. These are the discriminant function of ancestry. So in our pilot study, there were non-significant intra-observer errors, but relatively low significant inter-observer error. Hence, observer training was given by the forensic radiologist to standardize the angle adjustment. So more importantly, quantitative morphometric assessment were less inclined towards subjective variability as compared to non-metric traits. So we concur with Santos et al. That there were significant differences between sexes within the South Indian population. So literature also shows morphological difference between sexes may exist between different populations. So population variability further reinforced by the Gaudemes et al. That foramen magnum dimensions of Central Europeans are greater in Middle Easterns and South Americans. So in conclusion, this study has shown both parameters could be potential discriminators in sex estimation at 60% as compared to ancestral estimation at 40.7%. So we did further our study to include the parameters from mid-facial bones as shown in the diagram, and the result achieved 75% as compared to earlier for sex estimation and it's improved to 75.7% for ancestry estimation. So these are the references of my study, and we encourage those researchers involved in this research. Thank you.
Thank you, Mr. Lai, for the presentation. So I would now like to invite the judges to begin with the Q&A session. Judges, over to you.
Dr. Lai? Yeah. Okay, my one question is one thing. You use discriminant analysis to figure out number one, the gender, and number two, the ancestry. Yeah. And you had 300 in terms of your sample size. Yeah. So did they satisfy normal distribution?
For both parameters of foramen magnums, including the FMAP and the transverse diameter, both satisfy the normally distribution.
Lai, for your presentation. Very, very interesting. Preliminary, but very promising. I have 2 points. I'll start with 1 point first. With regards to ancestry, you're using self-reported ancestry, right? So the anatomical makeup of a person is determined by the genetic makeup, and there's diversity in the genetic makeup. How accurate is self-reported ancestry to represent the genetic diversity of the populations in your sample?
Randomize those sampling from the post-mortem cases, and we did equal distribution of the sampling as well according to the ethnicities and also gender of this research. So when there is a balanced sample, so we are tends to unbiased in the sampling as well in terms of genetics as well.
I was getting at is we are categorizing ethnicity into 3 subgroups, whereas more likely the genetic variation or diversity is a combination of the 3 rather than distinct into the 3. Thank you.
Dr. Lai, thank you very much for your presentation. Something that is very interesting. My question is, how do you reckon your 300 samples is powered enough for you to generalize into the Malaysian population?
Actually calculates based on the sample size of the population and by using the online sample size calculator. So actually, in fact, the calculator mentioned about 330. So, but in order to balance out the sample size, so we take it up to only 50 for each groups. That means 50 for Malay, Chinese, and Indian, and for both sexes.
And those power calculation were based on which parameter? What I mean is that which parameter you use as the determinant of the significant difference for you to calculate the power analysis. Any specific parameter you choose?
Within the total total population of the Malaysian, and then it will calculate for us how many total sample size would be
Understand.
For
Thank you very much.
Okay, thank you, Dr. Lai, and thank you, judges, for keeping to the time. So we will move on to the second presenter, Ms. Sardiana Sarmidi from ONG Department Hospital Tunku Azizah, with the research entitled Pro-Fertile as the Antioxidant Supplement for Men with Oligostenoteratospermia OAT at Reproductive Medicine Unit, HTA Kuala Lumpur. Are there any positive effects on their sperm quality? Ms. Sardiana, floor is yours.
Assalamualaikum. Assalamualaikum and very good morning to all judge. And my name is Sardia Samidi and I would like to present my study titled Profitil as Antioxidant Supplement for Men with Oligoasterotrozoosmia at Reproductive Medicine Unit, HKL Kuala Lumpur. Is there any positive impact on their sperm quality? And this study collaborate with also authors from different institutions in Malaysia. Okay, as we know that male fertility is on the rise and becoming a serious public health issue when sperm quality has declined over the past 15 years. And instead that nearly 25 until 30% of cases of infertility are due to a male factor only in worldwide. And based on LPPKN data from 2010 until 2019, 75% were carried out for male infertility problems due to the abnormality in sperm production and infection due to the varicocele. And then oxidative stress may be the cause of sperm quality of a decline, which is induced by reactive species, which we call ROX. However, a spermatozoa still require a very small amount of ROX to develop fertilizing capability, sperm capacitation, and regulation of sperm maturation. And high level of ROX can be resulted from occupation factor, environment pollution, infection, and lifestyle. Excess of RX cause a damage of cell and membrane, where the cell membrane, which contain a lot unsaturated fatty acid and easy can oxidize by RX. But cytoplasm inside the cytoplasm, sperm, they have a very small amount of enzymes that can neutralize RX inside the sperm. However, when lipid peroxidation happen, they can cause protein modification, DNA damage, sperm cell, and also cell apoptosis, and can cause reduced motility, sperm count, and also increase a number of abnormal small polyp sperm. Based on the concrete review, it states that antioxidant supplement in infertile men may improve sperm quality and reproductive outcome among couple undergoing RRT cycle. Majority of the previous studies show a positive relationship between antioxidant and improved male infertility. And in this study, we use Profitil as a combined supplement, which is contain 8 micronutrients, and this one, and then that are known to be helpful in boosting sperm production and activity, and of course can increase the sperm, can increase pregnancy rate. Okay, they have a 5 study have been done using Profitil, and all show all sperm parameters significantly improve after 3 months of Profitil treatments, and also leading spontaneous pregnancy. However, all evidence reported mainly in American and European, and very little in Asian population, especially in Malaysia. And surprisingly, no study has been done using Profitil as a combined micronutrients supplement on the framework study, especially in Malaysia. Hence, we aim to investigate a relationship between antioxidant supplement intake Profitil and sperm parameter in Asian men with oligoasterotrozoosmia condition. Okay, this is a single side retrospective. Around 92 infertile men and male meet inclusion criteria with at least 1 year of sub-infertility and range from 20 to 50 years, and 1 recent abnormal sperm analysis. and not receiving other treatment. We include in this study, which is 92 infertile men we serve as a treatment group. And for exclusion criteria, all infertile male partner with azoospermia, aspermia, varicocele, recent urogenital infection, patient with diabetes, a chronic kidney and renal disease, and taking hormone therapy or antioxidant supplement who are excluded in this study. And then around 103 infertile men are reserved as a control group. And segment analysis report before and after treatment, including the demography and baseline characteristic, were collected from our center from January 2016 until September 2021. And statistical analysis were performed using SPSS Vision 27. This is a framework on sperm analysis, but I didn't want to mention a detail about this. Okay, table 1 show all characteristics are not significant difference in both groups, which is control and treatment group, except age of husband, BMI of husband, and etiology of infertility. Table 2 show effect of fertility on macronutrient on sperm parameter. Okay, we can see we do not see or observe any change in more volume of sperm between treatment and control. However, according to pairwise comparison, P and P adjusted show the medium level of sperm concentration, motility, sperm progressive motility, total sperm count, total progressive motility shows increase significantly compared to control, which is before treatments. And moreover, around 24 of men with abnormal morphology sperm show improved significantly after receiving Profertil in 3 months. Actually, this graph show is the same thing, previous table actually, but we can see clearly based on the median level before and after treatments. And then here we can see clearly all parameters will show improve significantly after receive Profertil for 3 months except volume of semen. Okay, and additional normal morphology also show improve after on Profertil. Okay, and then in this, okay, on discussion, all these increment difference of 4 parameters occur due to each capsule of antioxidant. As I mentioned before this, they have 8 micronutrients, which is consists L-carnitine, L-arginine, zinc, vitamin E, glutathione, selenium, coenzyme Q10, and folic acid. And each ingredient has beneficial on sperm quality. Is therefore and recommended for potentially effective therapy for treatment of male infertility. Actually, I have another slide. The new one, is it the old one? Okay, and all resulted also cause a change of lifestyle habits such as reduction in nicotine consumption, because in previous studies show a significant increase in the number of abnormal sperm motility after nicotine exposure compared to control. So, and the second one, nutrients intake, for example, food such as barley, seafood, red meat rich in zinc. That's this kind of food can be included in our diet style to have a increased sperm count. And then the third one, physical activity. Previous study also have revealed higher physical activity and lower TV watching were associated with high sperm count and sperm concentration. And I want to add another extra our finding. After complete 3 months by consent Profertil, female partner underwent ICSI and did in the transfer, and then we found you found a 32 of biochemical pregnancy, and then 28% of clinical pregnancy, and live birth 24, which is reported in Profitable. In control group, just 28.9% of biochemical pregnancy, 23.6% of clinical pregnancy, and the live birth only 20%. So we can see the difference between treatment and control groups. So we successfully prove antioxidant supplement can lead the improvement in sperm parameter and helping couple with infertile male partner have the opportunity to have children by their own. Thank you.
Thank you, Ms. Sardiana. So, judges, over to you. We can proceed with the question and answer session.
Thank you very much for the nice presentation. Can you discuss briefly what is the potential bias in your study?
Thank you for the question. Actually, I'm not doctor. I'm official science officer. I work as embryologist in embryology lab. Okay. What a potential bias in my study is because it's a retrospective study, so you cannot control the what there is it there is it for especially for the control study. Especially for a control study, is it there? Is it correct? They didn't do any exercise. You know what I mean? Yeah, because it's a retrospective. You just based on the what they say. Yeah, it's a different when it's a prospective study. We control from the beginning until in the end, but all the data I just extract from the medical report and the list exactly. Yeah.
You are right in mentioning that selection of the control group is very important because you're comparing between the two groups. And if you did not select the control group right, then this might lead to a misleading conclusion. So is there any criteria that you use to select the control group? Anything, or you just take anybody that is not on the treatment as your control group?
As I mentioned before this, infertile men with a critical health issue such as azoospermia is the mean they have no at all sperm in the ejaculated semen, and then of course aspermia, which means nothing at all, and a varicocele, which is because on high infections, and of course diabetics, which can give very critical outcome on the sperm parameter. So I try to exclude this kind of criteria. And of course, I want to make sure they didn't take any antioxidant, even though it's single mononutrients.
For your presentation, very interesting study. A lot of work has gone in. Just to number one, reconfirm. So at 3 months, you saw a higher, more positive results with sperm properties for the Profitable compared with the control, right? Were the differences in Profitable before and after higher than the differences in the control before and after?
I'm so sorry. I didn't count I didn't count a baseline on control groups. I'm focused on Profitable group who before they start consume Profitable, and then 3 months after they complete the treatments. Yeah.
So there was no measurements for control at baseline?
Yes, correct.
But there were measurements at 3 months?
Yes, correct. Just for 3 months. But actually, there is one of my objective because another objective I need to find out the outcome based on the embryology part, mean fertilization, quality embryo, blastocyst, and of course, pregnancy and outcome.
Thank you.
Thank you, Puan Sardana. Now, you mentioned at the end of your discussion verbally that there were some pregnancy outcomes, but I didn't quite catch whether the results were truly statistically significant. Were they?
That until that point, yeah, because I still have a long journey, yeah, because I still have another 2 patients ongoing pregnancy. So I will do a complete statistician, whether it's significant or not after all pregnancy, yeah, until live birth, something like that, yeah.
Okay, thank you, Ms. Sardiana and the judges. Before we move on to the third speaker, a gentle reminder to the presenters, please adhere to your time limit given, which is about 7 minutes. So the first bell will be rung at the 6 minute, the second bell will be rung at the 7 minute. So without further ado, the next participant, please welcome Ms. Chang Shok E from Pharmacy Department HKL with the research entitled Development and Validation of a Pharmaceutical Assessment Screening Tool, PAST, to prioritize the provision of pharmaceutical care by the pharmacists at general medicine wards in Hospital Kuala Lumpur. Please welcome Ms. Chang.
Hello. Hello. Oh, so now it is already okay. Okay, hi. A very good afternoon to all the panel judges and the audience in Zoom. Today, I will be presenting on my study titled The Development and Validation of a Pharmaceutical Assessment Screening Tool, abbreviated as PASS, to prioritize the provision of pharmaceutical care by the pharmacists at general medical wards in HKL. Yeah. So we know that clinical pharmacists play a diverse roles in the ward. We join patient rounds and review patient medications, answering queries, do TBM, counseling, and many other tasks. Many papers have shown that clinical pharmacists play a major impact on a great impact on patients' outcomes. Pharmacists can help in early identification of drug-related problems, ensuring a cost-effective treatment, improve patient adherence, and etc. However, clinical pharmacy service are not without challenges. We often face challenges such as limited staffing in the ward service, and there is a high patient turnover in medical ward, and hence with a higher demand for clinical pharmacy services such as medication counseling. And while ward pharmacists are multitasking to meet the ward demands, there is often a lack of guidance on how to prioritize patient care and manage their time effectively. This is a global issue, and our study aims to tackle this problem. So here's our research question. Is there any PASS tool that can help clinical pharmacists to prioritize patient care? And hence our objective is to develop and validate a PASS tool to assist clinical pharmacists in general medical wards to prioritize patients and to review patients with higher acuity. Our study involves in 2 stages. So for the stage 1, we developed the PASS tool by conducting a literature review on the current public screening tools. This is followed by a rigorous group discussion to draft out the PASS tool suitable for medical wards pharmacists. And then we proceed to the validation of PASS, and this involved a 3-round Delphi survey. Our study population is experienced pharmacists from HKL, HTA, and IPR who have master or PhD in clinical pharmacy and with a working experience of 7 years or more. So we have set our Delphi questionnaire in the Google form, and experts were given a 2-week period to rate the relevance and completeness of each criteria using the 5-point Likert scale. Relevance is to check whether the criteria content are essential for the practice, and also completeness is to check whether the criteria contains all the necessary information. There are open-ended questions at the end of each criteria to allow for expert feedback, and the results would be anonymized and compiled, then sent back for expert reviews before proceeding to the next Delphi round. So we have just used descriptive statistics for our statistical analysis, as we have set the benchmark of consensus at 75%. This means that a criteria is retained or may be unmodified in the past when more than 75% of experts rating agreed or strongly agreed for that criteria. This is our research timeline. So we have conducted this study for the past 1 year. So here come to the results part, our expert demographics. So 24 pharmacy experts have joined our studies. 22 of them has master in clinical pharmacy, while 2 have PhD. And more than half of our experts actually have at least 8 years of working experience in the clinical pharmacy unit. So this is the past version 1, which we developed from the stage 1. Let's have a look. So we called it initially as hot gems. So it contains 7 criteria. So which is namely high alert medication, organ dysfunction, therapeutic drug monitoring, Jekyll quota medication, anesthetic referral, medication related admissions, and specialty care. And from the round 1 results, you can see that most of the criteria has achieved consensus in terms of relevance and completeness, except for Jekyll quota medication, which is does not achieve and has to be removed from the second round. And then worth to note that HEM and also NS referral does not achieve consensus for the completeness, which means the criteria needs to be refined in terms of its content. And so we have drafted the past version 2 according to the expert feedback and rating results from Delphi round 1. As mentioned earlier, Jekyll quota medications was removed, and then we have added 3 major criteria with subcomponents according to expert suggestions. The first one being specific drugs for close monitoring, which includes things like ARF antibiotics and biologics. And the second ones are medications related issues, for example, non-adherence and polypharmacy. And the third one would be patient-related factors, for example, history of ADR and special populations. And also we have increased the scoring threshold for level 2 and level 3 patient acuity to a higher threshold. So these are the results for Delphi round 2 and 3. So as you can see here, there are 3 subcomponents being removed in Delphi round 2 for not achieving consensus, namely the brain and bone marrow for organ dysfunction, and also gastroenterology for specialty care referral. Whereas in Delphi round 3, only 1 subcomponent was removed, which is the history of fall in ward or in the past 3 months. So after 3 rounds, here come to our finalized tool, which we called it, we rearranged the criteria and we called it a story map. So this is the first page with the criteria, and the second page consists the scoring system, the modified HEM list and TDM list as an appendix. So our story map, the final one, contains 8 main criteria. And throughout the Delphi process, we have already removed 1 major criteria with 4 subcomponents, and we have 3 new criteria added, while 5 criteria remain in the past, but the content was modified and refined. So we come to discuss about Jekyll quota. So Jekyll quota medications are drug lists which are removed from the past because experts commented that the drug lists were confounded largely by the cost and does not necessitate close monitoring. These findings is actually consistent with most public screening tools published. While for specific drugs for close monitoring, we have ARF antibiotics, which are restricted antibiotics under the hospital AMS team surveillance. Clinical pharmacists play a vital role by ensuring appropriate dosage and rational use to prevent antibiotic resistance. And for UKK drugs, it is also a suggestion by the expert. It is called Ubat Kelulusan Has. The old term was KTK items. So for example, injection alloprost. So because this kind of drugs, usually it is listed because of its off-label indication and uncommon dosages. So close monitoring is often warranted. And then we have also made a brief comparison between our tools with the other few tools available in the UK and New Zealand. As you all can see here, most of our criteria actually share high similarity with the other tools. Indeed, actually our tools are considered more comprehensive. So for example, in some of the tools for the specialty care referral, they only involve ID or palliative discipline, and some do not even have intensive care transition. So one of the strengths of our story map is that we target specifically on medical adult patients, and most criteria in it has achieved expert consensus of at least 83% and above. So the strength of our study, we use Google Form to deliver our Delphi questions. It is easily distributed and received. We have open-ended questions at every round, ensuring anonymized expert feedback. The tool is easy and simple to use even in non-IT healthcare system or semi-IT like HKL, and it is adapted to local settings. And we also have our limitations, of course, because this tool is validated only for screening adult patients in general medical ward, so cannot be generalized to ortho or surgical, etc. And our expert panels only involve senior pharmacists. So in conclusion, we have successfully developed and validated story map. This could be one of the first pharmaceutical assessment screening tools in Malaysia. And this story map may act as a useful guide for clinical pharmacists to prioritize patient care in general medical wards. And we are looking forward to further validate the practicality and acceptability of it in clinical pharmacy services. So these are my references. Thank you.
Thank you, Ms. Chang. So we will proceed with the question and answer session. Judges, over to you.
Thank you, Chok Yi, for that presentation. A very interesting presentation. Can I ask you what next with regards to the tool? So you've developed a tool, right? You've presented some validation results. How would you ensure the tool is performing as you want it to perform? What are you going to do next?
Thanks, Dr. Sanjay. Actually, our plan next is to apply this tool in the ward, and then we will want to see whether this tool is helping clinical pharmacists in prioritizing the patient care. So we might have experienced clinical pharmacists and junior clinical pharmacists using the same tool and compare whether they get the same results. And then also to see whether from this tool, do we actually document and review the case that is considered acute in the ward. So this would be our next phase of implementation.
Hi. Following to what Prof. Sanjay has asked, could you illustrate to us, in a general medical ward, for example, in any KKMOH hospital, okay, you've got easily 30 patients. How would that impact? Because your story map, that's quite a handful to go through. So how would that impact in terms of the practice in the ward or clinical pharmacists?
Okay, now because the plight of clinical pharmacists in the ward are there are too many patients, and then we have different demands and tasks and all that. So without prioritization, some of the pharmacists might just choose some very easy case to review. Because usually for clinical pharmacists, we have a form to select some patients to document down and properly review the patients. So let's say for easy way out, they might choose some very simple case like ABA just to document down and just hit the statistic. So with this tool, we ensure that pharmacists really triage the patient and select the most important cases to be documented and do a proper case review so that we wouldn't miss any drug issues and all that. And so with this case, with this tool also, we hope that we can help the pharmacists to manage their time more efficiently because they will know which ones are more important to review first, and the other maybe they can refer to the inpatient pharmacies, for example, for counseling and etc. So they know how to prioritize their patient care. Thank you. No question. All right. Thank you so much. Thank you.
Thank you, Ms. Chang, and thank you, judges. Now let's move to our fourth presenter for the day, Dr. Nurul Liana Roslan from Emergency Department HKL with the research titled 10 times lucky from the Cupid arrow, a case report of a penetrating injury over the neck and thorax. So Dr. Nurul Liana, this is the floor is yours.
Okay, Assalamualaikum and good morning. My name is Dr. Nurul Liana Roslan, and I'm going to present a case titled 10 times lucky from the Cupid arrow. It was quite a hectic shift when our team received a 15-year-old boy who sustained a penetrating neck injury and over the upper chest after he allegedly slipped and fall off a tractor while picking and lifting the palm oil fruits. It was a referred case from a district hospital. Physical examination findings as per ATLS protocol were unremarkable except for the E component. His only complaint to us was pain and restricted neck movement, especially over the entry side and over the exit side. As he already received tranexamic acid, petidine, and ATT from the previous hospital, we continued the oxygen therapy, administered the IV antibiotic, and started him on IVI fentanyl infusion while waiting for the surgeon and also the anesthesiologist on call. The point of care of investigation, including the EFAs, were done and were normal except for the total white count, which is expected to be slightly higher in post-trauma patient. The chest X-ray obtained from the district hospital was not very informative to guide the surgeon. Hence, CT thorax is warranted. However, the width of the gantry aperture of our CT machine is only 18 cm width. So we called JBPM, which is Jabatan Bomber dan Penyelamat Malaysia, to help with the rod shortening process. Concurrently, the plan of care for the patient was discussed and was agreed among the specialists as this patient required removal of the metal rod with the anticipation of difficult airway. First, we will send the patient to the OT for awake intubation using fiber optic scope, and then followed by the shortening of the rod by JBPM using metal bar clamp and hydraulic metal bar cutter. After that, patient went for CECT thorax and the neck, which revealed no significant organ injuries. He then was sent back to the OT and the rod was successfully removed by the surgical team without any complication. The patient further was observed for 24 hours and sent back to the district hospital for further observation. Well, everything you are hearing so far is like a fairy tale, case well managed. But here are some discussion points that I would like to highlight for the future improvement. First, regarding the inter-hospital referral policy. Actually, we did not receive any pre-arrival notification. It is very important as it allows us, especially from the emergency department, to prepare for the worst scenario. And at the point of time, actually, we have lack of manpower in view of search of patients. There is a KKM policy of inter-hospital referral and transfer in 2009 and revised by HKL own policy in 2019, which highlighted that the receiving primary team is responsible to ensure that the resources is available before accepting any cases and is responsible to inform the ED MECC using this extension number, which is 5333. Why? Because ED have a lot of phone lines, so the communication might be disrupted. It is also highlighted that not all cases need to be sent to ED, except for those who are unstable, and those who are required intervention or deteriorated during the transfer. Point number 2, the inter-facility safe transfer, which all is actually involved the safety of the healthcare worker, the patient, and relative who accompanied the patient. For our case, the transfer was uneventful. However, I would like to emphasize this. The impaled object was not stabilized. Yes, the referring team did ensure the sharp end of the rod is covered, but a reinforced bandage at the entry site is required. The previous use of donut bandage should be abandoned as this method of bandage is not stabilized. It's not stabilizing the impaled object. The current method proposed by Malaysia pre-hospital care expert is by using rolled gauze on each side of the impaled object and reinforce it using roller or crab bandage or even a duct tape in crisscross manners. Next, I would like to emphasize on the use of restraints and patients sitting in the ambulance during the transfer. The latest 2019 KKM policy only gave a general statement, but it did not mention the method of applying the restraint. Allow me to give you a rough idea of the challenges in transferring this case. This is the diagram of the picture of KKM ambulance with the width of the ambulance and the stretcher. As you can see here, the patient cannot fit on the stretcher inside the ambulance because it is limited by the 1.5 meter rod. And the wall over here is actually limit the structure for the patient to be placed on the stretcher. So I went to a few expert pre-hospital care fellows member, of which in the end, they come up with this suggestion. So actually, the patient can sit in the stretcher with the position you put it and sideways. So we also have to modify the seat belt so the patient will be in place, and when the ambulance will be moving, he will be stable there. Other than that, it's not compulsory actually for the patient to be on the stretcher. So the patient can be put on these 3 seats. And for your information, at this point of time, the KKM ambulance, all these 3 seats actually can be rotate sideways. Other than that, all the experts also emphasize that the ambulance speed needs to be steady and the driver needs to prevent from any emergency brake and abide with the traffic rules and regulation. Next point is about the patient handover, because inadequate handover in emergency care is crucial. We propose the ADMIS mnemonic, which is used widely in UK, America, and few other countries. It is simple and most of the vital information will not be missed. However, there is no studies to suggest that standardization of handover will improve the patient outcome. Next point that I would like to highlight is the approach to the neck injury. Traditionally, for the past 50 years, Monson et al. Actually suggested that penetrating neck injury should be approached using the zone, which is zone 1, zone 2, zone 3, and also he divided into the anterior and also the posterior triangle. However, the current evidence actually accumulating to suggest the use of non-zonal approach. Well, the non-zonal approach, for example, in this 8-year retrospective analysis by Abraham et al., he found that the zone-based guideline can actually result in unnecessary negative exploration. And he also proposed the non-zonal approach in evaluation and management of penetrating neck injury. Next one is approach to the difficult airway. There are many algorithms of difficult airway, however, all are based on the expert consensus. Therefore, a pre-formulated strategy for management of the anticipated difficult airway need to be personalized per local setting. The recent ASA guideline criteria actually stated the criteria to perform awake intubation. It stated that 88 to 100% success rate if we perform awake intubation using fiber optic scope. Therefore, we do support the decision of our NS colleague to intubate this patient using such method. Last point is the teamwork. Teamwork is important when managing a complex case. We were lucky as the teams involved were very helpful. Nevertheless, it was to highlight that the Tier 1 trauma team activation and HIT CT protocol had started in HKL in collaboration with our radiology colleague. We were hoping that Tier 2 trauma activation to be initiated soon, which involved surgical, NS, ortho, and ENT team. A good interagency relationship is important. For example, in our case, JBPM assisted us with the shortening of the road, while the PBHKL handled the reporters and managed the crowd outside our emergency. Now, let's go back to the title of my presentation, 10 times lucky from the Cupid arrow. The patient was struck by a so-called Cupid arrow, which is the harvesting road. He is considered to be lucky as he escaped death without any injury to all these 10 vital structures. And with that, thank you.
Thank you, Dr. Nurul Liana. Now I would like to invite the judges to begin with the Q&A session. Thank you.
Thank you very much, Nurul Liana, for that presentation. Very interesting presentation. So the question I would ask is, if you could use the results from your case study now, right? What would you do next with the results from your research, from your case study?
What we learned from this study, actually, for this case, actually, for the case, is actually the main point is actually the communication between the teams in the hospital itself and the hospital from the referring hospital. Because I think what the problem with our Ministry of Health is the lack of communication. So I think maybe because the most of the reason is because everyone is quite busy. They want to manage the patient, but at the same time, if we spend like few seconds or few minutes in managing this patient, I think it actually helps a lot. Okay.
Thank you.
Did you actually collect the data in terms of important time points and time of events from the moment the patient obtained actually acquired that injury until the successful removal and recovery?
At this point of time, I don't have it, but I need to look back inside my hard disk to look for the timeline.
Now, for the presentation, in 1 year, estimation, as an estimation, how many cases similar to this case that you presented you encounter in the emergency department? Yes.
Okay, actually for penetrating neck injury with the object in situ is actually so far, this is the first one. Because the rest of the case usually like knife is usually step case. So step case, usually the object is not there anymore. But the rest of the case that our pre-hospital care actually attend, usually die at scene. So it's actually a negative outcome. So far, this is the first one during my 10 years in HKL. This is the first one successful penetrating injury with that large object, with the large object there.
Excellent. Thank you very much.
Thank you, judges. Thank you, Dr. Liana. So we move on to the next presenter. Last but not least, I would like to call upon our fifth presenter for today, Mr. Koh Hock Peng from Pharmacy Department, HKL, with the research entitled Mortality Outcomes and Predictors of Failed Fibrinolysis using Streptokinase and Tenecteplase in ST elevation myocardial infarction, STEMI reperfusion of an Asian population. Mr. Koh, floor is yours.
Hello. Hi, can everyone hear me?
Hear you. Here go. We can see your slides also.
Okay, thanks a lot. Okay. Hi, very good day to all the panel judges, the organizing committee, and of course, all the audience. My name is Koh. I'm from Hospital Kuala Lumpur. Today, I'll be presenting my research entitled Mortality Outcomes and Predictors of Failed Fibrinolysis using Streptokinase and Tenecteplase in ST elevations myocardial infarctions, reperfusions of an Asian population. Okay, first of all, I would like to acknowledge that this research is a collaborative work between the Pharmacy, Medical, and Emergency Department of Hospital Kuala Lumpur. Some background information. I think everyone is aware that ischemic heart disease, or IHD, is the #1 killer globally and in Malaysia. So fibrinolysis is the current primary reperfusion strategy for STEMI in Malaysia's public hospital due to the limited availability of PCI-capable centers. Streptokinase and Tenecteplase are the only two fibrinolytic agents indicated for STEMI in the MOH Malaysia. These are some comparison between Streptokinase and Tenecteplase. For your information, Tenecteplase is 3 times more expensive than Streptokinase. Move on to the literature reviews. Failed fibrinolysis, of course, is a major concern in STEMI reperfusion as it is associated with early mortality. However, the worldwide study had reported an inconsistent rates of failed fibrinolysis. Some studies had also identified the predictors of failed fibrinolysis, but it was limited to Streptokinase. So the inconsistent findings, small sample size, and outdated studies were among the justifications to conduct this study. Furthermore, the evidence tailored to our local population is needed to assist physicians in selecting the right fibrinolytic agents for the optimal outcomes in STEMI patients. The vast cost difference between the fibrinolytic agents is also another concern in Malaysia, a country with subsidized healthcare. Thus, the study objectives were to assess the mortality outcomes of failed fibrinolysis and also to identify the predictors of failed fibrinolysis in STEMI reperfusion. So in this study, the fibrinolysis outcome were based on the cardiology physician's documentations in the patient's record. This was a single-center, retrospective, observational study involved all adult STEMI patients who received fibrinolytic agent in ED HKL from 2016 to 2020. These were the inclusions and exclusion criteria, and these were the statistical analysis conducted. So a total of 1,043 STEMI patients profile were reviewed. The final analysis actually included 859 patients with sufficient data for at least 30 days. So move on to the results, looking at the baseline baseline demographic and clinical characteristic. Our STEMI patient had the mean age of 53.6 years and predominantly male. The usage of streptokinase and tenecteplase was comparable over 5 years. For the outcomes following fibrinolysis, the rate of failed fibrinolysis in hospital mortality and 30 days mortality were 8.4, 10.8, and 12% respectively. This multiple logistic regression showed that failed fibrinolysis was one of the predictors for 30-day mortality with an odd ratios of 2. We identified 4 predictors of failed fibrinolysis, which include tenecteplase use, family history of ischemic heart disease, history of stroke, and heart rate above 100 at presentation. Further analysis were conducted to identify the predictors of failed fibrinolysis in each fibrinolytic agent. We found that KILIP classifications above 1 and heart rate above 100 were the predictors of failed fibrinolysis in the streptokinase arm. On the other hand, history of stroke and anterior locations MI were the predictors of failed fibrinolysis in the tenecteplase arm. So this actually answered the objective number 2. So, okay, let's move on to the discussion. There is a worrisome trend of STEMI patients occurring at a younger age in Malaysia. Our STEMI patients were more ill at presentation and had a higher risk of mortality. And sadly to say, our mortality following STEMI fibrinolysis was high, although the prevalence of failed fibrinolysis in our setting was much lower compared to the literatures. Then our findings of failed fibrinolysis as one of the predictors for 30 days all-cause mortality was consistent with the literature. Okay, I'll move on to the discussions on predictors of failed fibrinolysis. It was actually surprising to discover that tenecteplase was one of the predictors for failed fibrinolysis. We postulated that inaccurate or underestimated body weight probably contribute to this finding. Next, our findings of family history of IHD and failed fibrinolysis was not previously reported in other studies. For history of ischemic stroke more than 3 months, we also postulated that the tenecteplase underdosing due to inaccurate body weight estimation probably contributed to this finding. Then, for anterior MI, it has been reported to achieve a lesser reperfusion following fibrinolysis. However, our findings of anterior MI as the predictors of failed fibrinolysis in the tenecteplase arm were in contrary with the current literature. Then, the heart rate above 100 and KILIP above 1 were the predictors of failed fibrinolysis in streptokinase arm. So, tenecteplase might be a better choice in these patients. Move on to the strengths. Large sample size and the real-world data with consecutive STEMI patients over the 5 years were the main strengths of this study. And these are the study's limitation. Mainly is the retrospective and single-center study. Then for future study, we actually propose a larger multi-center study to be conducted to draw more solid conclusions on failed fibrinolysis and its long-term cardiovascular disease outcomes in our population. In conclusion, the mortality following STEMI fibrinolysis remained high in our Asian population and was contributed by failed fibrinolysis. The identified predictors of failed fibrinolysis include tenecteplase use, family history of IHD, prior history of stroke, anterior locations MI, heart rate above 100, and KILIP above 1 during STEMI presentations. We had identified several important impact on practice or policy from this study. Of course, number 1, public health awareness is needed as our STEMI patients are getting younger and presented with a higher risk of mortality. Number 2, we need more PCI capable facilities, probably at least 1 cath lab in HKL, looking at the huge differences in terms of mortality outcome between these 2 treatment modalities. And then in non-PCI center like us, of course, the identified predictors of failed fibrinolysis enable early risk stratifications to accurately evaluate the STEMI patient's prognosis and can serve as a guide in triaging and managing the patients. Next, streptokinase is, of course, still an effective fibrinolytic agent for STEMI reperfusions in our population so that we can use it more confidently. Higher failed fibrinolysis in tenecteplase in our center require further exploration. And the physicians actually need to ensure accurate weight-based dosing of tenecteplase to ensure optimal outcome. Lastly, we suggest reserving tenecteplase for STEMI patients contraindicated to streptokinase, hemodynamically unstable or extensive anterior MI. These are my references for these presentations. We would like to thank the DG for his permissions to present this research. With that, I end my presentations. Thank you.
We will continue with the question and answer session. Judges, over to you.
Thank you very much, Mr. Koh, for the a nice presentation and overview of the extensive data, single center data. You conclude that your data can be generalized into the ASEAN population.
Yep.
Can you share with us what are the basis of a generalization that you have used
I see.
to allow you to generalize into the ASEAN population? Thank you.
Okay, thank you, Doctor. Actually, I didn't. There's actually more data from these studies, but due to the time limitation, I only share the major one. But of course, from the year 2015 to year 2020, we have 1,043 patients, 1,043 STEMI patients received thrombolysis in HKL. Actually, 30% of our STEMI patients are actually foreigners, which include permanent residents from Indonesia, Bangladeshi, Myanmar, some UNHCR patients. Is 30%. Yeah, and all of them, this 30% actually receive streptokinase and even metallized, tenecteplase in our center. That's why we can say that probably our findings can generalize to this population. Yeah.
Thank you, Hock Ping, for your presentation. So in your discussion, actually, you do two bits, right? One is you do prediction and one you do some etiological comparison. So coming to the prediction, what is the discriminant properties of your prediction model? What is the AUC?
Oh, AUC. Yeah, I think I can share my screen back.
How well does your prediction model discriminate the outcomes?
Actually, it's all above. Hold on, I share.
It's okay, just a number will do.
Yes, it's basically all significant. As I remember, the AUC is above 70 to 80+%. Yeah, there's no interactions and no multicollinearity in the regression analysis. Yeah,
okay,
so yeah, we have checked all this. Yeah.
Hi, I just like to find out in your multiple logistic regression, how many variables of predictors did you use?
Yeah, I think, Doctor, you want to ensure that my numbers of what do you call it? My sample size is adequate for the regression analysis. Is it, Doctor? Actually, I have calculated that ensure that our sample size, the number of variables included in the logistic regressions is sufficient, because I'm applying the rule of EPV. The event of variable of 50 subjects per variables. So I actually using the formula of 100 plus 50i from the Bujang et al. So actually I have different variables in different logistic regressions. Of course, the numbers of subjects needed is actually varies from 400 to 550. So it's actually numbers of the minimum sample size are actually achieved to run the logistic regressions with the numbers of included subjects. Yeah. So the variables, for the mortality is 6. For the field fibrinolysis, overall field fibrinolysis is 9. So for the predictors of field fibrinolysis, I actually need a minimum of 550, but the numbers of subjects that are included is actually 859.
Can I ask another question? You make a lot of etiological comparisons. How susceptible are your results to confounding bias?
Confounding bias, of course, because this is a retrospective studies, of course, there are also some baseline characteristics that might affect the outcomes. But in the regression analysis, interactions or multicollinearity is checked. So yeah. Okay.
Okay, thank you, judges. Thank you, Mr. Koh.
Yep,
we have come to the end of our oral presentation competition. On behalf of the organizing committee, once again, I would like to thank our honorable judges, fellow presenters, and all of you for your kind attention. The results will be announced towards the end of our event today. That's all from us. We'll pass the floor back to our Master of Ceremony for today, Dr. Aina. Thank you.
Thank you, Dr. Raj and the Scientific Committee for hosting the oral presentation competition. After our exciting talks and oral presentations and poster presentations, we now would like to invite you to enjoy your meal during this lunch break. Excitingly, we have prepared a quiz especially for our viewers online, and the link and QR code for this will be showcased on our Zoom, FB page, and YouTube Live for the only first 20 minutes of the lunch break. Please do participate to challenge your knowledge and win prizes. Again, take note, only the fastest 10 people to answer all the questions correctly will win the cash prize. So meanwhile, throughout this resting period, please do browse our poster presentations online and our ebook program. We will rejoin again in an hour's time at 2 p.m. See you later. Thank you. Welcome back, everyone. We hope you had a hearty lunch and a relaxing recess time. Before we begin for our next session, some housekeeping notes on the program. Kindly mute off your microphones on your PC or laptop to ensure an uninterrupted event. We will regularly announce any updates from time to time, so please be alert. The QR code and Google links will be provided in the chat box for the attendance and feedback form, whereby certificates and CPD points will be obtained upon filling those. Please leave your questions or comments in the chat box on our Zoom or FB Live or YouTube chat box. We will leave a link for the Research Day ebook program for your perusal. Without further ado, we will move on to our fourth presentation for today. There's a small announcement. Datuk Professor Dr. Adiba is currently giving a talk in Dubai. Therefore, she'll join us for the next session. Meanwhile, Dr. Haja Salina Abdul Aziz will be delivering her presentation entitled Innovation in Research During COVID-19 Pandemic. A bit about Dr. Haja Salina. She is our consultant psychiatrist and clinical epidemiologist. She is currently the technical head of Service of Psychiatry and Mental Health Services for the Ministry of Health of Malaysia. She's the chairperson of Medical Research and Ethics Committee, MREC, head of Department of Psychiatry and Mental Health, Hospital Kuala Lumpur, and also the head for Clinical Research Centre, HKL. At the academic level, Dr. Salina is the Adjunct Associate Professor for Perdana University, Adjunct Professor for Mahsa University, Honorary Lecturer to Postgraduate Psychiatry for National University of Malaysia, University of Putra Malaysia, and University Malaya. She is also the Chairperson MMC, Specialty Education Subcommittee for Psychiatry. And last but not least, a member of the Conjoint Postgraduate Advisory Board for Psychiatry. With this, we please welcome Dr. Haja Salina for her talk.
Dr. Aina, for that introduction. Sounds very manic to me, okay. I'm going to talk a little bit about doing research during COVID-19 pandemic, okay. Some of the things that I'm going to talk about what happened during our 2 years of COVID and how it has changed some of the research that was done and how it was done during the pandemic. That means during the year 2020 and 2021. Okay, this is a quote from Steve Jobs, okay? Innovation is the ability to see the change as an opportunity and not a threat. Okay? I think COVID-19 did a lot of good with regards to digital health. We were forced. I think we wanted to digitalize something for some time. I think if this morning you listen to Dr. Fazila, you've seen that we have talked about making things digital in here for a long time, but it never sort of moved until COVID-19 came and a lot of things sort of moved with regards to digital. So it present an opportunity to us at that, when we had this COVID-19 to do a lot of things in a digital way. So how does the COVID-19 has impacted the scientific research activity? How did it? No, when we had COVID-19, the usual or the things that you hear every day, in fact, until now, is that we have to have new norms. Okay, so the COVID-19 has changed the way we do almost everything. Okay? And initially, we were hoping that this is temporary. We was also, a lot of us were in denial actually. A lot of us were not following until we had to put in laws, forcing everyone to wear masks, you know, and continue to live under lockdown and restriction. Okay. So with regards to research, we were looking into like what MREC CRC does is you try to ensure safety to the participant of your research. Okay, but when we have this lockdown and restriction, there are a lot of things that you need to do differently. Okay, let's move on. Okay, so there is a paper, actually there's a document that was I think you can find it if you go and go on internet on the overview of the FDA guidance for conducting clinical research during COVID pandemic. One of the first thing that they talk about is the IRB or the EC, the ethics committee. Okay, the ethics committee need to change their review process. Okay? If we are so accustomed to face-to-face, okay, submission still on paper, okay, but fortunately for us in Malaysia, we were already having electronic submission. We had the NMRR and whatnot, okay, but our committee, okay, still meeting face-to-face. There was no teleconferencing format. So those who review electronic or virtual instead of face-to-face were not in much of a problem. Okay, and protocol submission should be done electronically to save time, and hard copy only mandatory. Okay? And principal investigator should contact your research committee as soon as possible to communicate their intention, especially those that it needs urgent, how to say, approval. Okay? So we are very how to say fortunate, but we had the old NMRR platform where you can sort of send in all your proposal, you know, and get it reviewed, and then do your SAE, do your review even the reviewers can look at your paper and review it online. Okay, but our NMRR at that time, I think dia punya contract already expired, so we had to change a new one, and it happened during this COVID pandemic lah. So the thing is, when we had to move to this new platform, it gave us some input to the sense that, you know, we need to make it all virtual. Okay, in fact, we even had now no need face-to-face meeting, mostly done online. In fact, you can even review your protocol. The reviewer can review and send back feedback online. Last time you cannot do that, you know, it has to be in. So what happened was when we had the COVID that time, actually during the MCO, the initial MCO, everything stopped actually for MRC. Everything stopped. Everything was postponed from January until May that time. Okay, everything stopped because we were not prepared for the non-face-to-face. Okay, but everything resumed after 19th to 21st of May 2020 until now. So we reverted from face-to-face to online. Okay, and those who does come to the committee that come for physical face-to-face, we had to put in the SOP for this social distancing. But most of them are now done via teleconferencing and online, and most of our report are sent back also online. So it saves a lot of trouble, okay, and also is very convenient. However, the new system, the new NMRR system, well, I get feedback quite a lot of you, quite a number of you have, well, anything new, you need to get used to it. Sometimes there is glitches, glitches. You can feedback to us. We will take into consideration some of your comment, some of your, how to say, difficulties in accessing the new system. Consent requirement. This is only talking of those research that already having the ethics approval. Okay, you are already having ethics approval. Then COVID came in. Okay, so now you want to continue your study. Your study said you have to see patient face to face, take consent. Okay, now suddenly COVID comes in. You have to continue your research. Okay, but patients are not coming to the clinic. Patient, you can still recruit patient, but now you have to use a different platform. Okay, so when you use different platform, different way of taking consent, then you have to be innovative. How are you going to do this? Okay. So a lot of the study need to revert to remote technologies. Okay, some of the ISR had to revert to this. Okay, so it's a bit tricky. How do you take consent without having face-to-face discussion with regards to the process? And also, how do you have this proof that patient is consented to the studies? You can't get signature. How are you going to get signature? But some of the investigators are very innovative. Okay, they do the discussion through video conferencing. Sometimes they send email, call up the participant, talk to them, and then ask them to sign consent, or even some of them even had to record the thing. Okay, when they record the thing, that as a proof that patient consented to the study. Okay. So during that time, so a lot of reconsenting process. Reconsenting ni when you change your protocol, okay, from face to face, or then suddenly now you're doing it electronically, online. You cannot simply change. Okay, when you send in your protocol, it's done face to face. Now you're going to do it electronically. Google form lah, you send by email lah. You need to amend your protocol. That means on how you do the study. One thing you need to amend. The second thing, once you change the protocol, you need to reconsent. So again, reconsenting is another problem lah, because you got to get those who had consent to reconsent, because you change your protocol now. Okay, so you can do reconsent by phone, video conferencing again lah, but you must try to get proper documentation, whether it's electronically or you send in the paper, patient sign and send back. Okay, whatever is feasible to your study lah. Okay. Okay, the other thing that we had some problem with is the process of apa? I can't see because you punya ni. Okay, the study drug supplies and equipment during the COVID-19. There was a lot of things stopped. In fact, the shipment of drugs stopped. Maybe because there was no flight, no shipment of apa. They cannot transport the drug to our country. So some of the patients who were on these studies, they had lapse, lapse because they cannot get the drug. Okay. The other thing is you have the drug in the hospital. Unfortunately, the patient cannot come to you. Okay. So a lot of contingency plan at that time. So some of you had to send the drug via courier. Then what they did was they had to take, because drug is dispensed by pharmacy. So they had a lot of change in the way the study is done in dispensing the drug. So again, another thing that you need to think about when the COVID-19 came. Data verification, okay, especially in ISR, when you do study, you key in a lot of data. Okay, sometimes your research coordinator from the sponsor will come, look at the file to verify and to monitor all your data that is being documented in the study file. Now, because of this COVID, what happened was data verification cannot be done physically. So some of us has allowed the verification of data through online. Okay, we had this in CRC. For us, it's done in CRC. You cannot do somewhere else because you get the file and you verify it online, okay, with the study coordinator. You cannot see face to face. Oh, this is what I thought just now about investigational medicinal product or trial logistic. You must talk to MBRA when there is a lot of logistic problem. Drug cannot come in because of the flight problem, because of the shipment problem. Then you need, especially drugs that are not registered. Okay. Study visits, okay. When you have started a study, then tiba-tiba ada COVID punya pandemic, okay, and patient cannot come to you because of the MCO, no transport, okay? So not vaccinated, you cannot move, okay? So a lot of the study move from seeing patient face to face to telephone calls and video conferencing, okay? Then this will substitute to the in-person visit. So that means some of you might need to do a questionnaire, look at side effect, you know, probably now rather than seeing the patient face to face, you need to substitute through phone calls and also video conferencing. But in we audited one of the study, you know, with regards to this, interestingly, dia kata dia buat phone call, dia punya visit lah, kononnya dia tukar ke phone call. So we call the number one, the number is not there, not the person. Ini macam dah menipu lah, sebab dia nak habiskan study dia. So I think you must document. If you change, you must document that number you call, who is the person you call, okay? Who called and what was the information. It still have to be documented in your file. You cannot just simply call and without any documentation in the file or in the study records. Okay. Again, change of clinic visit to phone visit. So during this, a lot of amendment that we get at MRC is with regards to changing from clinic visit to phone visit. Okay. Again, I like to remind you, if you change from clinic visit to phone visit, you still have to document in the file the phone number, what is discussed, what drug you're going to give and whatnot. It still have to be. It cannot be just call this number. That's all. You have to document your speech, your what is the point that you talk to patient, summarize the whole thing. Okay. Okay, when most of you change to electronic platform, I think even this morning Dr. Fazlah talked about privacy and confidentiality, especially confidentiality about especially personal data. Okay, things like name, IC, address, you know. So this there is an ACTA actually, okay, which regards to privacy and confidentiality of personal data, where you are not allowed, okay, you are not allowed to give to a third person data of patients, okay, of your patient, especially the personal data. So a lot of you change to a different platform of taking consent and also getting information. Okay, so what happened is this platform, are they secure? This is what MRC is going to ask you. Are these platforms secure? Is there a third party that can, you know, access to this data? Okay, so this is what came up with MySejahtera, whether the data that, you know, thousands, millions of Malaysian is being, you know, is there privacy, confidentiality? Is there anybody else who can access to the data? How secure is the data? Ini penting. Even in research, the personal particulars of person, you cannot divulge. That's why if you were to look at the most of the protocol now, they do not collect your personal particulars. Okay, they just probably take what's your sex, your age, you know, sex, age, gender. Probably they will do that. Okay, and they say if you want to continue with the study, you just press this, which means if you continue with the survey, that means you are consenting to the study. So without collecting personal data. But that one, which some people might find it, how to say, it's just a survey lah. Dia punya evidence tu not so good. Okay, post approval. This is for already having data, or having you punya consent from MRC. So when just now I was saying that you have to change the way you consent, the way you send drug, the way you review, the way you monitor. Okay, all those changes you need to fill in the amendment form. Okay, the process you need to fill in. In the year 2020, we had 244 amendment, okay, application because of the MCO. Now the research come in already from start. they do not use face-to-face. So that means amendment tak banyak lah. Dulu you already registered, next tiba-tiba ada COVID, then you have to amend the whole way you do the study. So the year, I think that was in 2020, we had 244 amendment to studies, okay, because of the COVID. Okay, now let's talk about when you do research during pandemic. Okay, this is mostly to research that time when we want to have data, we want to have evidence, okay, especially with regards to the pandemic. We had a lot of issue at that time, you know. The speed of the study needs to be dipercepatkan. You know, people want to know whether this vaccine works, whether this treatment works, okay, and everybody is asking for evidence. So when you talk about evidence, you talk about research. So the problem was doing research, drug research, doing vaccine research is not a matter of months, it's a matter of years. So how do you come to, you know, a center, or how do you give a midway for this so that you can do this research fast, but at the same time you can protect the safety of your subject. So these are some of the things that we learn. Okay, we learn, and some of the things that we learn during the COVID pandemic. Okay, as we all know, that time with regards to vaccine treatment, there was a lot of, I think, not only medical, I think non-medical, political, financial, a lot of issues. Okay, a lot of issues because people were very stressed up. They cannot move out of the house. Okay, and they are already all the time on the internet. So there was a lot of issues, a lot of noise on the internet. Okay, so we need, at that time, we need to have a rapid production of evidence. Okay, we want to register vaccine very fast. We want to register medication very fast. Okay, so we want a rapid response. Okay, so the thing is, how as when you do the protocol, when you approve a study, you know, how do you look at the risk and the benefit balance, you know, to ensure that it is acceptable. Okay? It's acceptable. So that was a very fine line, especially when you want to approve a newly drug for use in research. Okay? So one of the way that I think FDA helped was shortening the time. Yeah? Remember, I told you some studies need to be like years before you can show a drug works, okay, or a vaccine works. So what happened was some of the clinical trial, we reduced the phase 2 and phase 3 by using human challenge study through deliberate infection of healthy volunteers. So we must, excuse me. So we must, I think, say thank you to a lot of healthy volunteers at that time who infected themselves with, we were given vaccine, okay, who were given medication, okay, because we needed them to hasten this phase 2 and phase 3, okay. Hasten the development of COVID-19 vaccine from a few weeks or months, okay. Because once you hasten the development, there is a great beneficial impact. If you were to read the impact of, you know, like us having vaccinated our population very fast to those countries who did not have access to vaccine, and they were, you know, or their population were hesitant to take the vaccine, how the disease has impacted their health system is very different from us, okay? You have to read about this, and then you understand, you know, why the need of to hesitate to urgency to fast track the vaccine study at that time. So one of the ways that we did, we had an expedited review. When the protocol came in, so when the protocol came in, we at the Research Ethics Committee, kan kita ada, you know, waiting time, you follow, you first come, first serve, okay? So when there's a COVID study, vaccine study, drug study, at that time, they were given priority. So we had to meet, okay? Meet. You cannot wait for the line. You cannot wait for, you don't go in line. You don't wait for people for the ethics committee to convene on certain date. We had a special date, we convene, and we look at the protocol and approve as fast as possible. Okay, so that's what we did. We had expedited review and special ethics committee meeting just to discuss so that this study can be hastened or dipercepatkan untuk dapat dia punya consent, approval. So when we were looking at the studies, okay, we want to ensure that the researcher and the participant were safe. Okay, we don't want people to take unnecessary risks. Okay, or the participant feel obligated to do the study, the research. Okay, so we had to have a risk management. We had to look at the study secara keseluruhan and weigh the risk and the benefit of this study. Okay? And we need information. I think that was great. During the COVID pandemic, the information on research done elsewhere is on the net. You can always search and find what other people are doing, what are their findings. So when we were reviewing this protocol, we had to do all this, real life, because the result were coming in. It's not like you have to wait for the journal to be published. Cannot. It was real time. We have to search for it at that time because time is crucial. So an example was solidarity trial. Okay, this is a trial by WHO. Okay, where they compare 4 treatments for COVID. Remdesivir, chloroquine, hydrochloroquine, lopinavir, I think 1, 2, 3, 4 with a standard care. Okay, so when they were doing this study, even I think Sungai Buloh did this study. Dr. Suresh was doing this study. While they were doing this solidarity study trial, another study was done in I think Europe. Another study was done in Europe, recovery study. Okay, what they find at that time was the recovery study found that there is no clinical benefit of hydrochloroquine. They found at that time that this is the timeline of that study. So that was in 5th of June 2020. So the solidarity study, what they did was they removed. Okay, although the study went on, with the 4 arms went on, but what they did was after that, with the evidence from the recovery trial, they removed one of the arm. So that means they stopped the chloroquine study because now the benefit is not there anymore. And evidence has showed that it doesn't work. So they have to stop. Okay, it's unethical to continue that arm. But the other arm continued the study. So that arm was suspended or revised. Okay, the need to unblind. Okay, the need to unblind ni interesting ya. A lot of the vaccine study, macam cakap tadi kan, ada healthy volunteers. Some were blinded. Okay, some were they were blinded to whether they receive placebo or vaccine. So you remember there are two things in when you talk about safety and efficacy. Non-maleficent is talking about do not cause harm. Okay, but you must remember the blinded placebo group. Okay, when you do the vaccine study, the blinded placebo group, maksudnya mereka yang tak dapat vaksin COVID ni, tapi dia tak tahu dia tak dapat vaksin COVID. Okay, you remember reading paper? There's one person who said that I've given vaccine. Actually, he was in the placebo group, and they feel as if they macam dia kebal to the study. There was behavior change. They feel that they're safe, but actually they are not, because they do not understand that they are in the placebo group. They don't know in the placebo group. Okay, the other one is autonomy, making sure that the participant understand the risk and the benefit of any procedure prior to consent. Okay, the risk of being unvaccinated has increased significantly since trial began. When we initially started the trial in 2019 or 2020, early 2020, we do not understand the risk of not being vaccinated. But as time goes by, you understand that the risk of not being vaccinated is very high, especially if you are in the elderly group, you have comorbidities, okay? So the true morbidity of the virus has not become apparent when you start the study, okay? And then, but you are already in this study, okay? And the level of risk at that time was not, we didn't know because it was a study, we're still starting at that time, okay? So, that comes to the next question. And then we have a policy change. Policy change kan? Policy change where there is a national COVID-19 immunization program. Everyone is asked, although they say it's voluntary, but if you do not have the injection, you cannot go into the supermarket, you cannot go in so many ways, your movement is so restricted. You can only stay at home, okay? So that time, all this policy change was not there before you start the study. So what happened was, a lot of people who are in this study don't know whether they are being vaccinated. So they don't have MySejahtera because they cannot get vaccine because they are already in this study, okay? And their movement is so restricted, they cannot do a lot of things. And they were like, okay, there is a policy change, okay? Their risk has increased. So now, are we going to tell the researcher to unblind them, give them the vaccine? So, then it goes back to the investigator. They should now evaluate whether to continue, modify, suspend, or cancel the study. We had a few studies that one study had modified. That means they modify, they switch lah. Siapa yang dapat placebo, dia bagi vaksin. Siapa yang tak dapat ni, bagi placebo. So when they switch, so they modify the methodology. There are some who definitely had to cancel because a lot of their patients suddenly realized they were in the study, they cannot move about. What they did was they did not come for follow-up, they went for vaccination. So most of them a lot of them have dropped out lah. Okay, so when there is a change in policy, when the safety and efficacy of the drug is changed over time, then you need to do something. Okay, so this is what happened with our vaccine study actually. A few studies we had to stop, suspend, one or two had modified their study. Okay, now if you send in a placebo control vaccine study, I'll be thinking, why should we do placebo? We know that it works, and somebody who get placebo have a lot of restriction. So if you want to do a placebo control study now with vaccine for COVID-19, we insist that in your PIS, patient information sheet, you kena tulis kat situ. If you are in this study, your MySejahtera tak akan tunjuk. You probably have restriction of movement. You tak boleh, you cannot, probably cannot go into tak boleh makan kat luar. You cannot go to the cinema. You cannot go for shopping. You probably cannot even move you cannot travel overseas and things like that. Okay. Okay. Most of my talk are from these two references, but I think most of the issue are from what we experienced at MREC itself lah, with regards to the COVID-19 pandemic that time. Oh, thank you very much. That's all. I welcome any question from the audience.
Thank you very much, Dr. Salina. We have two questions from our chat box, Doctor. So the first question, if we're using Google Form, can we use that as an e-consent? And is the consent still valid if there's no name, IC, or any other identifier? That's the first question. The second question, Dr. Salina, what are the innovation or new ways during our pandemic that can still remain even if the pandemic or endemicity has resolved? For example, using online surveys.
Okay, thank you very much. E-consent ni, kalau you buat, a lot of us now use Google as e-consent, okay? If you're doing a survey, ada questionnaire, you ask patient to fill in, and you don't take you don't take the personal information, but and you have this disclaimer in front. If you continue or click on this button, you are already consenting to this study. Yes, survey boleh lah. Saya cakap tadi survey senang, tapi masalah dia, most of our study are outcome study. That means you have to know patient datang bila and the next time what happened. Most survey study is not a problem if you do this with Google Form. Tapi kalau yang ada outcome, yang kena ambil blood later, you want to talk to patient later, you need all this personal information, especially the one that you have to jot down in their file and whatnot. So that sort of study, you cannot be using Google because you cannot put in patient's name and IC and whatnot inside there. Okay. When you talk about innovation, innovation naik balik sikit tak nampak. Next question. Okay, new way of doing research. One of the things that now rather than using Google Form, rate apa dipanggil sekarang? Rate cap. Okay, ICR. Okay, ICR has a platform where you can make dia punya apa? Question, okay, the study punya interview schedule, consent, where that rate cap is with us, it's not with Google. So that one you can use, you can have identifier, okay? So much easier lah, okay? It is going to continue. This ICR punya rate cap is going to continue.
Thank
And
you.
what I understand is ministry, I think ICR is going towards that, where they are now coming up to providing space for you to do your research online, providing space for you after maybe you finish your research, your data is there, you collect, then they remove this one, allowing that space to another person to use their research online. That one I think is in the pipeline, okay, other than rate cap. Any other questions?
Be open to the floor if you would like to ask questions live. A question from myself, Dr. Salina.
Boleh.
It's okay. What is the biggest challenges that you face during the 2 years of the pandemic? The most challenging part for the research field?
I think we are so used to coming to hospital, okay? When you do a proposal, kita banyak clinician we are so used to getting our patient, our candidate for the study. You come to the hospital, in the clinic, you pick up the patient, okay? Now, you punya klinik tak ada tutup tau. You punya klinik tutup, tak ada orang kat situ. And you have to start this, let's say you want to do something on Parkinson, kan? MCO tak ada klinik. Okay. Even if you want to do online survey pun, Parkinson, macam mana saya nak cari patient Parkinson ni if the clinic is not there? So now comes this, itu yang datang, social media, Instagram. What we see was some people, what they did was, when they send in the proposal, they send in an advertisement. Okay, advertisement macam poster lah. Dia tulis situ, are you suffering from Parkinson? We are having this study. If you are, please contact this number. So now it is more general. Some of them will put it on macam Parkinson group punya on the Facebook, or put it on Instagram. Okay, so that was the way it was going. Okay, for example, in psychiatry, we had one study where we were doing at neurocognitive, okay, function after getting COVID. When you have a COVID infection, what happened to the neurocognitive? So we put it on Facebook everywhere, and we had actually the pickup was quite great. Actually, we had more than 3,000 to 4,000 participants who answered the questionnaire and whatnot. So the thing is, you have to become innovative. I mean, a long time ago, I would have thought that Facebook would be a very good place to sort of, get your patient for your study. Okay, so there are some other innovation that you would think of. For example, now you talk about spreading your research. Okay, last time you have to put in journals, have pay a lot of money. But now there's so many online sort of journal where you don't have to pay anything and people can access to it easily. So you just write up your paper and you send in to this sort of portals where they will put your study online, and you don't have to pay a single cent actually. Okay.
Interesting.
Any other question?
I think that's the end of the session, Dr. Salina. Thank you very much, Dr. Salina.
Oh, you're welcome.
Yeah, indeed, innovation memang we have to improve ourselves from time to time, learn, unlearn, relearn, innovate. Yeah, thank you very much, Dr. Salina. So we shall proceed to our next presentation. We are now on our fifth presentation for today. We would like to invite Datuk Professor Dr. Adiba Kamaruzzaman to deliver her presentation entitled Clinical Research Impacting Global Health. A bit about Datuk Professor. She is a professor of medicine and infectious diseases at University of Malaya and an adjunct associate professor at Yale University. She was the Dean of the Faculty of Medicine of University Malaya from 2011 to 2019. She is presently chair of the UMMC COVID-19 Task Force and is a member of several state COVID-19 task forces and also the Malaysian National Recovery Council. Datuk has played a leading role in the response to the HIV epidemic in Malaysia and globally, and is currently the chairman of the Malaysian AIDS Foundation and president of the International AIDS Society, and also the member of WHO Science Council UN AIDS Advisory Group. With this, we would like to please welcome Datuk Professor Dr. Adiba for her speech and presentation. Thank you.
Assalamualaikum and good morning, everyone. And thank you very much for inviting me to speak at your conference. I'm really sorry to the organizers for having to change my time so many times because I'm traveling actually. I'm at the moment speaking to you from London. Now let me, can I share my slides? Because I can't seem to do it. Can someone give me the ability to share my slides? Because I can't seem to do it.
Give us a minute, Professor.
Sure.
Yeah, sorry.
Apologies about this. So my talk actually hopefully will complement what Dr. Salina has just delivered. And my reference is from a very nice series from The Lancet on clinical trials and research, 4 papers that were published towards the end of last year. Okay, let me see if I can, I think I still can't share.
Okay, Prof. You are now the co-host, and are you able to share the screen with us?
Let me try again.
Okay, there's a green icon.
Yeah,
There's share screen.
Correct, but what I'm seeing is who can start sharing when someone is this only the host can share.
I see. Give us a minute.
Okay, let me see. Maybe I need to go out and come back in again. Can I do that?
Oh, sure, Professor.
Yeah, sorry about this. Let me go out and come back in again.
Okay, sure. We'll wait for you. Sorry for the inconvenience. We will come back to you later while waiting for Professor Adiba to share her slides. Thank you.
Okay. Mhm. Okay, now can you see my slides?
Yes.
Okay, great. Okay, so my talk is on clinical research impacting global health. And like I said before, I think it will hopefully, inshallah, complement nicely what Dr. Salina has just delivered. Just a bit of a background. There is currently a mismatch between research efforts, that is the number of clinical trials and disease burden. What I mean by that is that most clinical trial research is, as we all very well know, undertaken in high-income countries, but the disease burden is largely in our part of the world and also in sub-Saharan Africa. And just prior to COVID, the WHO International Clinical Trial Registry registered randomized controlled trials between 2010 and 2019, total 324,854 in low and middle income countries. Sorry, of the more than 320,000 clinical trials registered in this WHO clinical trial registry, only 70,777 or 5% were set in South Asia, and only 5,756 or 2% of the trials were set in sub-Saharan Africa. And this is obviously a very, very small proportion of clinical trials compared to what the numbers that are being conducted globally, and proportionate to the population, as well as the types of the burden of disease, both in sub-Saharan Africa and in Asia. I was actually surprised when I was reviewing the literature for this presentation to hear of, or to find that only 2% were done in sub-Saharan Africa. Maybe I'm biased, but I thought that, there were a number of at least HIV and TB related trials currently ongoing or have been done in the last decade or so. But obviously, this is small in comparison to the global randomized controlled trials that are occurring. So there is still a lot of catching up that we need to do in our part of the world to the whole clinical research, clinical trial landscape in global health. And in order to do that, I think I'll touch on that later. Obviously, we will need to invest in it, invest in clinical research, invest in research in general, and adopt new innovations to enable us to be part of this whole research landscape globally. So aside from the importance of us in the what is sometimes referred to as the global south or low and middle income countries, being able to partake in the trials as part of improving our research capability. The other reason that it is important that we in low and middle income countries undertake research either together with colleagues from high income countries or even on our own is because location and context matter. Obviously, firstly, the disease pattern can be very different, or disease pattern is very different in in lower and middle income countries compared to high income countries. Prior to COVID-19, obviously infectious diseases became less of a priority in high income countries, I guess with the exception of HIV/AIDS. Although non-communicable disease is generally a problem in both the global north and global south, but there is, as stated there in the first bullet point, substantial heterogeneity between countries and within countries, and therefore the importance of location, where studies are conducted, where clinical research is conducted, but also the context by which, in which, it's important that research is done to understand the context and also to appreciate and to be able to answer some of the more details in terms of disease burden, in terms of population, in terms of socioeconomic status, and so forth. So it's it's one thing to take results from results of studies from high income countries, but obviously it would be even more important to conduct those studies locally or at least regionally, because of the differences that can exist within countries and within regions. As mentioned, there are different biological and socioeconomic factors where trials are conducted that must be considered during the planning stage to determine whether research question is being asked in the right setting and in the right context. Now, to give you an example, this is of a study of neonates across 12 different trials in low and middle income countries that were put together in a Cochrane review by Haider and colleagues that came up with the conclusion that vitamin A supplementation on infant mortality was, we still don't know whether vitamin A supplementation on infant mortality is useful or not, despite there having been 12 different clinical trials in low and middle income countries. The results have been conflicting because the study design is different, and different studies had different rates of maternal vitamin A deficiency infant mortality. And what the authors are saying here is that the trial had been done at a more regional level with common inclusion criteria and so forth, that would have been much more meaningful than having 12 different trials costing so much money, taking so much effort, and still, after putting it all together, we still don't know whether neonatal vitamin A supplementation on infant will have a positive outcome on infant mortality. So underscores the importance of location and context and designing clinical trials to suit those, or to try and answer some of the differences that exist, as I said, within countries and also between countries. So in the global health context, clinical research is often fragmented and uncoordinated. The research questions or priorities are often set by funders who often come obviously from high income countries, and we in the lower middle income countries often have very scarce funding and have to compete for a small pool of funds. And And with that, we you know, and funders in our part of the world and most part of the world rarely collaborate. So people put forward calls for proposals based on their own interests and biases, and may not necessarily be in the best interest of global health in general or of researchers in the global south. There is little incentive for better collaborations within geographic regions and beyond current existing professional networks. And this gives little room to consider building local infrastructure and human expertise. And what happens is when these short-term trials finish, the infrastructure often disappears, and so do the data generated from research. So there is much that needs to be done to sustain in clinical trial research. In some ways, we here in Malaysia, particularly at Ministry of Health, you know, I've been observing the fantastic investment in research by the Ministry of Health, and you know that you have CRCs all over Malaysia, and you're seeing you know, wonderful research coming out of CRC that's been published and widely. So I think at least here in Malaysia, we are seeing more interest and focus on clinical research, more investment that's now paying off, but that there is still much more that we can do. Now, COVID-19, as has been mentioned by Dr. Salina, has obviously changed how clinical research is being done. And in my opinion, I think it's for the better. When you know, we have such a devastating pandemic, obviously, we all need to innovate, we all need to respond very quickly, and we see that happening with COVID-19, at least in the second part of it in 2021. What it's done is re-emphasize the importance of well-designed randomized controlled trial, but also highlighted the need for large-scale clinical trials that's structured according to a master protocol. And what is very, very important, that these research is done in a coordinated and collaborative manner. There's also need for structures and incentives to enable faster data sharing of anonymous data sets, and importantly, need to provide opportunities to those in high-income countries for clinical trial research in low resource regions, but also to truly benefit us in lower middle income countries. Now, we obviously saw the medical research community responding almost insanely to the COVID-19 pandemic. You know, it was very, very hard to keep up with the science that was coming out, and that is a good thing. But on the downside, there has been, and there still is, a huge number of research and publications and pre-publication, sometimes at the expense of the quantity has been at the expense of quality. And what it has, in a way, damagingly done is obviously promoted, how do I say, not the wrong science, but in the case of ivermectin, especially, I think this is ivermectin is a very good example of how many small studies were done, wrongly interpreted, wrong conclusions that then were very quickly picked up before adequate peer review had been done, were published on preprints, and as was observed in many times during the COVID pandemic. People just take the headlines without reading through very carefully, and then become viral and taken as gospel or taken as great science, and we saw that, and we're still continuing to in a way suffer from the bad signs of ivermectin clinical trials. The other example of how the speed and the preprints of studies then became misinterpreted and resulted in inappropriate treatment is, of course, in the early days of COVID-19, it was hydroxychloroquine. And until the large solidarity trial that was mentioned by Dr. Salina definitively answered the question whether hydroxychloroquine for treatment of COVID-19 infection is effective or not. It was being used quite extensively and may have resulted in some adverse side effects as a result of it. So they're two examples, I think, of how small clinical trials during COVID-19 and coupled with the less stringent peer reviewing and care in publishing this data in journals rather than in preprints without peer review, without scrutiny of the methodology, scrutiny of the data analysis, then gets taken to say that, oh, but the science has been conducted, the results shows XYZ, therefore it must be good. As you can see here, this is just from January 1st to June 1st, 2020. JAMA alone received more than 11,000 manuscripts, whereas only 4,000 manuscripts were submitted during that same period in the pre-COVID period in 2019. So close to 3 times more manuscripts were being submitted. A more recent example of misinterpretation of clinical trials is one just very, very recently of the mRNA vaccine that got misinterpreted as showing that the RNA gets incorporated into DNA, whereas this was very much a lab study, and the authors actually didn't conclude that it would that the RNA gets incorporated into DNA. But in this era of misinformation and disinformation, trials that or research that firstly are either poorly done or taken out of context, as well as being widely available to both the scientific community and the lay public, even in its preprint stage, prior to being peer reviewed, and like I said, the methods and the statistics being adequately scrutinized and looked through carefully, then gets taken out of context or gets viral to the detriment of the public. As I mentioned, the first 2 examples is in terms of treatment with hydroxychloroquine and ivermectin, and then more recently, this study from Sweden that kind of gave strength to the anti-vaxxers around their assertion that the RNA within the mRNA vaccines can get incorporated into human DNA, which of course is not something that happens. So like I said, most early COVID-19 trials were small, did not provide sufficient statistical power to detect a meaningful treatment, in fact, and either investigated identical or similar treatments with the dose regime being made without adequate clinical pharmacology. The ivermectin story is a good example of this third bullet point, where inadequate understanding of the dose that's required for different types of treatment then just gets extrapolated and considered in these clinical trial designs. Most of the trials in the early stages of COVID-19 were two-arm studies, or the standard randomized controlled trials comparing treatment versus placebo, or comparing treatment versus standard of care. And what that led to was multiple redundant control groups. In a way, it's a waste, and different trials have been run in the same region or even institution. If you look at tocilizumab studies, for instance, many small, including when we tried to do it ourselves, were being done of course, in the US, but also in China, in Spain, in many different institutions were doing similar studies of trying to understand whether this tocilizumab worked or not. So when we conduct, let's say this what I call standalone randomized controlled trial to investigate treatment A versus placebo, or treatment A versus standard of care in non-pandemic settings, in a way, if you have a large enough sample size, that can help answer the research question on its own. Or if the sample size is underpowered, it is still possible eventually to pool the study results and to aggregate them using usually meta-analysis. And that's what Cochrane reviews and all that are for. There is time to wait for the studies to be completed, results analyzed, and then individual results individually analyzed. And if there are 5 or 6 similar studies, then you could pool these studies, aggregate, and do this meta-analysis. And there've been, obviously, several very important meta-analyses that answered important questions from aggregating smaller studies. However, obviously, in a pandemic situation, we just don't have the time to wait for small studies to be aggregated and to do this analysis. The other downside, of course, to these meta-analysis is there can be substantial heterogeneity in the clinical trial designs in terms of dose, duration, endpoints, although that to some extent can be looked through statistically, but obviously it's not as what do you call it? As statistically or scientifically valid as having a large trial that is more homogeneous. The other problem of that was faced during COVID-19, although that improved in the second half or in 2020, was that there was this race to publish. and there was a shortage of data sharing and lack of a coordinated global approach to aggregate the data. And then finally, trials that failed to reach their recruitment targets. So negative results are often not published, and therefore, will lead to biases even when you do your meta-analysis. So those are some of the issues with regards to doing small studies to answer these large questions. Even a meta-analysis may not necessarily completely overcome some of those shortcomings. So I think in the last year or year and a half of the COVID pandemic, what became clear was the need for better coordination and collaboration in these large clinical trial networks that have gone on to really answer critical questions in treatment, in vaccine efficacy, that have really contributed hugely to us being where we are now with COVID-19. Well, I'm here now in the UK, able to travel, though it's for work, life in Malaysia is almost back to normal. At least, we're no longer all stuck in our homes, etc. And that's really thanks to the availability of the vaccine, which, these amazing tens of thousands people trials for these new vaccines that tested its efficacy. Although the anti-vaxxers would say that these trials were not done in the usual manner, and I think Dr. Salina also went through some of it. Rest assured, these studies, went through the same scientific rigor, phase 1s, 2, and 3, as it did. What they were able to do and able to really have large number of participants is because of the huge investment in the research, but also were able to come up with the results very early is because, we were in a pandemic. There were lots of people becoming infected, and the clinical trials were able to reach their endpoints very quickly. Now, aside from the ability to have a large number of participants and the importance of collaboration and networking, obviously one of the sticky points in research collaboration is around data sharing. And we face this not just globally, but also locally. I think if we're honest with ourselves, it's been one of the reasons why all of us are not collaborating as well as we should, given that, we're a relatively small country. I think we need to overcome some of these barriers of collaboration that can potentially really benefit the clinical research environment here in Malaysia. So there are some principles in terms of data sharing that needs to be understood and that needs to be agreed upon by everyone, so that this huge barrier around collaboration can be overcome. So as is in that first bullet, data sharing in the context of clinical research can often be challenging. Researchers work in a global context, and there's a variety of internal and external tools for tracking clinical trial data. A REDCap, as mentioned by Dr. Salina, is widely used globally. we also at UMMC use it, and I think that gives it's a platform. It's not the answer for everything, but I think if we all start to use a similar platform, at least that's a start in terms of ease of tracking clinical trial data. So data management is in a is deposited in a repository that's shared by everyone, you know, that can have password protection, etc., that would make it easier for data sharing, but also ensures that there's data security, etc. So having the right tool for data sharing is, of course, one of the prerequisite for effective collaboration. And through that common system, that data, so there are 4 key principles. The data must be findable, meaning, you know, there's a common system that allow for researchers and others to gain access to data, but also obviously different levels of access to that data through password protection, etc. Can take place. So the data, like you said, there has to be accessible, findable, accessible, interoperable, and reusable. So that's in terms of the principles of data sharing. And then, of course, often the other sticky point is who's going to, you know, be the first author, who's going to be the corresponding author, who's even going to be included in the authorship, is almost always a source of friction between collaborators. And so deciding that upfront, as you are, you know, towards the end of your protocol development and agreements, etc., I think that is incredibly important, because it avoids later tension and fights and so forth. So these are some of the principles of data sharing that I think would ensure greater collaboration. On a national scale, we need to have better investments for clinical trial research. Unfortunately, I think for Ministry of Health, you are much more lucky in terms of there being bigger investments in clinical trials from Ministry of Health, from Ministry of Finance. Sad to say, I think in Ministry of Higher Education, the pie is getting smaller and smaller and has to be divided, you know, between more and more researchers, and within Ministry of Higher Education, obviously, there are other researchers and research types, including basic science research, fundamental research, and clinical trial research is, you know, less of a priority in this huge sort of pool and pie of people needing, you know, that investment in research dollars. So it's always a struggle, and so smarter investment for that clinical trial research should really mean that, at least here in the context of Malaysia, I think it would be great if you know, the government could pool the clinical trials dollars that go to all the different research agencies, whether it's NIH or whether it's through APT or through MOSTI, that you know, there is some alignment and harmonization of that research dollars, so that we could have a bigger pot of money to do, you know, substantive clinical trials research together. And as has been seen, I think the hugely successful studies that have really impacted COVID-19 management, some of those that have been mentioned by Dr. Salina, like the Solidarity Trial, the Recovery Trial, the REMAP-CAP Trial, and several others, employed master protocol. So WHO has this core master protocol for clinical trial evaluation in hospitalized patients, and the Solidarity 1 and 2 trial, Solidarity 1 and 2 trials are a great examples of this master protocol, where results of smaller study get looked into to see if these are treatment options that need to be studied at a with bigger sample size. And has already been mentioned, the first 4 were remdesivir, hydroxychloroquine, Kaletra, and interferon 4. And as we know, then later on, other drugs got added into Solidarity 2 trials, hydroxin, all those with, I guess, with the exception of remdesivir, hydroxychloroquine, Kaletra, interferon B, were able to be shown to be conclusively ineffective in the treatment of COVID-19 as a result of these large multinational studies. And this would, in normal times, if this was not done in this manner, imagine we would have to wait for X number of studies looking at Kaletra, X number of smaller studies, which indeed happened, but then someone would have to put it all together in a meta-analysis and eventually come up with the results. But through this fast recruitment, because of multiple sites around the world, WHO could then, and other investigators could then definitively say XYZ didn't work. The beauty of this WHO master protocol is that they tried to make it as simple as possible, bearing in mind that they wanted to recruit patients from countries that may not have complete research infrastructure or even clinical and laboratory infrastructures as that of high-income countries. So they really pared down the requirements to as practical as possible, and even allowed participating sites that couldn't provide serial virology or any other laboratory, not so essential laboratory documentations, to still be able to participate, so as to not burden the researchers who were participating. There is a centralized randomization and data capture system, harmonized statistical support, and interim analysis and DSMB were being monitored by a global team. So if you like, a big mother spaceship of clinical trials with hubs all around the world conducting these studies, and it showed it's shown to be very, very effective indeed. So these kinds of master protocol and platform trials really are the way to go. The multi-arm studies, and you're able to the other study design that you might hear of being talked about in the context of COVID a lot is the adaptive study design, where depending on results of studies, you bring in new studies, and you drop off the ones that are no longer shown to be effective. So these master protocol platform trials and having an adaptive trial design really have shown to be extremely effective in the setting of COVID. And in my own personal opinion, would be the way forward for clinical research to answer huge global health questions in any specialty. Really, it shouldn't just be limited to COVID-19 and infectious disease. So there's been important lessons from COVID-19, the need for us all to have trial sites and some capacity in being part of this global network. And what we know is that to have and to be able to perform efficient clinical trials, we need trained personnel, strong clinical and laboratory infrastructure, strong data management systems, the ability to convene data safety and monitoring committees and boards, and of course, research ethics and overall institutional oversight, which I think obviously here in Malaysia through the CRCs and through the universities, we have already many of these elements, and I think somewhat ready to really be part of this global network of global health research in a much stronger way than we are at the moment. We certainly have trained personnel, but I think there needs to be many more of those at all levels that's required to conduct clinical trials, research assistants, research clinical trial supervisors, auditors, you name it. I think we really need to plan and really invest in personnel to be able to conduct clinical trials. I think the clinical and laboratory infrastructure, for the most part, is not a problem, particularly in the big cities in Malaysia, but some of the smaller cities may lack, say, immunology support. That's so important in this day and age. But nonetheless, I think there are ways in which samples can be sent from even smaller towns into KL, into IMR, into other labs quite efficiently without causing any damage to the samples. Data management systems, although it's there, also I think it's something that we need to invest in and build capacity on to undertake these trials. And I think in terms of DSMB, again, training in how to convene DSMBs, how to conduct data safety and monitoring analysis is also much needed if we want to expand our clinical research, clinical trials ability in Malaysia. So these are just some of the other examples of master protocols and platform and adaptive trials. Interestingly, the REMAP-CAP consortium or network was established, way back in 2016, and it's a research consortium that looks at treatment of community-acquired pneumonia in patients admitted into intensive care. And the group really had the foresight to have already written sort of an appendix to their master protocol for inclusion of an influenza-like population should a pandemic occur. Of course, there's been a lot of talk about future pandemics in the past, and the focus has mostly been on influenza. And so pandemic preparedness, many countries, including Malaysia, has a pandemic preparedness plan, and mostly focusing on the flu. And so the REMAP-CAP group had the foresight to do this. And so when COVID-19 came, it was not difficult for them to expand their existing network to 233 active sites, and it's probably more now, and were able to contribute significantly to some of the research questions that became available in the case of COVID. Now, another example of a very large collaboration that also impacted greatly on the COVID-19 pandemic and probably contributed to a huge reduction in deaths is the recovery trial, UK's recovery trial, a national level collaboration across 176 NHS and non-NHS hospitals, which, as you know, came up with the definitive answer around the use of corticosteroids or dexamethasone that became the standard of care. So this was very impressive, and this is something that I think we in Malaysia can emulate in terms of having, or in some ways it's already done with the ivermectin trial, had to have a truly national level collaboration to conduct these kinds of important research. So in the last few minutes, I want to focus on the way forward, and aside from pooling the very scarce ringgit for research in Malaysia, that by having government agencies that are funding research come together, and have a pot of money that can be used in these kinds of collaborative trials instead of funding small research would be a very important step forward. And secondly, as I was alluding to, having a truly national platform, not just teaching hospitals with teaching hospitals, CRCs with CRC, but a really Malaysian collaboration would, I think, be an ideal way forward for us here in Malaysia. We're small, but we have the capacity. We obviously still need to build the capacity, but I think if we pool our resources, both in terms of human resource, funding resource, ethics approval, etc., and truly work as one, I think we would be in the years to come, we will be a formidable national site to conduct important global health research that's important to Malaysia and the region. So just in the last few minutes, I just want to acknowledge that capacity is already here in Malaysia, and as exemplified by this fantastic work done by all of you in Ministry of Health hospitals to conduct this ivermectin study with so many centers in Malaysia and published in JAMA. So obviously the infrastructure is there, the human resources there. I know it's hard work, and there are many things that can be improved, and no doubt many things were learned in conducting this trial. But I think the way forward, like I said, would be to collaborate and to pool the resources. At UMMC, in the very, very early stages of the pandemic, although this protocol says 11 March 2021, actually, when I and a few others wanted to look at putting together a clinical trial, we actually put this together in March of 2020. This 2021 is the final report. Just to kind of illustrate how difficult doing clinical research is, and it started off by with me needing to know whether tocilizumab and steroids really work, because remember, this is in 2020, March 2020, and there was so much confusion about how to treat patients with cytokine storm and severe COVID-19. And what happened was I was in contact with colleagues from the US who at the time were already experiencing a big surge in COVID-19 and mentioned that they were using tocilizumab with very good outcomes. So as a result of that, Rick Ortiz, my long-term collaboration from Yale, and I decided to put this randomized control trial together, because at that time, in March 2020, corticosteroids really were not advised as treatment for COVID-19, if you all recall, because in MERS and in SARS, when used in MERS and SARS, it actually led to poorer outcomes. So there were actually advisory in guidelines from WHO and others for steroids not to be used. And, after a lot of discussion, we thought that this was based on, very relatively small studies, and it really needed to be challenged. And so we decided to put together this research that looked, where, this was a factorial crossover design where patients were randomized initially to toci or methylpred, and if they progress, that it could be switched to methylpred and toci for whichever they had not received. So this was a very, very innovative protocol, and we had invited Sungai Buloh, HKL, Seremban, and Penang to be part of this. I actually did crowdfunding and managed to raise quite a large sum of money from very well-meaning funders, and we started this study. If you recall, back in March, so by the time the protocol and everything was put together and ethics approval received in UMMC as well as MRC, etc., it was well into May, June by the time all that got finalized. And by then the hospital, the public outbreak had slowly died down, and so we were not able to recruit, and so we took for a long time. We were then not able to recruit, and so we were not able to reach the sample size of 310 as the numbers started to decline from our good management of COVID-19, and by the time the numbers went up again, the results of all the various large global health, large solidarity, recovery, etc., became available. So many were not so comfortable in randomizing patients to toci or dexamethasone, and so we, after convening the Data Safety and Monitoring Board, we halted the study, but hopefully we'll still be able to analyze the patients that were enrolled. And finally, I know I've run out of time. Recently, I also put together this multi-center randomized trial to look at the efficacy of fluvoxamine, which is an antidepressant which has shown in several largish studies to be effective in treatment of pre-hospital COVID. And we had already gone quite far in terms of working with Datuk Suresh and Datuk Kalai, and also our FMS colleagues, and about to submit this study to NMRC for approval. But then we heard that Paxlovid was coming in to Malaysia, and I felt, and Suresh felt, that we didn't want to go through another storm problem, and so we've actually withdrawn this study. So in summary, so what those attempts at clinical trials, at least on my part, shows that we still have a lot of way to go in terms of making it easy to do sort of this international standard types of studies, publishable, etc. And it will require, investment in all those things that I've mentioned previously. So once again, thank you very much for inviting me and allowing me to share some of my thoughts on how we can move forward in clinical research in Malaysia to contribute to important global health questions that we have in our country and around the world. Thank you very much.
Thank you so much, Datuk Professor Dr. Adiba Kamal Zaman. We are very honored to have you here today, speaking from London, I understand. And thank you so much. Before we end our session, we would like to invite Dr. Salina to say hi to you.
Hi, Datuk. Thank you very much.
Assalamualaikum. Hi.
Waalaikumsalam. Thank you very much for accepting our invitation.
My pleasure, of course.
This is the beauty of a virtual world.
Yes.
Across the other side of the world, and here you are, helping us with our research day. So thank you very much. Selamat berpuasa.
I hope that was helpful. Sama-sama. Yeah.
Bye.
Bye.
Delete sikit. Okay. Alhamdulillah. So for our final presentation from our pharmacy team, the next speaker is Dr. Rahila Ambaras Khan. Some introduction on her. She received her PhD in pharmacy from University Malaya in 2018, and she is currently the head of pharmacotherapy services in our pharmacy department of HKL. She is very actively involved in our committee, especially our HRRC or Hospital Research Review Committee of HKL, and she's coordinator for pharmacy in credentialing and privileging HKL. She is also active in producing research publications and presentations with diligent involvement in the Malaysian Clinical Practice Guidelines throughout the years of her service in MOH. With this, I would like to invite Dr. Rahila to deliver her presentation entitled Becoming a Clinical Pharmacist Researcher.
Assalamualaikum and very good afternoon. Can you guys hear me? Okay. Thank you, Ms. Chairperson, for the kind introduction. So first of all, I'd like to thank the organizing committee for inviting me to actually share regarding clinical pharmacy and also research. Yeah. Okay, as an introduction, I would like to highlight on WHO's 7-star pharmacy concept and also WHO 9-star pharmacy concept. So what is it all about actually? I think the slide is, I'm not sure, it's not full, yeah, but never mind, I will just read, yeah. So the first one is actually one of the, a component that be introduced by WHO for pharmacists to actually, incorporate this element into our, to ourselves actually. For example, the leadership, okay, the first one is actually leader. So if we have leadership, definitely we can execute our plan better, okay? Pharmacists also need to become a teacher. Why teacher? Because we need to actually, provide information about drugs, yeah, to other healthcare providers. Of course, the ultimate, our vision is actually for the patient to have, better, in terms of optimization of therapy of the patient, okay? Next will be decision maker. So pharmacists need to be a good decision maker, good in making the decision. Why? This one not just apply to clinical pharmacy, but also to all pharmacists, okay? Because we are the one who hold the drug, we are the one who hold the money. So we need to become a good decision maker, okay? Next will be lifelong learner. We need to continuously improve ourselves in terms of knowledge so that, we can optimize the care that we give to the patient, yeah, for the better outcome. Okay. We also need to become a caregiver. Okay, this one between us and the patient to optimize their compliance, to make sure they take the drug, okay, they get the optimum outcome for the better, of their health. We also need to become the communicator. We are in the middle of the doctors and also the patient. So we convey the message to the patient. Okay. Last one is actually as a manager. We need to become a good manager. So this is the 7-star pharmacy concept by WHO. A few years later, WHO actually added researcher as one of the component, another component inside the star pharmacies. They call star pharmacies. So researcher, why research? Okay, this shows that research is very, very important and pharmacists need to involve with the research. Why? I will explain this further in the next slide. Okay. To actually relate research and clinical pharmacy, you need to know what actually clinical pharmacy is doing. Okay? Clinical pharmacy basically promote safe, effective, and economic use of medicine. If we are very near to the patient, to do this, we need to acquire ourselves with a good knowledge on the pharmacology, pharmacokinetic, and therapeutic to patient care. So basically, clinical pharmacy or clinical pharmacists will involve, okay, in the pharmacotherapy of the patient, in the treatment, for example. Okay, we need to be strong in terms of drug interactions, yeah, to actually inform, is there any modification need to be done in terms of therapy? Okay, we also need to be good in terms of, to advise which drug need to be adjusted according to the organ function, yeah, the kidney function, the liver function. We also need to inform earlier what possible adverse drug reaction that the patient will have. Okay, so we can minimize the adverse drug reaction risk in our patient. Okay, this is the basic thing that clinical pharmacy need to know and and also optimize patient care based on this element. Okay, to make sure that we improve our service in the long run, we have to do research. Because all this actually coming from the, published papers, coming from the product insert, but sometimes published papers, they are not, the study not being done in Malaysia, it's in Western countries. So not everything you can generalize. So we have to utilize all these elements and then conduct the study for us to actually improve the care that we give to the patient in Malaysia. Yeah. So basically, a research in clinical pharmacy should focus on precise, personalized relationship between patients and also their medication. Yeah. Okay, so why research is important in clinical pharmacy context? First, to solve issues or challenges with regards to patient care. For example, in the ward, we keep on having unique patients, especially the elderly patient. Yeah. So I can give you an example when we dose patient on vancomycin, let's say, in elderly. I'm sure, when you discuss this with the TDM pharmacy, she will tell you that, the patient actually, when you see, it can become like when you start to give vancomycin, first day, second day, when you test first level, second level, it can be subtherapeutic. But when you start adjusting the dose on the, subsequent level, you can see suddenly it becomes toxic. Okay, why? Because elderly patient is a unique population. Okay, so study actually can help to improve in terms of dosing that we give to the patient. Sometimes it can relate to their albumin level, because we know vancomycin is 50% albumin bound, okay, protein bound. Or maybe when we estimate the patient weight, okay, sometimes we estimate, pharmacist A estimate differently, pharmacist B estimate differently. So when you estimate the weight difference, so when you calculate the dose also will be different. So this is like among the, factors that influence the dosing that, we give to the elderly patient, let's say. So study will actually improve this. Okay, this is what we are doing now to see what is the best dose to be given to the elderly patient in terms of a narrow therapeutic antibiotic like vancomycin. So research will actually help us. We can have paper for obviously, on the elderly patient and vancomycin, but of course we have to test. Is it really related to our population? So we need local studies. Okay.
Then from there, we can improve the dosing that we give to our patient. Next will be drive for new approach of personalized. So I continue my example just now. When we can come up with a good model, okay, let's say we do pharmacometric on all the vancomycin level, we try to model it, do the pharmacometric and come up with a personalized dosing for elderly patient in our hospital. All right. Okay, next will be evidence for decision making and policy. So of course, when we get some, personalized guide, we can further, doing the new policy. Maybe start with our hospital, and then after that, we can expand and include patients from other hospital and come out the national policy in terms of drug dosing to certain population or special population. This is what research is all about. Okay, to improve the care that we give to the patient. Okay, I wanted to explain a bit and share regarding the focus area for pharmacy research. This is from our ministry, Pharmaceutical Services Division. I'm sorry, it's like run a bit my slide, not the original one. I hope you can still read it, yeah? Okay, so our ministry, the Pharmaceutical Services Division, they publish this pharmacy research priorities in Malaysia. Basically to guide the pharmacists in the hospital, in the ministry, wherever we are, to do study based on this. Okay, this is the research priorities. First, assess the medicine. Okay, this is more to the ministry people. Monitoring and evaluation of outcome. So it related to the hospital pharmacists as well. When we do something, we can do research and monitor. Is it okay? Does it really help? Okay. Next one will be quality and safe use of medicine. As we know now, what Prof. Aditya also mentioned just now about COVID, drug for COVID. We know some of the drugs use immunomodulator. Yeah? Previously, we just used, let's say, for rheumatoid patient. Now we use for COVID patient. We can do study to see the, safety and quality use of this medicine in our COVID patient. Okay, for example, baricitinib. So we are doing it. Actually, wanted to register and see. Okay, baricitinib in COVID patient in hospital Kuala Lumpur. This is actually our plan. Yeah. Okay, next will be sustainability, optimization of therapy. Okay, this is more to patient in outpatient, let's say, yeah, they are study, okay. Pharmacy services delivery, okay, it's totally run, I'm sorry. Okay, the last one is actually national database of big data analysis. This is the research priorities that, our ministry advocates us to conduct study with regards to this area, so that, we can get like it become more structured rather than we have like no knowledge of what to do, which area to prioritize. So this is a very good guide for us, yeah. Okay, I just wanted to highlight a bit about the research process because I need to emphasize on identifying the research topic. This is very, very important. Okay, as we know, the first step we do is identify what to do, what topic to do. Okay, so we need to spend time when we wanted to choose what research to do. Okay, if you just do for the sake of doing, later you will regret because you have to put a lot of effort, but you are not sure whether you can generalize the data, you can generalize the outcome, you can actually improve something. So you have put a lot of effort. So it's better at the beginning to spend some time to see is it worth to conduct the topic. Okay, this is some guide you can see on the right side of the slide. Yeah, the criteria for us actually identify what research topic that we need to do. First, can a study be designed to provide a practical solution or outcome? You need to ask. Okay, you come up with a topic, so you ask yourself, can you get something from that? Can you get good outcome from that? Okay, will there be sufficient capacity to carry out this research? Okay, you have to see your capability. Okay? For example, you don't have knowledge about systematic review, but you feel, I don't want to collect data, I don't have time to collect data, I wanted to do systematic review. It's easy. I just pull all the papers and I do meta-analysis and I publish. It's not as simple as that. Capacity not just mean how many percent to collect data. It's what knowledge you have to actually conduct that study. Okay? If you don't have knowledge about systematic review, you better don't do systematic review. So that easy, even though you feel you can actually, you can ignore the data collection process. Actually, it's not. It's different different style of collecting the data. Okay, you need to collect, you need to do systematic review and get all the papers, yeah, the scientific search. It's not that easy. So you have to have a knowledge first before you conduct any study. Okay, the third one is the cost and time required for this research is reasonable. Let's say your boss asks to do any research and they want the result next month. Okay, you cannot do research in just 1 month. You have to be reasonable. Maybe you change it to become just an audit. Okay, so be reasonable when you wanted to choose which topic to be done. Okay, the importance of potential impact. With the result of this research fills an important knowledge gap in achieving national goals. This is what we call high impact study. Okay? When you wanted to do something, please become very ambitious at the beginning. Okay, you have to make sure the study that you've done, the study that you'll be conducting, will actually give some, some insight at the end of the day to fill the gaps. Okay, if you can find out study like this, it's worth to spend time to collect the data and come up with all the conclusions. Okay, the second one is the result from this research likely to shape future planning and implementation for you to do policy. Okay, I will give you example of this later in my future slides. Yeah, the third one are the result of the research likely to be beneficial. This is the thing that you need to ask yourself. Okay, brainstorm with your group and see whether you can answer this. Okay, magnitude or severity. Is the problem common in terms of burden to the healthcare system or community? Okay, you have to see, is it common? Why? Because later you can actually translate your study to people from other facilities can use your findings if the problem is actually common. Okay, is the problem severe to the healthcare? So if like got some severity, so it's worth to conduct the study. Everybody is actually waiting for the result. Okay, is the data urgently needed for decision making? So you have to ask this. Yeah. Okay, you have to also make sure that when you choose the topic, is when you come up with the recommendation, for example, the recommendation is actually valid. Okay. Some of the people they try to advocate, like to minimize the use of PPI, let's say, proton pump inhibitor. But when you wanted to educate to use H2 receptor blocker, you don't have it in the formulary, national formulary at the moment. So is it worth to conduct the study now? Because you have to ask yourself when you wanted to get some result, but that particular medication that say nobody have it. So how you how you actually implement or how you try to generalize your findings to make sure you get something out of it. So you have to be sensible and reasonable. Okay, after you identify the problem, then you start reviewing the literature. Okay, to get the study that is published in overseas, for example, or any local study, for you to see what output they got, from their study. Then you can predict what output you want for your study. Okay, is there any gaps that you need to fill, right? Then after that, you can follow the sequence of the research process. Start with the settling research question, objective, hypothesis, choose the study design, deciding on the samples, design, collecting the data. Okay, this is another important thing. Yeah, processing and analyzing data, and last but not least, writing the report. Okay. I got a few examples to highlight here. These few examples of research topic actually the pharmacist presented in the National R&D Conference last year. Okay, and judges comment something related to this topic, which I think is beneficial for me to share here. Yeah, the first one, this pharmacist wanted to do the association between pharmacist intervention and the practice of early intravenous to oral antibiotic switch in surgical wards. Okay, so they presented, but when we asked them, how does the pharmacist conducted the intervention? So they say they just go and suggest, okay, this patient can actually the oral the IV antibiotic can be converted to oral, because when we see the acceptance is low, so we ask, how does they do the intervention? Do they have guide that they give the prescriber? okay, for example, in this kind of infection, you can switch at day what, for example, and you give the equivalence of IV to oral switch, the bioavailability. Do they give or not? They don't give. Then how you do this study? How the doctors can appreciate it? When you suggest, okay, this one can change from IV to oral. My study shows that, it is good to change from IV to oral. You can actually minimize the infection, blah, 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 blah. But the doctor don't even know about the guide. You don't even provide, proper protocol for IV to PO switch. You didn't provide, IV to oral equivalent antibiotics. So at the end of the day, can your study be generalized to other hospitals? Can you even implement that to your hospital? Definitely cannot. So for me, it's not worth to do something like that. You have put a lot of effort. That's why I say spend time when you wanted to select what topic you want to do. Okay, if you think it's related to prescriber, you get them involved in your study so they can give the input. Then at the end of the day, you can actually translate your research finding into practice. This is what we want, yeah. Okay. I use this. Okay. I think I'm running out of time. I try. Okay. The second one, an evaluation of medical care and critical care nurse knowledge towards the use of inotrope and factors associated to their knowledge. So when we ask, is there any nurses involved in this study? No. Okay, I would mind if somebody do study about pharmacy and you didn't involve the pharmacist. So actually we have to be sensible. When we do study, we wanted to do study about other healthcare professionals, get them involved so they understand what is going on. They can also check on our protocol, ethic wise, it's good to get them involved. Yeah. Then after that, when you wanted to, translate your research finding, it's easier because the nursing side also involved in your study, right? Okay, next, adherence to evidence-based therapy for heart failure patient in Malaysian tertiary hospital. What does it mean? Adherence to evidence-based therapy. Okay, title also confusing. Okay, the study also confusing. So I feel pity to the person who conduct the study, yeah, because your effort is not worth in that sense. Yeah, this is all because of the lack knowledge in terms of research. Yeah. The last one, impact of antimicrobial stewardship on management of Pseudomonas aeruginosa infection in orthopedic patients. So this one, when we ask what is the AMS initiative that you implement to actually manage Pseudomonas aeruginosa, they don't even understand what is the initiative. For example, the rounds, or you use the pre-authorization form, you have protocol. They don't even understand, but they just use, bombastic word here, antimicrobial stewardship. Okay, so all this carry meaning. When we wanted to do something like this, you have to know what is the initiative actually. And when we say about Pseudomonas aeruginosa, it can come from many sides. Is it about, it coming from the respiratory? Is it come from the skin and soft tissue? So we have to have clear guide before we wanted to do study to see the impact. Yeah. Okay, this is basically the example. Yeah. Okay. Next, I will go to essential for a good pharmacy researcher. Okay, what component we need to have to become, a good pharmacy researcher? What element needed? Yeah. The first one, use scientific method. Okay. For you to get good result, you have to make sure that you go through the scientific method. Then when got the result is valid. No question on the result when you really conduct it proper, following the scientific methods. The second one is a continuous process. Okay, do some research that that research is valid, not to say forever, but still valid. Okay, you cannot do something that, let's say you have some service. Okay, the service is just short term. You wanted to see the impact of the service. At the end of the day, when you got the impact, you close the service. This is what I'm trying to say. So you take something continuous. When you get the result, you can translate the result. You can improve your service further. Okay. Next one, multi-purpose activity. Okay. So when we wanted to conduct study, we have to make sure that it is not just about data collection. Got a lot of activity. okay, in one research that you need to know and you need to carry out, okay, for you to get good result. Too many steps. So you have to be strong in all the steps so that you can conduct the study appropriately. Okay, next will be maintains objectivity and eliminates impartiality. What does it mean? Okay, you need to be, consistent. When you do objective, you have to make sure that your result actually answer your objective. It cannot be different objective. When you go to the result, you come up with a new idea. Discussion is a different idea. Conclusion, we also don't understand. Okay, so you have to make sure it's consistent. Okay, empirical nature. I actually like the observational study. Okay, one thing is easy to do. Another thing, you will understand the whole situation because you include all the patients. If you do RCT, of course, it's a good study, okay, but you need time to do it. Okay. Another thing, the inclusion and exclusion criteria is very tight. Sometimes we wanted to see the impact of certain drug, let's say, but we exclude, all the end-stage renal failure, we exclude liver failure patient, we exclude many patients. At the end of the day, when you wanted to generalize the data, it doesn't suit your patient. Your patient got a lot of problems, which, they come under category of exclusion criteria. So sometimes when you do something empirical in nature, you do observational study to see the practice of, in your ward, for example, you will see a better picture, clearer picture. Okay? I didn't say that I advocate on the observational study. No, definitely not. We have to go for higher quality of study. But our level, as the pharmacist or as a medical officer in the hospital, try to do something that we can do and we can see, we can actually appreciate what is going on in front of us. Okay, because in the ward, definitely you don't exclude all these patients. You don't exclude patients. So it's good to tie up the RCT study and also you do some observational study in your hospital. You try to merge the data, see the suitability to actually translate the data to get, to change your practice to become, better, so that the patient can, enjoy good outcome. Yeah. The last one is the generalization of the data. So to make sure that your study can be generalized, as I mentioned earlier, you have to make sure the population is like almost the same population as other hospital. So when they see the data, they can see, okay, basically it's the same patient as our patient. We can use this study finding to also improve our practice. This is what we want, yeah, sharing, yeah. Okay, so I have a few things to highlight here. Okay, what we need to do before conducting research, yeah. Choose a research question that interests you and would interest your target readership. Okay, don't do something that you don't like. Okay, consider having research collaborators if that would add value to your research project. So like pharmacy, we always involve with the practitioner, we also involve with the academician, okay, so that we can get more idea, yeah, to come up with the research, and it's easy. You can divide the job. Okay, determine the methodology for your study after a thorough literature review. So you can see the same topic, how other people doing it. Then you can have a better idea what method you should do. Okay, check if you need to acquire any permission, especially if you involve animal or human. This is ethics. Think of how and where you would store your data. So this is data management, yeah. Okay, so after conducting research, you have to ensure that there are no error in your analysis and result. Go over them again and again. This is very important. Later when you publish something wrong, the reviewer will ask you. So it doesn't look nice if like something wrong with your analysis, for example. And bad analysis will give you bad result as well. Yeah, so you have to be careful in that. Consider getting feedback about the result from your mentor. This is very important. You have to get people in the area to advise you, because sometimes something can be significant, yeah, statistically significant, but they are not clinical significant. So you need to get people in that area to advise you. Okay, this one, even though it's a statistically significant, we don't even care about this. So you focus on the better thing, not just, oh, this is significant, I want to highlight this. For what? So you have to get people in the area to actually give you advice on that. Start thinking of how you would present your result. Create an outline for your research paper to ease the writing process. set target for writing your research paper and start writing based on the outline you created. Yeah. Okay, now I'd like to share about the pharmacy research in HKL. Okay, we have about 70 studies in our database from 2015. Yeah. Okay, out of this, there's a few studies that I wanted to highlight to show that, how this research basically influence the policy and practice. The first one is development and validation of pharmaceutical assessment screening tool, FAST, to prioritize the provision of pharmaceutical care by the pharmacists at General Medical Ward in Hospital Kuala Lumpur. Why we conduct this study? It was 2019, if I'm not mistaken. We came up with the idea. That particular time, HKL main block doesn't divide to MH yet. So we have about 60 patients, maybe in medical ward, it can reach until 60. So that particular time, we feel like, we are not sure the patient that we give more time, is it like enough? Or some of the patient we miss in the ward that we need to give more time and check thoroughly, review thoroughly. So that's why we try to come up with this story map. So we want to make sure that we don't miss any important patient to be, reviewed. Of course, some of the patient we review in detail, some of the patient will screen the prescription. Screening prescription is a must, but this is something that you review in detail. So we came up with the story map. And now we have the, the scoring already. We will try to start using it and try to improve further, yeah, in future. The second one, the outcomes and acceptance of pressurized metered dose inhaler bronchodilators with venturi mask modified spacer in the outpatient emergency department during the COVID-19 pandemic. As you know, that particular time when COVID, came into picture, we cannot use the nebulizer. So start using the MDI with the venturi mask, and we managed to publish the study as well. Okay. Next, vancomycin, initial dose in adult dialysis inpatient. So we try to advocate on the weight-based dosing rather than just step. Okay, so study can, when you conducted a study scientifically, you get the result, good result, you can actually convince the doctor, for you to change the practice, to suggest the doctor to change the practice. So research can do that. You cannot just say, okay, I think this one is, it is good to use the weight-based dosing as what this paper published, let's say the Western country, but we don't have the local data to prove that. So it's good to conduct study locally, then you can further improve your practice. Yeah. Pharmacists' perspective of their roles in antimicrobial stewardship, a qualitative study among hospital pharmacists in Malaysia. This is another good study. We try to venture, our pharmacy, their perspective towards their role in antimicrobial stewardship. And because it is qualitative, we get a lot of information that we try to, highlight this to the ministry people for them to do training, because most of them said that when the hospital doesn't have infectious disease specialists, they have lack of knowledge. Okay, so and then they are not senior enough, to actually advise. So we get a lot of information from the study that we can, do something out of it to improve, our pharmacists in giving their, advice in terms of antimicrobial stewardship. Yeah. The last one, correlation between antibiotic consumption and the occurrence of multi-drug resistant organism. This is 3-year observational study. As you know, when you read about antibiotic collateral damage, certain antibiotic can actually welcome certain organisms. The most common one, like third generation cephalosporin, can welcome ESBL infection. So we conduct this, using our hospital data, okay, 3 years of hospital data, to correlate between antibiotic use and MDR organism. And we found when, we use extended spectrum cephalosporin or quinolone, we can actually welcome MDR organisms. So it's proven locally as well. So that's why we have to be careful. That's why we have antibiotic request form to actually limit the use of broad spectrum antibiotic, because we know it can welcome a lot of other nasty organisms or resistant organisms. Okay, engaging and training future generation of pharmacists. Yeah, we have JOY project. Okay, for pharmacy, we have JOY project whereby we train our junior, the provisional registered pharmacists in terms of research. So we try to make them as one group as us. Okay, work together, do the research together, so that we can also improve their research skills. Definitely, they're being assisted by the senior pharmacists and also by the R&D pharmacy committee. Okay, engaging other healthcare provider for research. The importance of collaborative research, as I mentioned to you earlier, with a diverse background, easy to solve complex and scientific problems. Okay, the merging of different fields of study allows for discovery that otherwise may be impossible for a single researcher, obviously. Okay, the recognition of the link between research collaboration and the importance of discovery has led many research funding and academic institutions to encourage the development of collaborative multidisciplinary teams. So pharmacists should evaluate what perspective they can bring to multidisciplinary research teams. This may include pharmacology, pharmacokinetic, drug delivery, pharmacodynamic, and also pharmacogenomics. This is something that we are encouraged. We encourage our pharmacists to get involved the doctors when the topic is actually related to the treatment of pharmacotherapy. So we can get more idea, we can actually improve our practice further. Okay, limitation and challenges as a clinical pharmacist researcher. The first one is inadequate knowledge and skill in conducting research, basically the methods and also statistics. But of course, all this we try to overcome through the research colloquium pharmacy. When they come up with the proposal, we give them more idea. Okay, in HRRC committee as well, when they present, the committee will give idea to actually improve their method and also statistics. And we try to overcome this through organizing related courses. Next, we have for those who feel that they have insufficient time to conduct study, the pharmacy give the research protected time. Our boss actually agree. So these particular pharmacists can apply protected time to collect the data or whatever research process they wanted to do. So their superior will keep all these documents, allow them, basically at least 3 hours per month. Okay. So this is like, mutual understanding between the boss and also, the pharmacist researcher. By doing this, I can see that our study, the pharmacy study moving. Before this, they said they don't have time, So when we allow all this, their study actually moving. So this is very good because we have to know that research is very important to improve your practice further. So we need to inculcate this culture, for our staff to conduct research. Manuscript writing, okay. Previously, we have a lack of publication. I think in 2019, about 3 publications. But now, last year, we have about 8 publications, okay. This year, up till March, we already have about 8 publications. So I can say that in terms of manuscript writing, we are better now, okay. With the help from all the courses being organized by CRC, by outsiders, yeah. All this actually helping. Okay, moving forward, I think this is my last slide, okay. Our future goals is to do more high impact research. Why? Because high impact research actually can improve our practice further, as all the example I've been given from the earlier of my presentation. Next will be more collaborative research. Okay, when the research related to prescriber, we need to engage them. Or if we wanted to do something with regard to administration of drug, maybe we can engage the nursing side. So this is what we are trying to do. Yeah, research competency. So this is another important things that we need to focus to make sure that the researcher, the pharmacist researcher, really follow the right way of doing research, so that the result can be valid and can be translated, and we can translate it into the practice. And last but not least, we try to focus on the more publications. We are trying to dig back from our database to see this study not being published and try to put effort on it to get more publication, because we know when we publish, it will be beneficial to others to see, and they also can use it to improve their practice. So in the long run, our patient actually, they can enjoy and get optimization of therapy through all these publications. I think that's all from me. Thank you for your attention.
Thank you so much, Dr. Rahila, for your very informative presentation on becoming a clinical pharmacist researcher. So with that, that was our final presentation for our 5th HKL Research Day, virtually live from CRC HKL. We will break shortly for around 2 to 5 minutes for the next highlight of the program, the Research Award presentation and prize giving ceremony. Meet you soon. A very warm welcome to all. Our event has come to an end. We would like to invite Yang Berusaha Dr. Fairuz Azli Muslim, our Deputy Director of Hospital Kuala Lumpur, for the closing ceremony speech. Please welcome.
Thank you, Madam Chairperson. Yang Berusaha Dr. Haja Salina Abdul Aziz, Head of Clinical Research Center Hospital Kuala Lumpur. Distinguished guests and speakers, ladies and gentlemen, Assalamualaikum warahmatullahi wabarakatuh, and a very good afternoon and salam keluarga Malaysia. First and foremost, let me allow me to thank the organizing committee for inviting me for the closing ceremony of the 5th HKL Research Day. Very special thank you to Dr. Haja Salina Abdul Aziz and the CRC team for the excellence in continuing technical support for research in HKL, with a vision of to steer HKL towards becoming a leading clinical research institute in Malaysia, and the mission to improve patients' healthcare outcome through ethical and quality research. Ladies and gentlemen, clinical research requires meticulous planning, resource management, dedication, time, sweat, and even tears. I believe this could not be achieved without the collaborative effort of all the dedicated researchers comprising of doctors, nurses, pharmacists, allied health personnel, who together with CRC, ICR, universities, and other collaborators all work together very hard to conduct sound research for betterment of our healthcare services. Ladies and gentlemen, it has been more than 2 years since first COVID case was reported, and since then the world had been battling COVID-19. During this pandemic, clinical research has been highlighted more than ever in understanding COVID-19 and its management. With the recurring HKL Research Day theme, Research Today for a better health, for best healthcare of tomorrow, it is aptly put forth as clinical research has played significant role in providing timely and scientifically backed evidence to manage the pandemic. HKL clinicians and researchers have done its share by participating in many COVID-related studies. To name a few, HKL was one of the study sites for WHO Solidarity Trial, ITEC clinical trials, investigating the efficacy of ivermectin in treating COVID-19, vigilance cohort study, and many more. Everyone has been contributing in its own discipline, and I must congratulate all of you for your efforts and dedication. I'm also proud to see the various research output on display today with involvement of most departments in HKL. Well done to all of you who have participated, and I sincerely hope that all attendees and delegates will carry on the research culture. Though the pandemic battle is not over yet, we are starting to see the light at the end of the tunnel with our transition into the endemic phase starting tomorrow, where international borders are open to Malaysia and most of the SOPs are relaxed. I am sure that this would strike some concern to us as healthcare providers. However, let data and findings from clinical research guide us to make better judgment and not by sentiments and feelings. Hence, I would like to advise all of you to keep following the SOP stated by Ministry of Health, wear your mask, hand hygiene, and practice physical distancing, as these three are actually proven to keep COVID at bay. I would like to take this opportunity also to wish all of you Ramadan Kareem. May Ramadan this year would strengthen the patient's willpower, empathy, iman, and taqwa, and also bring extra happiness and joy throughout the month. Last and not least, congratulations also to Dr. Salina and her team for the hard work in organizing much awaited event of the year. And with this, I close the 5th HKL Research Day. Take care and stay safe. Assalamualaikum.
Thank you, Yang Berusaha, Dr. Fairuz Muslim, for his closing speech for our 5th HKL Research Day for the year 2022. Without further ado, we now move to the Research Award presentation. We please invite Dr. Fairuz Muslim to have a place.
Aina, can proceed.
So live from our meeting room in CRC HKL, the Research Award presentation and prize giving ceremony. For the Research Award presentation, for the category for the best performance in investigator-initiated research, or IIR, goes to the Department of General Medicine. We welcome Dr. Saiful Safwan Matsani as the research coordinator to accept the award on behalf of the department. Thank you, Dr. Saiful. The next category for the best performance in industry-sponsored research, or ISR, goes to the Department of Radiotherapy and Oncology. We bid Dr. Muthukumaran Thiagarajan as the research coordinator to accept the reward on behalf of the department. Thank you, Dr. Muthu. The last category for the Research Award presentation, which is the publication of the year, the highest impact factor journal for 2021, goes to Dr. Chew Hui Bin of the Department of Genetics of Hospital Kuala Lumpur. Dr. Chew's paper is entitled Progressive Myoclonus Epilepsies, Residual Unsolved Cases Have Marked Genetic Heterogeneity, including dolicho-dependent protein glycosylation pathway genes, which was published in the American Journal of Human Genetics with an impact factor of 7.38. Congratulations, Dr. Chiu. We now move to the next category for the poster presentation competition, the case report series category. Winners will receive certificates and prize money amounting up to 50 ringgit for 2 consolation prizes, 100 ringgit for the third prize, 150 for the second prize, and 200 ringgit for the first prize. Without further ado, the first consolation prize goes to Dr. Farah Nadra binti Muhammad Nasir with a case report titled TB Immune Reconstitution Inflammatory Syndrome in an Immunocompetent Child, a case report. Thank you, Doctor. The second consolation prize goes to Dr. Cik Zubaida Cik Daud with her case report titled Case Series of Cholangiocarcinoma, a rare liver tumor in children. Thank you, Doctor. Now, for the third prize, this goes to Dr. Nurul Liana Roslan with a case report title of The Forgotten Tetanus and Role of Magnesium Infusion in Managing Generalized Tetanus. Next, the second prize goes to Dr. Zuhratun Naziha Khairul Kamal with a case report title of Isolated Third Cranial Nerve Palsy as Presenting Sign of Sinonasal Undifferentiated Carcinoma. And the first prize for the case report series categories for the poster presentation competition goes to Dr. Ng Kar Sheng with the title of Unfortunate Kisses from Charlie, a case series. However, Dr. Ng is unable to join us as he is currently in Kelantan. The next category for the poster presentation competition, research category. Winners will receive certificates and prize money amounting up to 100 ringgit for 2 consolation prizes, 150 for the third prize, 200 ringgit for the second prize, and 300 ringgit for the first prize. So for the first consolation prize will go to Dr. Nadir Adi Azhar with his research title of Factors Associated with Tuberculosis Treatment Outcomes in a Malaysian Tertiary Healthcare Center. The second consolation prize goes to Dr. Ernie Zurina Romley with the title Winding Road to Recovery, a Needs Assessment Study of People Who Use Drugs in Malaysia. She will be sending her representative, Dr. Muhammad Khairul Asraf. Thank you. The third prize for the research category goes to Mr. Koh Hock Peng with the title of his research, Impact of COVID-19 Pandemic on ST-elevated myocardial infarction, thrombolysis in a non-percutaneous coronary intervention tertiary hospital. This will be taken by Dr. Jivan Raj as his wakil. Next, for the second prize, would go to Dr. Sarah Abdul Mubarak with her research title, A Pilot Project to Determine Prognostic Factors for Successful Surgical Sperm Retrieval with Testicular Sperm Extraction, a multi-center study. So the first prize winner for our research category poster presentation competition goes to Dr. Ong Swee Geik with her title, Predictors and Radiological Characteristics of Rheumatoid Arthritis-Associated Interstitial Lung Disease in a Multi-Ethnic Malaysian Cohort. Congratulations, Dr. Ong. Finally, the most exciting prize-winning award, the oral presentation category. Winners will receive certificates and prize money amounting up to 100 ringgit for 2 consolation prizes, 200 ringgit for the third prize, 300 ringgit for the second prize, and 400 ringgit for the first prize. I will announce the 2 consolation prizes. The first consolation prize goes to Dr. Nurul Liana Roslan of the Emergency Department of HKL with a title 10 times lucky from the Cupid Arrow, a case report of a penetrating injury over the neck and thorax. Congratulations, Dr. Liana. The second consolation prize goes to Ms. Sardinia Binti Sarmidi of the Reproductive Medicine Unit of ONG Department of Hospital Tunku Azizah, with the title of Profertil as the antioxidant supplement for men with oligosteroteratozoospermia at Reproductive Medicine Unit, HKL. Are there any positive effects on their sperm quality? Third prize goes to Ms. Chang Chiok Yi, our pharmacy from the Pharmacy Department of HKL, with the title Development and Validation of a Pharmaceutical Assessment Screening Tool to prioritize the provision of pharmaceutical care by the pharmacists at general medical wards in HKL. It's getting more exciting now. So for the oral presentation, the winner, i.e. the first prize, goes to Mr. Lai Po Sun of the Forensic Medicine Department of HKL with his title of Morphometry of Foramen Magnum by using postmortem computed tomography for discriminant analysis of sex and ancestry among Malaysian population. Congratulations, Mr. Lai Po Sun. And the second prize for our oral presentation goes to Mr. Koh Hok Peng, which will be taken by Dr. Jivan Raj by Pharmacy Department, HKL, with his title, Mortality Outcomes and Predictors of Failed Fibrinolysis Using Streptokinase and Tenecteplase in ST Elevation MI, Reperfusion of an Asian Population. The next category, for the quiz winners during our lunchtime, we have first lucky 10 persons to win cash prizes of 20 ringgit. And we are going to display them on our computer screen. Thank you so much, Dr. Fairoz, for giving away the prizes for this ceremony. And with that, we would like to also invite Dr. Haja Salina Abdul Aziz to join Dr. Fairoz and present him with our token of appreciation from our Clinical Research Center of Hospital Kuala Lumpur team for his support and presence. Okay, thank you, Dr. Fairoz. Thank you, Dr. Salina. With this, as the saying goes, to every beginning, there's an ending. And now our HKL Research Day 2022 ceremony has come to an end. We wish you the best for the future and do keep on the research spirit. And don't forget our motto for this year's Research Day, Research Today for the best healthcare of tomorrow. Thank you so much for joining us today. Again, a reminder for all those online, please do scan the QR code or click on the provided link in the chat box and kindly fill in the attendance and feedback form. This is to ensure that you'll get your CPD points and certificates later. Also, please like our FB, CRC HKL and YouTube page and hit the subscribe button. And also hit the bell icon for any future notifications. Again, with that, see you next year. Thank you. Assalamualaikum warahmatullahi wabarakatuh.